Share screen option.
Now only they are.
Yes, ma'am. There is a green icon.
Now only they are giving. I think
Yes.
now it is visible. Okay, thank you.
Yes.
So I have told about the early pregnancy. So coming to in early pregnancy, a lot happens. There is tissue differentiation during this time. If the teratogen happens, it may be today what I am going to concentrate is glucose, the abnormal metabolite, and it can also come across other viral infections such as rubella and radiation. This pre-life exposure, the fetal development involves an interplay between the maternal physiology, metabolism, and hormones. The environment that the oocyte is exposed to during this periconceptional period can have a significant effect on the oocyte developmental competence, that is the ability of the oocyte to support fertilization and subsequent embryo development and the long-term health of the resulting offspring. So diagnosis in early pregnancy has enormous effect on all these events. So in early pregnancy, the blastocysts implants in the uterus between 7th and 9th day after conception, burrows into the endometrium where it receives its nourishments. It is rarely visible, but see how fast it multiplies, doubles every 24 hours. The placenta and supporting system infrastructure for pregnancy all develop at this time along with it. Hyperglycemia in this period can prevent implantation or go for abnormal implantation, or it can even cause recurrent abortions. They have estimated that only 55% of zygotes they reach this phase of growth. They are not able to reach this phase in phase of hyperglycemia. If you take the normal pattern of glycemia in non-diabetic, normal pregnant women, the fasting is always around 70 to 80, 1 hour around 120, and 2 hour 110. This has been done by Hernandez in about 250 normal pregnant females. So we need a glucose target. Euglycemia is very critical during fertilization. During in vitro development, the oocytes and zygotes cultured briefly in the absence of glucose. They are unable to complete embryo compactions and they fail to progress beyond the morula stage. There is no glucose. And also, if there is excess glucose, again, here also it is toxic to the embryos, indicating that normal development requires a zero glucose concentration, as I have told in the previous slide. In Banting lecture 1980, if we just go through, it was insulin-dependent diabetes. In the early pregnancy, it was always that, and in the later pregnancy, it was gestational diabetes. This is what we saw long back. But in 1994 onwards, there is evidence for high prevalence of type 2 among women of reproductive age due to the increasing obesity, our lifestyle, and type 2 diabetes occurring much early, and delayed childbearing in the present day, in the 3rd or 4th decade, and also delayed marriage. And the pregnancy is a celebration for them. They unnecessarily take feast and functions. So what has happened? The scenario has totally changed. We get a changing presentation in 2020. That is, we not only have type 1, but along with type 1, we do have more of type 2 marching through pregnancy. And the prevalent diabetes, that is, which is detected in the first trimester, and also the incident GDM, which was very common those days. So we have all these types. What is prevalent? It is mild hyperglycemia detected early in pregnancy, shows increasing prevalence of type 2 in our community. And here the hyperglycemia less than overt diabetes, it at increased risk of adverse pregnancy outcomes, and more insulin resistance, high BP, or hypertriglyceridemia, more of perinatal mortality, and which leads to macrosomia, leading to recurrent hypos once it is born. And main thing is there is a greater need for insulin in these cases than GDM, which is diagnosed much later in the trimester, that is at 24 to 28 weeks, which is arising de novo, and we call it an incident GDM. And if you take the incidence, previously the type 1, which I said, which was very common, was just 0.24%, but it has risen to 0.33. Yes, there is a definite increase of about 33%. What about type 2 diabetes? See, it has risen from 0.09% to 0.42%. That is, there is a rise of 367%. There's a phenomenal rise. This diabetes diagnosed early in pregnancy is present right from the time of conception, blastogenesis, which increases the risk of spontaneous abortion and congenital malformations mainly. The placental vasculopathy here is severely affected, which affects the flow of blood and other substrates to the fetus. So what happens? This prevalent diabetes, in the first trimester, it affects the organs and leads to congenital malformations, and then continues. It doesn't stop with that. It has effects on the brain in the later trimester, causing behavioral ramifications, and later trimesters, it causes anthropometric and metabolic effects. And along with this, it also has gestational hypertension, preeclampsia, which are all remarkably increased in this prevalent diabetes. What are the consequences? This early exposure during fetal organogenesis and placental development has different effects and may occur on the embryo fetus. That is, it can cause abortion, can cause congenital anomalies. The baby may be very big, large for gestational age, or it may go very small because of vasculopathy. Intrauterine growth restriction can occur, small for gestational age can occur, and sometimes even IUD and stillbirth also occurs. So diabetes diagnosed early, if the woman is found to have fasting hyperglycemia or any abnormal glucose intolerance in the first trimester itself, you might think about pre-existing diabetes and should be treated as women with glucose intolerance prior to pregnancy itself. The early gestational exposure to excess maternal fuels may impact the placental transport in a time-dependent manner through the fetal so though we discuss the fetal development in days or weeks, it's wiser to test the maternal glucose as early as possible. That is, on the next day woman misses a period. That will be ideal, because you see all these skeletal caudal regressions, spina bifida, anencephaly, myelocele, hydrocephalus, all these along with this cardiovascular dextrocardia, venous arteries defects, ventricular septal defects, renal agenesis, hypoplasia, or it may be charged from 3 weeks, 4th week, 5th week, and before 6 weeks, everything gets completed. So we have to diagnose first pregnancy as early as possible by doing serum beta-hydroxychorionic gonadotropin in the 3rd week of menstrual cycle itself, and in the 4th week, you can test in the urine itself the same hormone. Once you confirm the conception, and if you happen to see diabetes very early in pregnancy, what else you need to do? You just follow by ultrasound for nuchal translucency scan, detailed ultrasound for fetal anomaly, fetal echo, and serial growth scans. What happens to the progeny because of the hyperglycemia exposed to a diabetic environment much early in utero is associated with increased occurrence of impaired glucose tolerance and defective insulin secretory response in the adult offspring, independent of genetic predisposition to this diabetes. This fact is well established in Paima Indians, that they have seen that the offspring of Paima Indians who were in utero when their mother had diabetes had a greater risk of diabetes than the earliest siblings who were born before the mother developed diabetes. So this intrauterine milieu has more than inherited destiny. So early maternal metabolic imprinting affects the fetal growth much and more. Why to diagnose early? If you take the fetal pancreas, each islet cell functions as an endocrine organ, and this appears by 11th week of gestation and recognizes and responds to maternal glycemia by 12 to 14 weeks of gestation. This priming of beta cell mass in early gestation may account for the persistence of fetal hyperinsulinemia throughout pregnancy and the risk of accelerated fetal growth, even when the mother enjoys good metabolic control in later pregnancy at the cost of fetal handling of mother's blood sugar. So failing to diagnose early can mislead her as normal glucose tolerance, but still the baby will have all the consequences. You may wonder how the mother's blood sugar is normal, but in spite of the baby is going for macrosomia and other problems, this is because the baby is allowed to handle the mother's blood sugar. How to prevent the complications? You have to monitor the mental glycemia 2 hour every week, not in 15 days or 1 month. You have to monitor every week and maintain it between 110 and 120 because the renal threshold is 110. Once the mother's blood sugar crosses 110, it will have glycosuria, polyhydramnias, and also the other problems due to hyperglycemia. And this alone, maintaining the blood sugar between 120 and 110 and 120 alone can assure you of a healthy baby weighing 2.5 to 3.5, which is the Indian standard birth weight, and it will also prevent the other non-communicable diseases as well. The absolute nutritional deviations from optimum, whether it is over or under, whatever it may be, it should be normal. Whatever it is, it produces the same effects on the offspring with great variability in fetal growth based on the genetics and environmental factors. Of course, we cannot control our genes. We may be able to affect the control the fetal growth by altering the maternal environment, not allowing to go for undernutrition as well as overnutrition. And if you say take in the growth, week 3, the heart forms with the beginning of development of brain, spinal cord, and GIT. This early development is critical for subsequent embryonic and prenatal development. Teratogens introduced in this period may cause several problems such as the absence of one or more limbs, heart that is outside the chest cavity at birth. In week 4 and 5, this is the beginning of vertebra, the lower jaw, the larynx, and rudiments of ear and eye. The arm and leg buds are visible with hand and foot pads. Teratogens now may cause very serious problems. What I mean here is hyperglycemia involving the esophagus, vertebra, and eyes. The infant could be born with severe facial clefts or missing of hands or feet. And week 6, the nose, jaw, palate, lung, buds all occur. The fingers, toes form but may still be wet. The tail is receding and the heart is almost fully developed. And hypoglycemia at this point may lead to fetus with profound heart problems or cleft lip. Week 7, the eyes move forward on the face and the eyelids and tongue begin to form. Hyperglycemia now may cause heart and lung problems and cleft palate and ambiguous genitalia. You're not able to say clearly male or female. Week 8, the embryo now resembles a human being. The facial features continue to develop and the external ear and the external genitalia appear. The circulation through the umbilical cord is well developed. The long bones begin to form and the muscles are able to contract. Hyperglycemia may still can cause heart problems and stunting of fingers in this stage, fingers and toes. See, you have by 0 to 2 weeks the germinal form and the midbrain, hindbrain, and forebrain starts by 3rd week onwards. And by 8th week, the whole thing is complete and you have the full neural development where the fetus is formed. Weeks 9 and 12, the embryo is developed enough to call it as fetus. All organs and structures found in a full-term newborn are present now. The head comprises nearly half of the fetus size and the face is well formed. The tooth buds appear, the genitalia are now clearly visible as male or female. So all this happens in the early pregnancy. Monitoring maternal glycemia level every week may be very difficult, cumbersome, but still it is very important and prudent. What is the maternal contribution in this? The ovum is well supplied with mitochondria, but the sperm contains a few, and even those few do not persist in the offspring. At fertilization, it is only the nucleus of the sperm that enters the ovum, and all the others, cytoplasm, mitochondria, mitochondrial DNA, are all exclusively maternally inherited. The maternal inheritance is mainly attributed to the mutations in the genes present on mitochondrial DNA, and it is transmitted invariably by an affected mother to a progeny. The unique feature of this mitochondrial DNA is it's mainly inherited from its mother. And what is the rationale behind this early diagnosis? Metabolic perturbations are underway before we do the usual diagnosis at 24 to 28 weeks. Don't think it has just started. Already, it would have started much early. Megava has observed that glucose intolerance maximum, 2/3, 63.6% is present in the first and second trimester, and the rest, 1/3, just 36.4% is present in the second and third trimesters. Again, our godfather, Dr. Sashia, again documented that GDM can manifest in all trimesters of pregnancy. For example, he has done a study in 2006 and shown that there is 60% of GDM in the first trimester, 22% in the second, and 61% in the third. If you're not screening early, you're going to miss this 48%. Again, he has redone his survey in 2016, 10 years later. See what has happened. This first trimester incident, which was just 16%, has become 32, 22% in the second has become 42%, and only very little was left for the last trimester. That is 1/4 only was able to diagnose in the third trimester. So you have to be very vigilant in doing the screening as early as possible. We heard so many complicated problems. Don't worry, we have a simple solution given by DIPSI, the Diabetes in Pregnancy Study Group of India, the single test procedure, which is easy, economical, very simple, which can be repeated every trimester and found negative in one, without the hesitation of the cumbersome GTT, which is done in fasting. And this is our national guidelines approved by the Ministry of Health and Family Welfare Government of India. And this is also recognized by WHO, International Federation of Gynecology and Obstetrics, and International Diabetes Federation. Then who else you need to approve? It's very easy, a simple solution for all the problems what you heard. So early diagnosis avoids some diabetes-related complications such as hyperamnia, fetal anomalies, macrosomia, IUGR, preterm birth in women with hyperglycemia and pregnancy. And this higher glucose concentration in early pregnancy is significantly related mainly to obesity in the society, against which is prone for to get IGT and diabetes later in life. In diabetes diagnosed early in pregnancy, remember, all diabetes is not the same. What I have told, incident GDM is not equal to prevalent GDM. So here visits differ according to the blood sugar, glycemic goals differ. There is different fasting and postprandial for incident and prevalent, different A1C, different meal plan, different HP percent, different BP and pulse, and mainly the treatment regime differs for both, though it is diagnosed much early. This means that you can't treat them all as same. In incident GDM, that is which is occurring later in pregnancy, our aim is to prevent big baby macrosomia, prevent fetal death, and prevent other fetal complications. But see, in type 2 and type 2 marching through pregnancy, and also prevalent GRDM, that is detected for the first time during pregnancy, you try to prevent congenital defects, IUGR, small for day in the fetus, and complications of cardiovascular disease, blindness, retinopathy, neuropathy, renal failure, nephropathy. You need to see to all this, screen all this, see at what stage they are, and protect all this, along with whatever we have seen for incident GDM. To conclude, I can say the sum of life. Lives of great men like our godfather, Professor Sashia, remind us we can make our lives sublime and departing leave behind us footprints on the sands of time. Thank you. Thank you, chairpersons, organizers, and all the delegates.
Thank you, Doctor. And this was a wonderful and very lucid session, which has given us such a big insight onto that how aggressive learning about pregnancy. And once you get to know that a patient is pregnant, you should immediately screen for diabetes, especially so it hails if the patient hails from Indian subset of continent. And DIPSI has made it very clear that a single test procedure is much more easy, feasible, economical, and compliable by most of the patients rather than World Health Organization guidelines or rather than any other guidelines. Thanks a lot for such a lucid presentation. With this, we would like to move on to our second presentation, the next stage of life. We will come back to you, Dr. Saab, at the time when we have questions and answers, right? So don't run away from the crease. You are still at the runners part. So let me ask my other batsman to start with the innings, Dr. Ashutosh. Can we have his profile? Yes. So Dr. Ashutosh Trivedi is a young, dynamic diabetes and a thyroid specialist. He's certified in diabetes management from Chennai. He's certified in thyroid disorders from USA. He is having special interest in diabetes and thyroid disorders, and he's a consultant diabetes specialist and a physician, along with being an associate professor in the Department of Medicine at MGM Medical College, Jaipur, Rajasthan. With this, I would like to invite Dr. Ashutosh Trivedi, who's going to start at the other extreme of life, which is diabetes in elderly. We did hear from our previous speaker about diabetes in pregnancy and diabetes at birth. Now it's the other extreme, diabetes in elderly, with a lot of precautions to be followed. What are the do's and don'ts? What we have to manage when we are especially managing a geriatric diabetes patients. With this, we move on to Dr. Ashutosh Trivedi for his talk.
Well, thank you so much, Dr. Vishal Chopra, sir, for the kind introduction. I thank Dr. Bhavtarini ma'am for a very lucid talk. You are a legendary in the field of diabetes. And so now we will move on to the geriatric diabetes. And at the outset, I would like to thank the organizers, especially Dr. Banshi Shahu, sir, for giving me this opportunity, Dr. Vasant Kumar, sir, and Dr. Gupta, sir, for making this 2021 diabetes possible. So I'm sharing just my screen. So am I audible and visible?
Yes, Ashutosh.
Thank you, sir. So, dear friends and colleagues, we all have come across this lovely slide. We see a physician once said the best medicine for humans is love. And someone asked, what if it doesn't work? He smiled and said, increase the dose. Same applies for the geriatric population, which needs a soothing touch and care in every management of every disease. So there is an increase in proportion of the older persons 60 years or older in 2013 as per the International Diabetes Federation guidelines released in 2013. The older population was about 15% and it is estimated to be about 25% till 2050. So it's about 1/4 of the overall population and we have to take care of them very eminently. So diabetes in older adults, why it is important? Because 50% remain underdiagnosed. Why remain underdiagnosed? Because early signs are almost missed every time because of the metabolic abnormalities, insulin resistance. There is decrease in the first phase insulin release, and moreover, many of the times they have normal fasting plasma glucose but increased postprandial glucose, which we often miss. Early symptoms, if any, are mistaken for the signs of normal aging, and often they have a gradual onset of symptoms. So diabetes in older adults is 50% underdiagnosed because of these reasons, and we have to be very careful for this. Aging and diabetes, we all know that poor diabetes control exacerbates the aging process. It causes age-related diseases to develop earlier, and it makes the comorbid conditions worse and harder to manage when there is diabetes along with the aging. So, dear friends, we have the agenda, 3-point agenda today. First, we will go with the considerations in the elderly. Second, we will go with the goal setting and hypoglycemia episodes, why the hypoglycemia is important in the elderly population. And finally, we will look at the doses and guidelines for the glucose lowering agents and what are the precautions we need to take with them. So first of all, taking the considerations in the elderly. Now look at this slide, factors affecting diabetes management and elderly. It's a versatile phenomenon. You can say diversify factors affecting the diabetes management and elderly. There are age-related changes in the glucose metabolism, obesity or sarcopenia leading to insulin resistance. There is reduced physical activity, and many a times a unhealthy diet is followed. Coexisting illnesses, comorbidities, COPD, asthma, cardiac comorbidities all affect the diabetes in elderly. The longevity is affected. There may be genetic reasons and autoimmune phenomenon, and most importantly, polypharmacy that affects the diabetic management in elderly. Too many medicines for too many diseases is a very important factor. So this is a case of mistaken identity. Sometimes in the elderly population, diabetes is often mistaken because because of the signs of aging, needing glasses. There is more frequent urination. We can't do things like you did when you were 20 years old. Atherosclerosis, high blood pressure, change in gait, restlessness, confusion, slower cognition, all could be signs of diabetes, which we mistake as signs of aging. Signs of diabetes, there is blurred vision, polyuria and nocturia, fatigue. So this is the respective signs which we saw in diabetes. MI and CVA is 2 times more common. High blood pressure, neuropathy and foot deformities, restlessness, confusion with high and low blood glucose, they all correspond to the signs of aging, and they are mistaken as a case of aging process. So these are the physiological changes affecting medications in elderly with diabetes. There is slowing of peristalsis, which leads to longer exposure of medications to GI tract, that is metformin and acarbose. There is decreased hepatic metabolism and blood flow of the drugs, which slows the elimination of drugs metabolized in liver. There is decreased renal blood flow with aging, and that increases the duration of action and potential for toxicity of drugs like sulfonylurea, metformin, and insulin. Geriatric syndromes, we know as diabetic complications, we often come across these syndromes: cognitive impairment and dementia. Depression is very common, reduced muscle strength and frailty, falls and fall related morbidity, disability, and urinary incontinence are some of the major geriatric syndromes we come across as diabetes complications. So diabetes related complications are very common in the elderly. They are the major causes of morbidity, disability, and mortality in older adults with type 2 diabetes, including microvascular and macrovascular diseases, neuropathy, retinopathy, nephropathy, CVD, and stroke. And there is now overwhelming evidence that the level and duration of glycemia does influence the development of diabetes-related complications. Hypoglycemia is a major challenge in the treatment of diabetes in the elderly. It may be because of the patient risk factors, lifestyle risk factors, and due to drug-related factors. There are many factors which affect the episodes of hypoglycemia and are a major concern in the elderly. Severe hypoglycemia accounts for almost 20% of all hospitalizations for type 2 IM in the elderly. It has been published in 2010 in the Clinical Endocrine Diabetes, and it was noticed that 17% of the severe hypoglycemia episodes were accounting for the hospitalizations in the elderly population. Older patients do have a less perception of hypoglycemia, and why? Because of the attention which may be reduced due to depression, cognitive dysfunction, or other chronic conditions or autonomic dysfunction. And also many elderly patients have limited knowledge about the symptoms of hypoglycemia. Knowledge of diabetes is essential for symptom recognition, and we have to educate the patient regarding this. Each and every patient should be educated regarding the symptoms of hypoglycemia, and especially in the elderly population. So coming to the goal setting and hypoglycemia in the elderly population, challenges in goal setting we have, because we need to focus on the elderly population more than the usual population, adults and adolescents or children. We have to assess them clinically, functionally, and personal goals and current quality of life should be set to meet the realistic goals. Each and every geriatric patient should be individualized, should be offered in individualized treatment. And in pre-diabetes, we can look for diet and exercise if it is effective. So we must go for dietary and lifestyle management in pre-diabetes in the elderly, and not looking for extensive management. So we must avoid diet plans that lead to unnecessary weight loss, and an exercise program should be made which is beneficial for gait balance and functional capacity also. So coming to screening and diagnosis in the elderly, these are the recommendations for screening diagnosis in elderly: that clinical presentation of diabetes in old age is often asymptomatic and non-specific, as we have already read, and clinical diagnosis may be delayed. So in general, screening for a diagnosis of diabetes in older subjects should be in accordance with published international, national criteria and guidelines, and no age-modified criteria are currently recognized. The prevalence and incidence rates in elderly subjects may be underestimated when using fasting plasma glucose. So always check both fasting plasma and postprandial plasma glucose levels, and accordingly HbA1c also. The presence of isolated post-challenge hyperglycemia is common in older subjects and should alert us to screen for cardiovascular disease and institute risk intervention strategies to minimize the premature death in elderly population. In high-risk older subjects with normal fasting glucose and where an OGTT is not feasible, determination of HbA1c may be helpful in the diagnosis of diabetes. And these days, we often follow HbA1c as a diagnostic test, and a value of HbA1c more than 6.5 indicates the likely presence of diabetes. Sometimes some labs, we also take more than 6.2% of HbA1c as diabetes. So what are the special considerations we should look for in managing type 2 diabetes in the elderly? Clinicians who manage older people with diabetes, they require special skills if they wish to provide high quality care. During these days, geriatrics as a branch has been introduced by the National Medical Commission, and even MD, some of the medical colleges although also have the MD geriatric course. So we need to individualize the treatment, and our approach is influenced by a multitude of factors such as the higher frequency of medical comorbidities, frailty, and also socioeconomic issues are very important in the management of diabetes in elderly. So a comprehensive geriatric assessment is a potential important tool and a must need in ensuring that patients with diabetes receive a multi-professional assessment of their functional status and unmet needs. So these are our major aims in managing older adults with diabetes. Medical conditions like freedom from hyperglycemia symptoms. We must look for prevention of undesirable weight loss. Avoidance of hypoglycemia and other adverse drug reactions is very important. Estimation of cardiovascular risk as part of screening and for preventing the vascular complications, detection of cognitive impairment and functional disabilities, achievement of a normal life expectancy for patients wherever possible should be looked for. We must provide protection against heart failure. Treatment should be individualized according to renal dysfunction. Looking for the osteoporosis and drug-drug interactions is very important. At the part of the patient, we must look for maintenance of general well-being and offering good quality of life, acquisition of skills and knowledge to adapt to lifestyle changes, and we must encourage for diabetes self-care, which is very important even in older adults. What are the rationale for high quality diabetes care? Why should we do high quality diabetes care in elderly? Because screening and early diagnosis may prevent progression of undetected vascular complications. Overall, this care which we provide early in the elderly population, it may improve the metabolic control and will reduce the cardiovascular risk. Improved screening for maculopathy and cataracts will reduce visual impairment and blind registrations. And we must offer an integrated approach to management of PVD and food disorders that will further reduce the amputation rates. So these are some rationale which provide the high quality for providing high quality diabetes care and which will improve the life in the elderly. These are the complications of type 2 diabetes in the elderly: hypoglycemia, cardiovascular, microvascular retinopathy, nephropathy, dementia, depression, falls, fractures, and peripheral neuropathy. So coming to the management and treatment considerations in the elderly patients with type 2 diabetes, glucose control and management and targets should be individualized. The recommendations are that glycemic control should be individualized, taking into account functional status, comorbidities, history and risk of hypoglycemia, and also presence of complications. Begin oral glucose lowering therapy when lifestyle interventions alone are unable to maintain the target blood glucose levels which we are aiming for. We must every time maintain the support for lifestyle measures throughout the use of these medicines and discuss with the individual and principal caregiver goals and medicine dose, regimen and tablet burden before choosing glucose lowering agents. The attendants, the relatives of the patient must be explained about each and every drug, its dosage, how to take regimen, and even the cost issues should be discussed with the attendants and the patients if possible. Use the start low and go slow principle in initiating and increasing medication and monitor response to each initiation or dose. Increase for up to a 3-month trial period. Consider discontinuing ineffective and unnecessary therapies because of the polypharmacy. It majorly affects the treatment of diabetes, and the most useful drugs are often missed because of the multiple number of medications. So we must discontinue the ineffective and unnecessary drugs, and we must consider the cost and the risk to benefit ratio when choosing a medicine. Treatment priority of elderly is the prevention of hypoglycemia. Hypoglycemia is the most important consideration we must look for during the management of diabetes in the elderly, because the patients are often frail The elderly people with diabetes are also at higher risk for hypoglycemia, and its unawareness. It is associated with many adverse consequences, and the available data according to ADA suggests that the risk of tight glycemic control exceeds the benefit in many elderly patients. So look for hypoglycemia. ESD, ADA, they all recommend that glycemic targets for elderly with long-standing or more complicated disease should be less ambitious than for the younger, healthier individuals. If lower targets cannot be achieved with simple interventions, an HbA1c of less than 7.5 to 8% may be acceptable, transitioning upward as age increases and capacity for self-care according to the cognitive, psychological, and economic status. In the aged people, the choice of anti-hyperglycemic agent should focus on drug safety, especially protecting against hypoglycemia, heart failure, renal dysfunction, bone fractures, and drug-drug interactions. So our strategies should be specifically minimizing the risk of low blood glucose, and these strategies should be preferred over the other strategies. So these are the determinants of glycemic control in the elderly patients: hypoglycemia, short life expectancy, comorbidities, geriatric syndromes, falls and fracture, disabilities, functional impairment, polypharmacy. Many of these factors, or sometimes all of the factors, are present. So we must look for the flexible goals of HbA1c. And if the patient is having healthy functional status, there is no comorbidity, short duration of diabetes there, we must look for some stringent goals for the HbA1c in the range of 6.5 to 7.5%. So this is the evidence. These are the evidence-based guidelines for diabetes management in the elderly as per the ADA and consensus statement by the American Association of Clinical Endocrinologists released in 2017. So they have divided the elderly population in three classes. One is the healthy one, second is the complex or intermediate one, and third is the poor class, having the long-term care, needing the long-term care, or having end-stage chronic illnesses. So in the healthy subclass, we have few coexisting chronic illnesses and intact cognitive and functional status. We must aim for A1C 7.5 or less than 7.5%. And metformin is the first line medication if not contraindicated, and patient-specific factors should determine that which agents are appropriate for dual or triple therapy when needed. In the complex or intermediate subclass of patients, there are multiple coexisting chronic illnesses when there is mild to moderate cognitive impairment and two or more instrumental activities of daily life are impaired. So there the goal of HbA1c should be around less than 8% for patients with these type. We must evaluate the risks and benefit of using anti-diabetic medications, and patient-specific factors dictate the choice of medication therapy. For the third class of patient who needs long-term care or end-stage chronic illnesses are present, moderate to severe cognitive impairment is there, or there are two or more daily life activities dependencies, then we must look for A1C less than 8.5%, and discontinuation of medication may be the proper course of treatment for sometimes in this group of elderly people. It includes those with severe cardiovascular disease, end-stage chronic diseases, and life expectancy having less than 5 years. So it was an original article published in the Diabetology that is there evidence of potential overtreatment of glycemia in elderly people with type 2 diabetes. This is the guidance study which suggests that 44.7% of patients who had 65 years or elder had HbA1c of less than 7%, and out of them 27.1% had ischemic heart disease or congestive heart failure. So we must be less stringent in managing these elderly population. Studies have also shown an age-related increase in HbA1c in people without diabetes. UKPDS modeling study suggests marginal benefits of decreasing HbA1c to lower than 7.5%. So we must avoid overtreatment in elderly. As per Lee et al. In the Journal of Permethringia in the 2016, the age-neutral historic target of an HbA1c below 7% is fallacious, and based on results of studies that did not allow for enrollment of patients aged 65 years or older, and hence these glycemic goals should not translate to older patients. So coming to the drug section, finally, metformin, use metformin carefully in older patients, even with normal creatinine. Watch out for comorbidities that increase the risk of acute renal failure, and follow closely for weight loss and GI side effects. In the sulfonylurea class, we must use with caution in frail elderly who forget to eat or skip meals because of the high risk of hypoglycemia due to sulfonylurea class of drugs. Drug-induced hypoglycemia is common with renal and cardiac dysfunction and gastroparesis. Thiazolidinediones, pioglitazone, we all know it's well tolerated, does not cause hypoglycemia, but there is fluid retention, congestive heart failure, risk of osteoporosis, fractures, myocardial infarction, and urinary bladder cancer. For alpha glycosidase inhibitors, they are fairly safe and effective, but not used widely. Flatulence and diarrhea are common, especially considering the Indian population. Flatulence and diarrhea are well-recognized side effects in the elderly population. For DPP-4 inhibitors, reduction in HbA1c is similar to younger patients, which we see in the elderly. There is low risk of hypoglycemia and they are weight neutral. So they are many times they are preferred agents. Many systematic reviews have suggested the benefits and risk of DPP-4 inhibitors in elderly patients. Coming to GLP-1 agonists, there is no risk of hypoglycemia in monotherapy, but there is difficulty of injections in frail once weekly for those with memory problems, and monitor dietary intake and weight, especially with GLP agonists in the elderly population. For SGLT2 inhibitors, they are associated with lower rates of heart failure, hospitalization, definitely all-cause mortality and hypoglycemia, but there are high rates of diabetic ketoacidosis when compared with DPP-4 inhibitors in older adults with type 2 diabetes. The efficacy profile of glyphosate remain unchanged by age and may further enhance the CV protection offered by statin, but also look for the urinary infections in these while using these SGLT2 inhibitors, and avoid using them in patients having diabetic foot problems already. Coming to the most important treatment strategy, insulin in elderly. Most trials on insulin therapy in type 2 diabetes, they have excluded the geriatric population. So we don't have enough data, much of data on them in the geriatric population. But definitely addition of insulin to OAD is safe, though data is limited. There is no evidence base showing superiority of one insulin regime over another in the elderly population. So before giving insulin, we must evaluate if physically and cognitive the patient is capable or not. We must administer appropriate insulin dose and monitor blood glucose more frequently than in the adults population. So recognize and treat hypoglycemia timely and reassess frequently. Insulin elderly, rapid acting insulin for those with erratic eating pattern should be prescribed. We must be cautious while using the regular acting insulin because of the risk of hypoglycemia between meals. Avoid sliding scale insulin. It has now been obsolete almost. And use of premixed insulin in those with vision difficulty or dexterity issues, but it requires regular eating schedule, and we must watch out for the nocturnal hypoglycemia because of early evening meal. So these are the summary of the drugs and their benefits in the elderly. We have discussed the metformin, sulfonylurea, metformin, thiazolidinediones, DPP-4 inhibitors, GLP-1 and SGLT2, along with insulin therapy. So, dear friends, diabetes in the elderly, we must look for a checklist. We must assess for a level of functional dependency. First of all, if there is any frailty or disability present in the patient, we must individualize glycemic targets based on the HbA1c for frail elderly. But if otherwise healthy, we can use the same targets as younger population. As we have discussed, we have divided the elderly population among the three classes. Avoid hypoglycemia, that is the most important in cognitive impairment patients. Select anti-hyperglycemic therapy carefully, cautious with sulfonylurea and TZDs. Basal analogs instead of NPH or human 30/70 insulin should be preferred whenever they are useful. Premixed insulin instead of mixing insulin separately. Give regular diets instead of diabetic diets or nutritional formulas in nursing homes. And education has an important role in the management of diabetes in the elderly. If we look at the patient's role, he has to determine the personal self-care goals. He has to find solution of every problem and take responsibility for his own health. Coming to our role as a clinician, as a physician, we must be active listener. We must be a source of accurate information. We must provide the essential knowledge and skills training, and we must understand the client's perspective. And we should acknowledge his feelings, support him, and we must behave as a facilitator rather than a pure physician. So, dear friends, to summarize, advancing age is a risk factor for the development of diabetes. Elderly onset diabetes should be diagnosed as early as possible in accordance with national guidelines to avoid the progression of vascular complications and other comorbid conditions. Hypoglycemia is a danger in elderly diabetes patients due to a high level of hypoglycemia, unawareness, and medication combinations in this population. The presence of comorbidities presents unique challenges for us in the management of elderly type 2 patients. Cognitive dysfunction, depression, risk of falls, frailty, and other morbidities need to be addressed as a part of comprehensive care during the treatment of diabetes in the elderly patients. Dear friends, we all know that when we are a caregiver, we know that every day we will touch a life, or a life will touch ours. So these are the famous words. Chance words spoken in kindness often help amazingly, and that's what old people are here for. So we must be kind enough, we must be soothing enough for elderly population while treating them. Thank you all for staying with me. I thank Lord that for helping me to remember that I'm doing his work. Thank you so much.
Thank you, Ashutosh. It was a wonderful presentation, and you did highlight about this multi-dimensional approach to elderly population, because when we use the terminology frailty does carry along with it a multi-dimensional syndrome, which makes them more vulnerable for so many complications. Yes, what you said at the end was right, that we should show humility while treating these patients. And there is a lot of common sense which we have to use while treating elderly population rather than sticking on to only guidelines. How use of HbA1c has not been the benchmarker for glycemic control. You highlighted that point very well. And I'm sure the listeners must have gained some kind of a knowledge about a proper glycemic control without causing hypoglycemia or without causing any risk to develop any complications in elderly subset of population. Thanks a lot, Ashutosh,
Thank you so much,
for this wonderful presentation. So with this, we move on to the third extreme of the stage of life. Friends, we've already seen how preterm, intrauterine, and postpartum diabetes is managed. We have also heard about the other extreme, about management of diabetes in elderly subset of population. With this, I have my third batsman who's going to start, Dr. Kapoor. Can we have his biodata, please? Dr. Rohit Kapoor will be talking about the adolescent which is highly vulnerable, and not to forget, they are the key when you talk about a developing country like India. Adolescent, obese, type 2 diabetes. Of course, when we say adolescent, it's full of life. But when we attach terminologies like obesity and type 2 diabetes, it's a growing concern. Who better than Dr. Rohit Kapoor will be addressing this particular topic? Dr. Rohit Kapoor is an esteemed faculty, and he has 92 research papers, national as well as international, 10 publications in chapters of contribution in diabetes and cardiology. He's also had multiple fellowships from ACC in 2013, ACP in 2019, and he is also a fellow of Royal College of Physicians 2019. He also has got an esteemed award of honor for best cardiologist in Amritsar in 2016. With this, I allow Dr. Rohit Kapoor to start addressing onto this wonderful topic and a much more concerning topic of management of diabetes, obesity in adolescent population. It's a growing concern, and let's see, Dr. Kapoor has some wiseness to spread about it. With this, I give the stage to Dr. Kapoor.
Thank you, Dr. Vishal. And it's very nice already. The two speakers, they have brilliantly spoken on this in pregnancy and in elderly people. So my topic is on adolescents. Let me share my screen. Yes. My screen is visible, Vishal?
Yes, your screen is visible.
Thank you very much. So, good afternoon or rather good evening to everyone who is joining this session, and thank you RSSDF for inviting me to talk about this topic. And it's very interesting to talk on adolescent obese type 2 diabetes is a growing concern. So obesity increases risk for diabetes mostly like BMI more than 35 versus less than 22. And you can imagine, you can see how the diabetes is 77,000 females and 46,000 males. They are adjusted for age, smoking risk, 10-year risk. And you just imagine, just see the bar diagram on this diabetes. And you imagine it's the odds ratio which shows it's too high with the BMI. So that's very important how the BMI is becoming too important. We are using anthropometrically BMI in our clinics a lot. Rather, every patient undergoes anthropometry to see. Now, after BMI, we are having various other anthropometric matters. Uh, this is worldwide prevalence of type 2 diabetes in young people. That is a very important study. You can imagine. I mean, the pink is 2013 data, and you can imagine how it is worldwide. This people less than 40 years, and this is in the young people. I'm not talking about here the adolescent, but less than 40 years. They are too high. That's 2013 data is, and it has risen so much from 2003 to 2013. You see the bar diagram. So what are the risk factors for childhood type 2 diabetes? So one is type 2 diabetes in the first or second degree relative, high risk ethnic or the racial group, obesity, then impaired glucose tolerance, polycystic ovary syndrome, exposure to diabetes in utero, very important. I mean, acanthosis nigricans, some markers of insulin resistance, hypertension, dyslipidemia, NAFLD, and use of atypical antipsychotic medications. That's one of the really very important. I will be coming on that. So type 2 diabetes and obesity. There's a one study, very important study. Many times we talked about this nurses health study, which shows BMI is directly and continuously related to the risk of type 2 diabetes as compared to the woman with BMI less than 22. Risk of rise in risk of type 2 diabetes 5 times higher in those with the BMI around 25, 28 times BMI around 32, and 58 times higher in those with the BMI more than 35. So I'm talking about here, I mean, this NHS is the most important study. I mean, because in adolescents, obese adolescents, obesity becomes a very major risk factor in adolescents, in the young people, to become the risk of diabetes that goes very high. And this is again the relationship between BMI and the risk of type 2 diabetes. And you imagine how the graph goes up. I mean, as you see in the females, I mean, if the BMI is more than 33, it is the age-adjusted relative risk is 93.2. I mean, it's too big as comparison to the males. I mean, so that's why we are very much convinced that controlling BMI is so important. I mean, to prevent or reduce the risk of development of the diabetes. So in the young, the once thought to be a metabolic disorder exclusively of the adulthood has become increasingly more frequent in now obese adolescents, occurs in all races with high prevalence in the non-Caucasian groups like us, and prevalence is increasing worldwide. And established relationship established specifically with the central obesity. And numerous studies overweight and obese, they are at increased risk of developing type 2 diabetes. So we know now, let's come to the term like diabesity. Many times in many webinars, we have talked about this. There's a concurrence of the type 2 diabetes and the obesity. And in 1973, this term was coined and is linked by various pathophysiological mechanisms around insulin resistance and hyperinsulinemia. It's a closely associated diabetes risk increases by 4.5% for every kg rise in the weight. So diabetes has been many times very interestingly discussed in various conferences. And and you see there's a vicious circle like insulin resistance, high blood sugar, high insulin, hyperinsulinemia, obesity, and this way it goes. So who to screen? I mean, then the question arises, who are the children or the adolescents you want to screen? any of the following conditions. The guideline, they say it's a 2018 diabetes Canada CPG, and this is type 2 diabetes in children and adolescents. So that was a very interesting topic to read. The non-pubertal and more than 3 risk factors beginning at age 8, or pubertal and more than 2 risk factors. Risk factors include obesity, like BMI more than 95th percentile for age and gender, first degree relative with type 2 diabetes and or exposure to hyperglycemia in utero, or sign or symptoms of insulin resistance. Very important. I mean, we have to see catharsis, skin tax, hypertension, dyslipidemia, NAFLD, and these all are very important. And we know if there are more than 2 risk factors, the chances of development is really good. And who to screen, I mean, and another conditions like PCOD and impaired fasting or IGT, and use of atypical antipsychotic medications. That's a very important reason. I mean, some child or some young child is on his antipsychotic medications. You have to screen this child for development of this diabetes. And how often to screen? If everything comes normal, then the question arises, when you want to repeat the screening, and the guideline, they say every 2 years you have to screen again. So what are the classification of type 2 diabetes? I mean, a type of diabetes is the presence of clinical risk factor, mode of presentation, the early course of disease, usually indicate whether the child has type 1 or type 2 diabetes. But children with type 2, they can present with a decay now, or the chances of development of the decay in type 2 diabetes with children is very less than 10%. The testing for absence of islet autoantibodies may be useful because they are most of the time they are absent. I mean, and definitely some C-peptide levels, they can be very helpful if immediately you are not doing it with the time you are doing it. Fasting insulin levels, they are not helpful at diagnosis, as levels may be low due to glucose toxicity. And DNA diagnostic testing for genetic defects in the beta cell function should be considered in children who have a strong family history suggestive of autosomal dominant inheritance and who are lacking features of insulin resistance. So, I mean, this is very important to understand that type 2 diabetes in obese adolescents, and you have to be sure, I mean, because if you are going ahead that some child is coming to you with the diabetes and you are going for uh, islet cell antibodies and GAD or whatsoever, most of the time they are negative. So diabetes is an epidemic, again coming to that. It's the biggest epidemic in the human history and seriously underrated as a global public health issue. World can no longer ignore the rise of type 2 diabetes. This is a heterogeneous disorder. We know it's very simple slide. I mean, we know at this level when the gust gathering is there, we know it's not the functional beta cell or the failing beta cells, metabolic syndrome, resistance, and hyperglycemia, and other things. So beta cell function is a main factor responsible for development of type 2 diabetes, is a continued decline in the beta cell function. And several studies, diabetes and the pre-diabetes, they do not develop until the beta cells, they fail to compensate appropriately to the insulin resistant state. So ability of beta cells to secrete sufficient insulin depends on multiple factors we know, including beta cell mass and secretory capacity, which are influenced by genetic and environmental factors, insulin resistance, and then lipotoxicity. So these all factors are very important. And what is happening in the obese adolescents, beta cell defects in pre-diabetic conditions in obese adolescents. This is the two phases. First phase insulin secretion and the second phase insulin secretion. You see, first is a normal glucose tolerance, then impaired fasting glucose, then IGT, the IFG by IGT. And you can imagine, I mean, the second phase and first phase, they're really affected in the both IFG curve, IGT, and in this curve, markedly affected in the first phase insulin secretion, and the same is happening with this. So, I mean, this really indicates, I mean, this is glucose sensitivity. The first phase and second phase, they are really affected, I mean, beta cell defect. So what is disposition index, DI? It's a relationship between insulin sensitivity and insulin secretion. As the sensitivity decreases, insulin increases, the secretion increases to maintain normal glucose tolerance. And we are many times discussing about disposition index. It's a product of insulin sensitivity and beta cell function. Therefore, can be used considered an index of beta cell function weighted by insulin sensitivity. So studies in adult population, DI is not only a measure for identifying subjects with poor beta cell function, but is a strong predictor for the development of type 2 diabetes. Obese children who progress to IGT, they manifest low DI values than those who do not experience a worsening of the glucose tolerance. So insulin resistance now influences the progressive beta cell failure of type 2 diabetes by placing an increased demand on the beta cells to hypersecretory insulin. The precise mechanism by which insulin resistance leads to beta cell failure, many times we have talked in various conferences and discussions, they are unknown. Possible hypothesis, the cause of insulin resistance is directly responsible for the beta cell failure, like example is lipotoxicity. So then the question is obesity and the lipid partitioning. I mean, obesity is the most important cause for development of this insulin resistance, we know, and the critical determinant of insulin sensitivity is not the degree of obesity per se, but the distribution of the fat partitioning. What is fat? Adolescents at risk for developing alterations in glucose metabolism, they are not necessarily the most severely obese, but are characterized by an unfavorable lipid distribution profile. That's very important. Sometimes you have a lot of adolescents diabetes coming in the clinic with the type 2 DM, but sometimes they may not be obese, and mostly sometimes, yeah. So then the question arises, it's a hypothesis, I mean, unfavorable lipid distribution profile. Visceral fat is the most important, I mean, ample evidence obese children and adolescents that visceral fat accumulation is associated with impaired insulin action, impaired insulin sensitivity secretion independent of total body adiposity, a significant increase in the 2R glucose. And we know the visceral fat is too big problem in our Asian population. And that's really, we know in many times we talked about it. And hepatic steatosis, how it is contributing to this adolescent in adolescents, this development of the diabetes. We know ectopic fat deposition in the liver is emerging as the most important marker of IR and glucose dysregulation in adults as well in the obese pediatric population. Studies in obese children and the adolescents, that has shown insulin resistance is directly related to the percent liver fat. Rising ALT levels associated with deterioration in the insulin sensitivity and glucose intolerance, and abnormal ALT levels were found in children with type 2 diabetes. So various factors I'm talking in my lecture, how these factors, they are so important to see in children. And these all factors are very important who poses the risk of development of type 2 diabetes in children. And you see this graph is there is a liver fat content and low, moderate, and the high liver fat content and impairment of insulin sensitivity and beta cell function in obese children and this adolescent. And you can imagine this is a whole body insulin sensitivity index. And this is when the liver fat content is high, it is very low. That's the insulinogenic index. It is very high when there is a high liver fat content. And this is disposition index, which is very important DI and small in children or adolescents to measure DI. And you imagine when the liver fat content is very high, you see DI is low. This poses a very big risk of development of the diabetes. So independent of obesity, the severity of fatty liver associated with decrease in insulin sensitivity, impairment of beta cell function, presence of pre-diabetes conditions like IGT, IFG by IGT ratio. Hepatic steatosis independently predicted pre-diabetes in obese adolescents. So any obese adolescents coming to you with this hepatic steatosis, NASH or NAFLD, you should be careful. It's one of the pre-diabetes condition in this obese adolescent. And these findings suggest that intrahepatic fat accumulation is a strong risk factor for type 2 diabetes in young. So obesity insulin resistance link, a lot of studies now they are there. The obesity and IR link is there. There are three distinct mechanisms have been proposed to link obesity to insulin resistance and predisposed to type 2 diabetes. And you know, one is increased production of adipokines, cytokines, increased TNF, IL, resistin, and retinol binding proteins that contribute to insulin resistance as well as decreased levels of adiponectin. Second reason is ectopic fat deposition, particularly in the liver, as I talked about, and perhaps also in the skeletal muscle and the dysmetabolic sequelae. And third is mitochondrial dysfunction, by the evidence by decreased mitochondrial mass or dysfunction. So mitochondrial dysfunction could be one of the many important underlying facts linking obesity to diabetes, both by decreasing insulin sensitivity and compromising beta cell function. Obesity and type 2 diabetes, how does all this link up at the molecular level? So genetic factors linking obesity and the diabetes, there's the genome-wise association scans, GWAS is there. We identified 40 genes associated with the type 2 diabetes and similar number, albeit largely different with obesity. And most type 2 diabetes genes appear to be related to the beta cell function, while few relate to IR independent of the obesity. This third point is very important because most of the genes, they are mostly linked to the beta cell dysfunction. So this is a unified field theory possibility. Both obesity and type 2 diabetes share a common underlying defect. Defect
Dr. Kapoor, there seems to be some problem. We are not able to see your slides.
am I audible?
Yes, you are definitely audible and I can see you.
All right, thank you.
But I'm not able to see your slides.
All right, there is some problem with the, now the slide is not visible. I will share again, sorry.
Just now it went out, the last slides.
Now you are able to see my slide?
Yes, sir.
Thank you.
Yes.
So these responses, they are not mutually exclusive. I mean, unified field theory, I'm continuing, and induction of one may trigger another, leading to cascade of damage. Obesity-associated cellular injury can in turn recruit and activate macrophages and other immune cells that exacerbate tissue inflammation. So collectively, these responses, they contribute to pathogenesis of IR in the liver, skeletal muscle, adipose tissue, and some changes may occur in beta cells as well as via mechanism discussed above. So therefore, obesity-induced metabolic impairment can favor insulin resistance on the one hand and progressive beta cell dysfunction on the other. And this theory has been very important when we talked about this childhood obesity and adolescent diabetes, obese diabetics development. So reduced insulin secretion can in turn worsen the nutrient excess problem by raising circulating concentration of glucose, free fatty acids, and other nutrients. So a vicious circle arises whereby obesity-induced nutrient excess triggers inflammatory responses that causes IR, placing a greater demand on the beta cell. Beta cell function declines, further worsened by nutrient excess. So since not all obese individuals, they develop hyperglycemia, that's many times the question arises. All obese individuals, they are hyperglycemic, they are diabetic. I say no. However, abnormality of the beta cell must coexist with the nutrient excess to promote type 2 diabetes. So what is central contribution? These are brain neurocircuits governing energy homeostasis. They also affect insulin sensitivity in the liver and perhaps other peripheral tissues. So inflammation similar to that induced by obesity in peripheral insulin sensitive tissue also occurs in these areas of the brain. So obesity-induced IR resistance may arise not only as a direct consequence of excess adipose mass, but via neuronal mechanism as well. That's very interesting to understand how neuronal mechanisms, they are really one of the causation of this obesity-induced IR. What are the benefits of weight loss now coming here? Delay progression from pre-diabetes to type 2 diabetes. There are various studies like diabetes prevention programs and various finished diabetes prevention programs. We know, 58% reduction of development of diabetes in diabetes prevention program only by the lifestyle modification and the exercise. Positive impact on treatment of type 2 diabetes, most likely to occur early in the disease development, and improves mobility, physical, sexual function, and health-related quality. This is just a link up. I'm not going in detail about this slide. It's obesity and type 2 diabetes link up. Adolescent is one of the very important diabetes care 2020. Early onset type 2 diabetes. It's a type 2 diabetes nationwide population based evaluated. A lot of involved adolescents, 59% men, mean age 17.4 years. And what does it show? This inverse graded relationship was observed between baseline BMI and mean age of type 2 diabetes diagnosis. So that's why 27.8 and 25 years among men and women with severe obesity, respectively, and 29, 28 among the low normal BMI. So fractions of adult onset type 2 diabetes that were attributed to high BMI at adolescents were 56.9% and with 61% in women and 56.9% in male. So severe obesity significantly increases the risk for incidence of type 2 diabetes in early adulthood in both sexes. That was a very good conclusion. From this study, we all globally take out. There's another study like BMI and incident type 1 and type 2 diabetes in children and the young adults. It's a retrospective cohort study. A total of 375 contribute to UK clinical practice research data link, and total of, you imagine the people, more than 3 lakh participants, 2 to 15 years as the BMI measured. And what is the incidence of type 2 diabetes increased in both overweight and obese individuals from 1994 to 2013. Obese individuals who constituted 47% of type 2 diabetes cases, they are markedly greater in risk of incidence type 2 diabetes. So increasing obesity conclusion has contributed to the increasing incidence of type 2 diabetes, but not type 1 among UK children and adults with a fourfold greater risk of developing type 2 diabetes in obese individuals. So how the obesity is important and how to screen these adolescents for this childhood obesity. That's so important to understand. In a lot of papers, there are more. I just quoted these two studies here. So weight loss can be more difficult to achieve in patients with diabetes. There are various reasons. In the diabetic person, weight losing is not that so easy. So these are the health goals for people with the type 2 diabetes. You see improved blood glucose, weight loss 5 to 10%, improved quality of life, and definitely it minimize and optimize use of glycemic medication and improve a lot of complications. So complications short term. Now here, what is happening in this youth? 10% diabetes decay, 10% of Canadian youth present with decay at diagnosis. And HHS. Anything to talk to me? Somebody's not muted. So high mortality rates, they have been reported in youth presenting with combined decay and HHS at the onset of type 2 diabetes. Evidence suggests early onset type 2 diabetes in adolescents is associated with severe and early onset microvascular complication, including retina, neuron, and nephropathy. We know this thing. Even the pre-diabetic population. One of the biggest study, they show 19% population pre-diabetes they suffer retinopathy. So we have to be very, very quick in diagnosing and screening this childhood obesity, who are at the risk of development of this diabetes. So it's a prudent to consider screening for these complications at diagnosis and yearly thereafter. We now come to its management. It's nothing new. Newer classes, they do not cause weight gain and they're weight neutral, like GLP receptor analogs, SGLT2, DPP4, and we have to talk about the lifestyle modifications, strategies with the patients, physical activity, medication, nutrition therapy. All they are important in the almost in this adolescent obese type 2 diabetes. Definitely sulfonylureas we do avoid because of the risk of the weight gain. So these are what are the weight loss? If these are the study. First co-primary A is like if you're doing an intervention group, when you are losing weight, you feel there's a percentage achieving a 15 kg weight loss at the 12 months, and you see 24.2% people they are benefited, and there's a B group. B group is their second co-primary outcome, remission of diabetes, like A1C is less than 48 millimoles for 2 months. And you imagine how the weight loss is causing a big benefit, 45.6%. And this is when you lose weight, how much you are benefited. If you are losing more than 15 kg, It is 6% population. It is 6% population is really benefiting. So weight losing is very important. So management is nothing new. I mean, you have to be talk about this physical activity to achieve the same activity level recommended by Children's Journal. 60 minutes per day of the moderate to vigorous physical limits sedentary screen time to less than 2 hours per day. So this is psychological issues like need to be addressed and intervention offered as required. Since 19%, they have neuropsychiatric disorder at presentation of type 2 diabetes. And that's very, very important, I meant to understand when you are talking about the obese adolescent type 2 diabetes or the childhood obesity. So this is very important. So recommendations, diet, physical activity, behavioral therapy, designed to achieve more than 5% weight loss should be prescribed for overweight and obese patients with type 2 diabetes. And intervention should be of high intensity, focus on diet, physical activity, behavioral strategies to achieve so much of this 500 to 750 kilocalories per day energy deficit. So short-term interventions that imply very low calorie diets and total meal replacement may be prescribed for select patients by trained practitioners. And we know many times we have talked about the direct study in which 800 kilocalories has been given, and you have found the diabetes remission over a span of this 9 to 11 months. So that's a really very important study, but I don't want to talk about and discuss that study here. But definitely, it's very important to understand that weight loss is very important. I think that was my last slide, and thank you very much.
Thank you, Dr. Kapoor, for such a lucid, easy, and much informative session. What we have in understanding about management is one aspect of managing adolescent in diabetes. But the most important part was that you took out that effort of making the audience understand the importance of going after adolescent diabetes and obesity and how they are closely interlinked genetically and otherwise at a molecular level. So this is one of the most important sessions. So today, friends, we had a discussion right from before birth, after birth, during the adolescent, the flying colors of life, and then during elderly. So we have all three speakers with us. And if there are any questions, you can unmute or you can put it in the chat box. Or let me start with one question. Okay. My question would be to Dr. Bhavtarini. Doctor, one thing your presentation did talk about right from the screening to the management. But when we are talking about especially so handling pregnancy in diabetes and Indian subset of population, so would you try and screen all the patients, those who are pregnant, those who come to your clinic or should there be a recommendation of screening all the patients, or should we be screening only high risk patients?
As far as India is concerned, we are 11 times more prone to diabetes than the other Caucasians. I will put all patients. It is universal screening. Right. And this is also recommended by the national guidelines also. As far as India is concerned, it is not depending on the risk. Everyone has to be screened once they become pregnant.
So during the first screening, if the patient is not diagnosed to be diabetic in the first trimester, if the patient comes to you, would you repeat the screening method again at the 24 weeks?
Yes, I have mentioned in my talk also. Since this test is very easy, you can repeat any number of times. In every trimester, if it happens to be negative, you have to repeat in the second. If it is negative, again repeat in the third. It has to be repeated.
Fantastic. So at least we all have understood the importance of screening. It has to be screened. And as what she had highlighted very clearly, that if you screen early, if you pick up these cases early, you can manage them well. And you can also reduce the risk of certain diabetes associated complications of both maternal as well as fetal complications. Thanks a lot.
So can I interrupt here? Can I?
Yeah, doctor.
Yeah. Again, Dr. Bhavtarini, here is another comment about it. I mean, screening population for diabetes in pregnancy is very important. And suppose the lady is coming in the first not first trimester. I'm talking about the ladies coming the first time detected pregnancy to you. I mean, so it's just a 4 to 6 weeks of pregnancy, and there is a family history of diabetes in that lady, but that lady is very young, around 30. And would you like to screen at that time? And she's obese, and she's a 6 weeks pregnancy. She's a family history of diabetes. What are the exactly guidelines they say, ICOG or whatever the guidelines? Are you going to screen for diabetes at that time, proper OGTT, or what do you recommend? Just to make me clear about
I go according to the Indian national guidelines, which says DIPSI screening test, the single test procedure, which is very easy for us to do any number of times. As I have mentioned early, I'll do soon after we see the lady missing her period. I'll do it as early as possible. I don't want to miss any congenital anomalies to take, and then wait for the risk and wait for BOH to happen, then go for screening. All that I don't do. I just straight away, once she misses the period, I do the single step procedure and find out if she is. And a very important thing I want to say is, once you miss in the early days, what happens by 12 to 14 weeks, the fetus starts handling the maternal blood sugar, mother's blood sugar. So after that, if you delay, you may look, the mother's blood sugar is very much normal, but the baby having big baby, the amniotic fluid is more, all this happens. You may wonder how it can happen in spite of the mother having normal blood sugar. This is because of the fetal handling. The pancreas is developed by 9th week and it starts handling the mother's blood sugar by 14 weeks onwards. So if you miss in the first trimester, the later trimesters, the mother's blood sugar may look normal. She'll have normal glucose tolerance, but the baby will have the consequences because of the baby handling, fetus handling the mother's blood sugar.
Very nicely put.
I would like to share my personal experience, ma'am and sir, respected eminent speakers, that my wife had GDM during her first pregnancy, and because she was having the family history, strong family history of diabetes, her grandfather was diabetic, her mother is diabetic. So I started following the blood sugar level screenings right from the first day when the pregnancy was diagnosed. And at around end of first trimester, I found that her blood sugar levels were increasing. So dietary and lifestyle pattern was started as soon as, and during the last about at the end of 8th month of pregnancy, she needed insulin. First, gradually, I started basal insulin, then the pre-meal insulin, one plus, and finally, during the last 15 to 20 days, she was on basal bolus insulin. She had hypothyroidism, she had PIH, and finally, she had cord around the neck of the baby. But by the God's grace, it was all good, all went well. So this is the importance that ma'am highlighted, that we must start screening right from the first day of the pregnancy these days, especially in the country like India. We must be very closely following these patients. So thank you so much.
Dr. Ashutosh, but we can't, sorry. Dr. Ashutosh, but we can't label it a GDM if you are having some detection of diabetes. It's a diabetes with pregnancy. I can't say some lady is pregnant and the second month we are detecting that she's diabetic. I say she's a case of diabetes with pregnancy, but not GDM. I mean, GDM definition is entirely different. I mean, so that's why you are absolutely correct.
I have clearly shown the diagrams. Previously, 80, we thought it is only type 1 passing, but now we have 4 types. Type 1 and type 2 also passing through pregnancy, because the age of occurrence of diabetes has come down. The age of marriage has gone up. The age of childbearing, again, it has gone up to 3rd, 4th, 5th grade. All these coincides. And the only time when they give importance to the female is they celebrate pregnancy with more functions and peace and more sweets. So they induce GDM. All this happens. So we have to be very vigilant. And it is not like how we saw in 80s. We had only type 1 in early pregnancy, but we now have type 1 and type 2. And also the incident GDM, as you said, diabetes detected during pregnancy because of the diabetogenic stress, that is hormonal stress, which triggers diabetes.
One thing is more, Dr. Bhavtarni, very sorry. if some ladies, you are diagnosing diabetes in the second month of pregnancy and her A1C is around 7.4, and what do you label then? A1C is
She's
7.4.
diabetic.
He
So we
says
would label
diabetes
it.
with pregnancy. Yeah, the lady is already A1C
She's
7.4,
prevalent.
7.6.
So we
This
would-
is
Prevalent diabetes.
Yeah.
So
Prevalent
we would
diabetes.
label it overt diabetes.
Yeah,
We would
yeah,
label
yeah.
it
Yeah.
overt diabetes.
Yeah, that's very important. Thank you.
Right. So, the one thing which I've come across, that thanks to Dipsy, that they have come out with this single test, which has been
Single test.
approved. And that can be done. You don't need a lady to be fasting. That's the most important part. Otherwise,
Yeah.
World Health Organization, all the other guidelines during the screening, they always recommend fasting. And it becomes very difficult in rural setup for these women, those who stand for hours and hours outside the PHC to just get the screening done. So this DIPSY guideline is very, very important part. And that has been definitely able to pick up many diabetic patients much earlier and give them a proper chance of a good glucose handling during pregnancy.
Definitely, the single step test is very, very important according to DIPSY guideline,
Yes.
and that's really benefited in our screening program also, which we even done in Punjab. I mean, we have done this. That's really good. Thank you.
And again, as Dr. Vishal said, they are all daily wages. In the rural area, and only weekly once we have the antenatal case day. So if we are asking them to come again in fasting, it may be the other week, and somebody accompany them also, they lose their wages twice, 2 times. So they don't agree for test.
Very true. Very
Ashutosh,
true.
can I ask you one question about
Yes,
your
sir.
lecture?
Yeah.
I mean, it was a brilliant thing
Sure.
you spoke about in
Thank you so
elderly.
much.
Dr. Vishal, we have got time to talk
Yes,
about?
yes, please go ahead.
And in elderly people, I mean, in one of the slides you said, I mean, a premix insulin is sometimes preferred in the elderly people, I mean, because you don't want to mix R or N, that's there. But I mean, but most of the studies with the premix insulins in the elderly people, because the risk of nocturnal hypoglycemia is very, very high with the premix insulins. I mean, it's terribly dangerously, because you have to do 7-point SMBG in all elderly people before prescribing premix insulin to take a decision, very nasty decision to take premix in octogenarian population. And because when the risk of nocturnal hypoglycemia is to the tune of 53%, I mean, so I mean, that is, if you can comment more, or Dr. Vishal is there to tell me, to the audience, I mean, because I don't want to prefer, I mean, premix much in the octogenarian population or elderly people, because the risk goes very high, and you have to do after every 3 weekly 7-point SMBG, telling elderly people, they will run away from your clinic. I mean, they will never come to you back. I mean, what is this going on? 7 breaks and 7-point SMBG. So can you comment on that? I mean, Dr. Ashutosh?
Yeah, definitely, sir. As I have highlighted already in those slides, that we need to individualize the treatment. Treatment is individualized, and we don't have a lot of data on every aspect of insulination therapy in the elderly. So definitely, whatever we have, I just presented that premix insulins are sometimes to be preferred. But yes, we have to look for the setting of the patient. What are the factors that are leading to the initiation of insulin, and what are his dietary patterns, socioeconomic status. So there are many patients which are doing good on premix insulin. That's my personal experience. But yes, definitely those patients, I have patients which n number of patients with more on the basal bolus or basal plus therapy. So definitely premix insulin is little bit of, because of, as you correctly pointed out, because of nocturnal hypoglycemia episodes. But yes, due to less number of shots, it is sometimes favorable due to effective cost effectiveness. It is preferred by a lot of patients who are doing good, who are able to manage, who are able to monitor the blood sugar levels. Yes, in the very elderly and very frail, it is obvious that we must not opt for the premix insulin therapy.
We can prescribe premix insulins to these very elderly people or frail people if your clinic is very active in doing AGPs. I mean, because my clinic is very active, because we are doing averagely around 75 AGPs per month in my clinic. And I think some clinic has to be very active in doing AGPs, because you have to see TAR or TBR or TIR in AGP to see what is the TBR going on. I mean, because if TBR is too high, then you have to stop that insulin. You have to adjust the dose of insulin, because prescribing premix insulin, many times we talked about in various lectures. I say, according to my opinion, I mean, if you're very active in AGPs in your population, I say yes. If you're not active on the clinician side, I'm talking about, if you're not active in doing CGMS or AGPs, and you don't know what is the TBR going on in AGP, and you're continuing with a premix, I mean, this can be sometimes very detrimental for the patient. It's just my opinion. Sorry for that.
No, you have correctly pointed out, sir. But we know that in India we have patients who say, "Sir, दो बार ही लगाने का कर दीजिए, sir, दो बार से सही रहेगा." So if he or she is doing good with that, then we are also okay. That yes, we should go for the premix sometimes, and whatever is it has to be individualized. But definitely, thank you so much for your insights, sir.
No. Dr. Bhavsarne, you were coming out something.
As Dr. Rohit said, we can very well try with the basal, because the Tresiba, what we have degluted is wonderful. Without any hypoglycemia, we are doing very good. Even if the patient goes for 70 and all, they don't have the symptoms at all. Like hypo, and they don't go for much hypo also. Better you can, as you said, we can try with the latest insulins also.
Definitely, second, we can go ahead with the second generation basal insulins.
Absolutely. Or
Degludec is now with us. I mean, that can be very safe to be prescribed in the elderly people, because 73% less risk of this confirmed hypoglycemia by the Degludec.
That's right.
Dr. Vishal, now.
Yes. So what I would say is, common sense prevails in the management of diabetes, whether it is preterm, whether it is postpartum, whether it is adolescent, or whether it is elderly. Somewhere we have to draw a line between wise approach, practical approach, and also guideline-based approach. So we are the judges when it comes to proper management of diabetes. We do all these scientific feats for proper awareness and spreading the right kind of a treatment, so that maximum people, practitioners, can be benefited out of this scientific knowledge. Thanks a lot for making each and every aspect of life so important and how to manage it so easily. Dr. Kapoor, with all your expertise, what you have highlighted, these important points are extremely important for the listeners, that when they start managing, they should use the best possible techniques which are available, and you just have to use them to get the maximum benefit in management. All three speakers were excellent in their talk, very lucid, and very simply, they made it understand such difficult topics were handled so well. Thank you, Dr. Kapoor.
Thank you very much.
Thank you, Dr. Ashutosh. And thank you, Dr. Bhavkari. Thank you, each and everyone. Thank you, RSSDI. With this, we will move on to the next session. Thank you.
Thank you all. Thank you.
Thank you so much.
Thank you.
Hello. Am I audible?
So audible.
Okay, thank you. After a lively debate and almost a fight, I think today we are going to the next session, where we are talking about the clinical aspects, approach to in different medical aspects of diabetes. So we will, without too much ado, we'll start with the first lecture. I'm Dr. Subni D'Souza, chairperson, with my co-chairperson, Dr.
Priya.
Yeah, he's here. Thank you very much. Let us start the session with calling the first person, Dr. Raj Narayanan from Hyderabad. He will be speaking to us on approach to a patient with poor vision with diabetes. I think all of us have this problem as a chronic complication of diabetes. They have a poor vision. Not only that, even if they have a problem, even in the beginning also, because of the change of the lens osmolality, they start having problems, but they are not well controlled. I think right from beginning, we get into a lot of ocular problems associated with diabetes, especially with the vision. To highlight all that, we have Dr. Rajnarayanan, who is currently a director uh, in Hyderabad. He is adjunct professor of ophthalmology. He is a clinical assistant professor, and he was a honorary general secretary VRSI. He has more than 150 publications in various index journals. He has delivered more than 150 talks in multiple international forums. I think with that, and he has got a lot of grants as well. And he has trained 72 retina surgeons. It's a pleasure talking to you, Dr. Rajan. Now we'll listen to you. Thank you very much. Over to you, Dr. Rajan. Narayanan.
Thank you so much, sir, for the kind introduction. I'll now share my presentation. Please let me know if you are able to see my slides.
Yes, we can.
Yeah. Thank you. So I thank once again RSSDI, Dr. Banshi Sabu and Dr. Sanjay Agarwal for giving me this invitation on behalf of the Vitreoretinal Society of India and LV Prasad Eye Institute. I'll be talking about approach to a patient with poor vision who has diabetes. These are my financial disclosures. The causes are varied in a patient with diabetes in terms of vision loss, but the frequent causes are cataract, refractive error, and then we have all the other complications of diabetes, mainly diabetic macular edema. Then you can have vitreous hemorrhage due to proliferative diabetic retinopathy, and in some cases you can have ischemic optic neuropathy. But remember, again, the most common cause still remains cataract in patients with diabetes. But cataract is easily cured with a simple surgery, but diabetic retinopathy is a chronic disease. Sometimes the vision loss can be permanent. So in terms of I'll be focusing on the diabetic retinopathy aspect. There have been multiple studies on diabetic retinopathy and diabetic macular edema. And Diabetic Retinopathy Clinical Research Network of the US has had multiple protocols, and they key protocols were protocol I and T, and also there was a MEAD study on another dexamethasone steroid implant. I'll keep my slides very brief just to give the overall message that over 5 years, when the DRCR protocol, I looked at the results, 5 year follow up, patients still required, some of them required injections for diabetic macular edema. On average, patients in the first year require 7 to 8 injections per protocol, but even at the end of 5 years, some of the patients do require about 3 to 4 injections. But this graph shows the gain in visual acuity from the baseline at enrollment. And what it shows is that if you look at this on the y-axis, 10 letters is 2 lines, 5 letters is 1 line. So patients typically gain about 2 lines of vision in general after so many injections over 5 years. And you must have heard of these numerous injections which we as retina specialists give to patients with diabetic macular edema. It keeps increasing every year now that biosimilars are also coming into the market and newer drugs are also available. But what I have listed are the main drugs which we use. Avastin, Lucentis, and Eylea are anti-vascular endothelial growth factor molecules which tend to be given very frequently every month. And then other last two, Ozurdex and intravitreal triamcinolone, are steroids, which are long-term steroids. They can be used less often in the sense they are their action lasts for about 4 to 6 months, but they also can have adverse effects of glaucoma and cataract sometimes. So anti-VEGF injections are usually the preferred injections in diabetic macular edema, and this is a study by DRCR of the United States where they compared three anti-VEGF injections and aflibercept or Eylea, which we know it as with the trade name, that has the highest improvement in visual acuity in these patients, more than 3 lines over a period of 1 year, and even 2 years this was sustained. I will now switch gears and show some of my patients to highlight the challenges of treating patients with diabetic retinopathy. This was a 51-year-old gentleman who presented almost more than 10 years ago, and he has been following up with me almost for the last 10 years diligently, except during the time of COVID. And initially, when he had started coming to me, there was some gap in his compliance. When he came to us, his HbA1c was 7.8, and he also had hypertension and dyslipidemia, which are usual comorbidities in our patients. And the visual acuity in the right eye was less. The left eye was normal, 20/20. The right eye was 20/80 or 6/24. But the point I'm going to highlight in the next slide is that even if a patient has normal vision, they can have diabetic retinopathy. The top left photograph is the right eye, and you can see a lot of red dot hemorrhages. You can see these lipid plaques, hard exudates, what we call as cholesterol deposits in the right eye. And this eye I had mentioned had less vision, just 20/80 or 6/24. But see the left eye. Left eye is 20/20, 6/6 vision. But even this left eye, which has normal vision, has moderate to advanced diabetic retinopathy with all these blood spots, hemorrhages, dot blood hemorrhages, and hard exudates. The only reason the patient still has 20/20 vision in the left eye is because the fovea, which is the most important part of the retina for seeing, is still unaffected. But there is a lot of diabetic retinopathy still going on. And this patient, I will show you, lost vision in the left eye also in his follow-up. This is the fluorescein angiogram showing all the microaneurysms and leakage. This is the OCT scan. The top one is the right eye showing extreme edema, 846 microns over here. The left eye is normal. As I said, the fovea was normal. That's why his vision was 20/20. And we gave him injections. And again, for our diabetology friends, what we as ophthalmologists just tell our patients, which usually does not translate into anything, is we just tell them good systemic control, whatever that means to them, whatever that means to us. But that's all we tend to tell. And that's, I'm just telling you how we actually tend to tell our patients. We don't go into the details of their lipid or their renal function, or even anemia. We don't look at them at all. And the patient is happy to show us their blood sugar. They'll say, doctor, see, I have my blood sugar report, which was done 3 months ago, and it was fine. So how much was it? It was about 250, whatever. And then we say, okay, go to your doctor. And then the conversation starts. We just talk about the eye, and we just gave injections to this patient. And after multiple injections in this patient, the edema in the right eye still persisted. And in the left eye, after a few months of follow-up, now you can start seeing the left eye is also developing macular edema, and his vision has started dropping in the left eye also. And now his HbA1c is 8.1, and the left eye also has macular edema, although the vision is still 20/20. And now, after 1 year, the patient was lost to follow up. He had to go out of Hyderabad. His family was staying somewhere else. And now the HbA1c has increased to 9%, and his left eye vision has started dropping. This is after many injections. These patients somehow tend to think, or at least wish, that okay, after a couple of injections I will be all right, I don't have to go back to the doctor. But unfortunately, this is a very chronic disease, and this is a very common story. All of you must be also knowing from your patients also, many patients don't come back as per the prescribed protocols, and they come up with complications. So this is after the 1 year of loss to follow-up. You can see the left eye is as bad as the right eye now. And you see the macular edema, which is severe in both the eyes. My point of this case was to highlight how patients do not come for follow-up, or even if they come for follow-up, after many injections, things are not always rosy for them. Another case which I want to show from one of my series, a very old case, way back in 2007. But it's a very short story I want to tell, although I have lots of follow up. The main message would be about cataract surgery and diabetic macular edema. 53-year-old gentleman at that time had a decrease in vision for 5 months. And as I had mentioned, cataract is probably still the most common cause of vision loss in these patients. And he had reasonably good vision. So, left eye, we did cataract surgery in 2008. And after the cataract surgery, this is the drawing which we had made. We used to draw a lot with color pencils at that time. You see a lot of hemorrhages, macular edema, hard exudates, and you see my students' notes here: moderate diabetic retinopathy with clinically significant macular edema. And look at the vision here. After cataract surgery, the vision has dropped tremendously. Patient came to us for improvement in vision. We did cataract surgery, and cataract surgery after about 6 months or so, the vision has dropped significantly. What I want to emphasize is that cataract surgery, especially in patients with early diabetic retinopathy or uncontrolled diabetes, can worsen diabetic retinopathy. The other causes of vision loss, including bleeding or proliferative diabetic retinopathy, we treat with laser. Laser is the gold standard for proliferative diabetic retinopathy to regress all the neovascularization and all the bleeding tendencies that these patients have. So, for macular edema, it is injections. For bleeding, vitreous hemorrhage, laser is the standard of care, which we call a pan retinal photocoagulation or PRP. Just to highlight, this is on the left hand side is a kind of normal retina, no blood spots, no diabetic retinopathy. On the right hand side, you see a lot of tiny hemorrhages and a lot of hard exudates. They can also have neovascularization. Now I will switch gear to a patient with proliferative diabetic retinopathy where we had to do surgery. So, if a patient has mild vitreous hemorrhage or very early, we can do laser in an OPD setting. You don't need surgery. But if the patient has significant vitreous hemorrhage and you won't be able to deliver any laser inside the eye, we have to remove the blood. So this is a pars plana vitrectomy. We are doing a complex surgery here to remove the blood. And ultimately, the aim is also to pump in laser because that is the permanent treatment. But these are very delicate surgeries. We are working right on the surface of the retina with the forceps. We're removing all the traction. So the optic nerve or optic disc is supposed to be here, which is covered with blood, and there is tractional retinal detachment. A lot of fibrosis going on here. We are using intraocular scissors right now to dissect out all the membranes. I'll just forward this overall, and then at the end of the surgery, you can see that we have removed all the membranes. There are some lasers which we have put inside. This is the laser going on right now. You can see those whitish lesions which are coming. They are endo laser spots which we are putting to the ischemic retina. Um, as I mentioned, cataract is still the main cause of vision loss in these patients. This is a cataract surgery of phacoemulsification, which we are doing on the left-hand side with what we call as Ingenuity. This is the ultrasound probe being used to emulsify the cataract. And once the cataract is removed, I'll forward this. At the end of the surgery, we'll be putting an intraocular lens. As you can see here, this is the intraocular lens that we are putting. It's a foldable lens. You inject it inside the eye, it will unfold itself at the end, and then you will patient will be able to see very well if the retina is fine. On the right hand side, I'm going to show a case where we had to do cataract surgery, but along with that, the patient also has diabetic retinopathy. So this is the phacoemulsification which we are doing, and we'll be placing the lens here. As you can see, the lens has been placed now. But then you see inside the eye, the retina is all scarred. There is a lot of fibrosis. And these are still the most complex surgeries that we as retina surgeons do. Diabetic retinopathy surgery in terms of vitrectomy is the most complex surgery, and not just students, even practitioners are, experienced people also have very, very challenging situations with these. So overall, just as a conclusion, I would like to say that diabetic macular edema responds well to anti-VEGF injections. However, they need multiple injections over many years to maintain the vision. Patients may not get back their eyesight completely. Steroids implants can sometimes be used as long-term alternative to anti-VEGF injections. Laser still remains the gold standard for a proliferative diabetic retinopathy. Cataract surgery can aggravate diabetic retinopathy and diabetic macular edema. But point number 4 is something where we as ophthalmologists have to work very closely with diabetologists. And this is where my request from my society, from the ophthalmologists, is that we need to get together here. Somehow diabetologists have been able to work closely with nephrologists, cardiologists, but there is a long way to go for us to travel together along with ophthalmologists. So with that, I like to thank you for your kind attention.
Thank you very much, Dr. Raj Narayanan. You have been very, very clear. Am I audible?
Yes, sir.
Yes.
Very, very
Yes,
clear,
sir, you are
very
audible.
apt, and you have gone through beautifully what are the things that are associated with the diabetes and the eye. Now, I have one or two questions. You put it very nicely that both of us have to work together, and we do that. We don't neglect ophthalmology; they are very part of diabetology. All right. Uh, do you think physicians or diabetologists should know how to examine a fundus, which I've been doing regularly, and that I'll tell you gives a lot of confidence to the patient, and they can detect things much faster. What is your opinion about that?
Yeah, so that's a very good question, and thank you once again, sir, for that you are working very closely with ophthalmologists. What I meant was, even as ophthalmologists, we need to work closely with you. From
True.
that perspective, I was mentioning. In terms of diabetic retinopathy screening, yes, it is important for not just diabetologists, because I know a lot of patients with diabetes are treated by general physicians also. All of us should be able to um, diagnose diabetic retinopathy. In what way? That's a big challenge. That is something we all have to come to a consensus, in the sense whether fundus evaluation through an undilated pupil in a busy diabetologist clinic sometimes can be a lot of pressure on the diabetologist, because it's not going to be easy to evaluate the fundus of every patient through a small pupil. But we may be able to circumvent some of those problems with new technology or some other alternative, where you can have, let's say, a lab-based camera, or in a diabetology setting, you can have a fundus camera, which is called a non-mydriatic camera. In a lot of patients, they do give a reasonable quality of image. So, from that perspective, even if you are not able to do a retinoscopy or ophthalmoscopy, but if someone gives you a photograph of a retina of a patient, you should be able to tell whether it's normal or abnormal. You don't have to grade the diabetic retinopathy, or it's some other disease. Whether it's normal or abnormal, I think every physician should be able to diagnose.
Well, thank you very much. And secondly, how often do you think a diabetic patient should see an ophthalmologist on a regular basis? Is it
Yeah.
mandatory that you should see? And thirdly, in a patient with advanced diabetic retinopathy, how do you talk to them about regarding the prognosis? Because this is a very delicate question.
Yeah, so in terms of screening, a patient who does not have any diabetic retinopathy should have an annual examination of the fundus. But those who have diabetic retinopathy, depends on the stage of the diabetic retinopathy. Someone who has severe diabetic retinopathy, but not requiring any treatment at this point of time, are usually asked to come every 3 months. But someone who has mild to moderate may be asked to come once in 6 months. But those who already have center involving diabetic retinopathy or already have bleeding because of vitreous hemorrhage, they are managed in a totally different way. But as a screening tool, those who don't have diabetic retinopathy should have a checkup once every year. So what was the second question, sir? Can you repeat it?
In advanced diabetic retinopathy, how do you speak about to the patient regarding the prognosis of the eye?
Yeah. So advanced, even within advanced, there are patients who have good prognosis. Like, as I mentioned, this patient which I had shown who had multiple injections and was lost to follow-up, but has been coming to me now for the last 10 years. He's still working in a corporate office. He's still having his job. He's an accountant, which would not have been possible. He would have gone blind if we had not treated him. So the prognosis is relatively good in the sense some of them may not be able to, look at very fine print. Like there are some patients who are goldsmith, or they may have to change their job. But in general, patients who come to us in advanced diabetic retinopathy can still be maintained in terms of ambulatory vision, or even they can have a reasonably good quality of life. And those who have bleeding inside the eye, when we do vitrectomy, as long as the optic nerve is fully functional and the fovea is functional, they do get back good eyesight. But the patients who have a severe ischemia, those are the patients where we are able to tell the patient upfront that you see, I can see a lot of ischemia in your both optic nerve or the retina. I think we may not be able to do much, but that forms a very small percentage of our patients. Most of the patients, we are able to save them, that we are able to give them a good quality of life.
Thank you very much, Dr. Rajanarayanan. Because of short of time, I'm winding it up. I'm going to put the next talk. But it's a pleasure talking to you, and it was really worth listening.
I think
Thank you very
Dr.
much.
Raj is Raja. The main problem in India is that only we are able to take care of 20% of diabetic. It's our issue, patient issue, and all. So when you live with best of centers in the country, also if we can only take care of 20% aggressively below 7, what the challenges we have. So maybe for that reason we have so many cases of complications of diabetic retinopathy and diabetic eye issues and all. So once like how aggressively we are, there are a lot of patient issues and all. So it's very difficult for us in this country to say no. But yeah, as sir said, like we work with the ophthalmologist. I work in a hospital setup where there's a team where every diabetic has to go through a ophthalmologist or local ophthalmologist. So yeah, that way we can somehow decrease the burden of blindness in the country, right? Absolutely.
I agree with you. As individuals, quite a few doctors are doing a great job, but as a system, as a country, we need to do
True.
much more.
I agree with you. A lot of ignorance is going on. So
Yeah.
thank you very much. Over to Dr. Devamalya for the next talk.
Yeah. Like, can I have the we next we have a approach to patient with diabetes with irregular menstrual cycle. We have Dr. Ritesh Kumar Agarwal. Uh, he is from Bhubaneswar, Orissa, eminent endocrinologist, and he has 10 or more publications in international and national journals. He is the first prize in oral presentation at Assam Endocrine Conference. So over to Dr. Ritesh Kumar Agarwal for his presentation.
So
Welcome.
thank
Ritesh.
you, sir, and thank you, organizer. May I allow you to share my screen?
Absolutely, Ritesh, go ahead.
Okay. So after a nice talk on the retinopathy, this is a new topic where the role of diabetes with menstrual irregularity. So lot of menstrual irregularities which comes as a obesity with the irregular menstrual cycle. And if you see globally, around 9 of 100 adults have diabetes, and the prevalence and incidence is also rising. The prevalence of irregular menstrual cycle in women is also very high, around 14 to 27% all across the world. And this irregular menstrual cycle mostly present with oligomenoric cycle during their years 20, which is twofold higher in diabetic patient compared to the general population. When you see the data, what are available for this connection between the diabetes and irregular menstrual cycle, a study has reported around 25 to 50% of the young diabetic women of reproductive age suffer some form of menstrual disturbances. Either it is the increased length of cycle or menorrhagia or delayed menstruation or delayed menarche, early menopause. These are the some form of menstrual dysfunction they will notice during their diabetic treatment. And nurses' health study also shown that there is an increased risk of the diabetic woman with long menstrual cycle history, that is more than 40 days, or irregular menstrual cycle mostly between the age of 18 to 22 years. And it has also been shown that there is an increased frequency of type 2 diabetes in those women with a history of very long menstrual cycle. So in either way, both are connected with the vicious cycle. If you are finding a female with a oligomenoric cycle, you may suspect they are having higher risk of type 2 diabetes mellitus itself. So in this regards, what are the major risk factors contribute to this irregular menstrual cycle? One is the obesity. Second is the hyperinsulinemia, which is the major reason for the diabetes itself, along with the insulin resistance and central distribution of the fat. So how this obesity is related to this menstrual irregularity? If you see, during the obesity, the peripheral conversion of the androgen to estrogen occurs in the adipose tissue. And this is the major culprit. The estrogen is the major culprit for the hormonal imbalance, where there is a feedback inhibition of the FSHLS during the pituitary, which will disimbalance the hypothalamic pituitary gonadal axis. And it is a major risk factor for type 2 diabetes itself, which leads to infertility and menstrual abnormality. As I have told, this high estrogen results in the menstrual abnormality and anovulation by negative feedback to the hypothalamic pituitary level. And there is an association of the menstrual irregularity with type 2 diabetes if the BMI is more than 25 kg per meter square. Here also you see a frequency of oligomenorrhea in diabetes patients who are obese, diabetes patients who are non-obese, and the control. So the obese diabetes patient has higher risk of oligomenorrheic cycle compared to the non-obese diabetes and compared to the control. Here also you see, if the BMI is more than 25 with oligomenorrheic cycle, they have an odd ratio of 9. That means they are more than 9 times at higher risk to develop the diabetes mellitus. And in non-obese with a BMI of 25, less than 25 with oligomenorrheic cycle, they have a crude odd ratio of 1.5 to adjusted odd ratio of 1.8. That means BMI itself is a major risk factor along with the oligomenorrheic cycle for the development of type 2 diabetes mellitus. And how hyperinsulinemia or insulin resistance, which is responsible for this abnormal menstrual cycle, here the hyperinsulinemia, which results in excessive androgen production, which leads to menstrual cycle disturbances such as decreased fertility rate, insulin resistance, and the associated beta cell dysfunction predisposes a person to type 2 diabetes mellitus. And this hyperinsulinemia also has direct effect along with the gonadotropin, that is the FSHLH, which directly act at the Sertoli cell for the secretion of the estrogen. This hyperinsulinemia also has a negative effect at the hepatic level, where it decreases the sex hormone binding globulin. So there is an increased level of the free androgen, which again gives the feedback regulation to the hypothalamic pituitary gonadal axis responsible for the abnormal menstrual cycle. So this insulin, how it affects on the ovary, it directly stimulates the hormone production in the ovary, acts synergistically with the FSH-LH to simulate the hormone production, upregulate the LH receptor at the pituitary level, promotes ovarian growth and cyst formation synergistically with LH, responsible for the polycystic ovary in the ultrasound. There are also relationship with the menstrual irregularity and the diabetes mellitus, and here in 2020 there is a good correlation has been found between the very regular cycle, usually irregular, and always irregular or amenorrheic cycle, where you see the occurrence of type 2 or the cumulative incidence of type 2 is very early in the irregular or amenorrheic cycle compared to the usually irregular, regular, and the very regular cycle. So the incidence of type 2 diabetes is more in the irregular cycle. Here also you see the length of the cycle. Normally we know the menstrual cycle is 28 days plus minus 5 days can be taken into care. So if the length of the menstrual cycle is more than 40, 32 to 39, 26 to 31, less than 35, they also shows the incidence of diabetes mellitus. If the length of the cycle is more than 40, they have a high incidence of type 2 diabetes mellitus during the presentation, and that can be taken care of while the patient comes with the oligomenorrheic cycle to your clinic. So what are the different menstrual disorders a female patients have? They have polycystic ovary syndrome, diabetes, as I have said, hyperprolactinemia present with the menstrual disturbance, hypothyroid, thyrotoxicosis, and Cushing syndrome. So this diabetes mellitus increased LH-FSH ratio and androgen because of the insulin resistance, decreased gonadotropin level because of the negative feedback mechanism, hyperinsulinemia, which decreased the sex hormone binding globulin, responsible for the oligomenorrhea, long cycle, or long and heavy menstruation in type 2 diabetes mellitus. So these are the presentation of the menstrual irregularity. A patient come to your clinic, either they will have type 2 diabetes at the presentation, or they may have the risk of development of type 2 diabetes in future. So this is the hypothalamic pituitary gonadal axis, where the pituitary gland, thyroid, adrenal, pancreas, ovary are correlated with the different hormone they are secreting, which can lead to diabetes, and the hypothalamus, GnRH, anterior pituitary, ovary, estrogen, progesterone are all acting in a systemic way to control the menstrual cycle or any imbalance at any level which is responsible for the menstrual irregularities. And it has also been noted that this progesterone, which itself is causing the insulin resistance. So in a normal cycle also, the first phase of the cycle, that is the follicular phase, they show improved insulin sensitivity. And in the luteal phase, that is the second phase of the menstrual cycle, because of the high progesterone, they show some form of insulin resistance. So in this period, they may show hyperglycemia or uncontrolled blood glucose. But in type 2 diabetes, that is not much noticed because of the oral hypoglycemic agent. But in type 1 diabetes, it is very difficult to control the blood sugar level during this luteal phase. Those group of patients who are also taking the progesterone-based oral contraceptive pill, there also the control of blood glucose is difficult. So most of the patients of type 2 diabetes with menstrual irregularity are associated with polycystic ovary syndrome. So it is rightly said, polycystic ovary syndrome, when a rite of passage takes a wrong turn, it gives the polycystic ovary. We all know the polycystic ovary, which is characterized by anovulation, androgen excess, and insulin resistance. 20% of the obese women with PCOS have impaired glucose tolerance test at the time of presentation, and they have a very high risk of development of type 2 diabetes in future. Studies of adults and girls with polycystic ovary shows that insulin resistance is present early in the course of the syndrome, and the high prevalence of this risk factor among the adults and girls with PCOS puts them at increased risk of developing type 2 diabetes. So this is the pathophysiological way how this polycystic ovary syndrome is responsible for the insulin resistance and development of diabetes. This insulin resistance causes hyperinsulinemia, functional adrenal hyperandrogenism, suppression of the sex hormone binding globulin, functional ovarian hyperandrogenism, which leads to increased androgen level, which is responsible for the hirsutism, acne, androgen-dependent alopecia, and it can give us a oligo or anovulatory cycle, dysfunctional uterine bleeding, endometrial hyperplasia, which may be responsible for the development of endometrial cancer in future. So if a patient come to your clinic, how to approach, take the history and lifestyle, the menstrual cycle, it is regular, cycle duration, last menstrual period, previous menstrual period, or the history of menarche in type 1 diabetes, regularity of the cycle, age of the menarche, because in type 1 diabetes there is delayed menarche and early menopause has been expected. Menstrual cycle, it is in form of the menarche, as I have told, presence of irregular menstrual cycle, then what is the length of the cycle, any oral contraceptive pill or any other medical steroids are the patient is taking, acne at adolescent, hirsutism, pregnancy history, history of the physical activity or exercise, any past medication or medical history. So that will also helpful in the history taking, which is also help in the evaluation of risk factor for the development of diabetes by seeing the menstrual cycle only. Here also you see there is a multivariate relative risk of type 2 diabetes mellitus, which is associated with the menstrual cycle pattern, has been found out in between the age of 18 to 22 years. If any of the patients come to your clinic who has history of hirsutism or severe acne during their teenage, with a usual cycle length of less than 21, 21 to 25, 32 to 29, and more than 40, here you see the cumulative multivariate risk of 1.46. That means they have a very high risk of development of diabetes. It is also associated with the body mass index less than 25, more than 30. If the BMI is more than 30, they have a very high risk of development of diabetes with a cumulative relative risk of 3.86. If family history of diabetes in first degree relative is also there with any form of menstrual irregularities, they also have a very high risk of development of diabetes. So what are the symptoms of diabetes and menstrual disturbances you have to take care? There is the presence of osmotic symptoms in the form of hunger or thirst, increased urination, weight loss, and long irregular menstrual cycle, very heavy and long period, blurred vision with recurrent history of urinary tract infection. Adolescents with type 1 may experience their first menstrual period in a delayed phase, and with type 1 may experience the end of their cycle about 6 years earlier than the average. So as I have told, type 1 diabetes patient may present with the delayed menarche, and they may have a history of early menopause around 6 years before. So why we need to check it out before the diagnosis? Because early management of blood sugar helps to minimize the symptoms and prevent the complication. As my previous speaker also highlighted the role of our blood glucose control in management of diabetic retinopathy. People with diabetes are at risk to develop the complication during pregnancy if their blood sugar are not well managed. They have risk to increase risk for the baby, such as birth defect, hydramnios, macrosomia, and other related to preterm labor. So this is the normal slide what we learned from the beginning of our MBBS career, how to diagnose the diabetes, the normal blood sugar level, pre-diabetes, or the diabetes by doing either the fasting for random blood glucose or the oral glucose tolerance test with HbA1c of more than 6.5 or higher. How to diagnose polycystic ovary syndrome, which is most commonly associated with menstrual irregularity with the diabetes, either by the clinical signs or symptom, ultrasonic scanning, and biochemical parameters. So the clinical feature is the oligomenorrhea, amenorrhea, or dysmenorrheic uterine bleeding, obesity, infertility, hyperandrogenism in form of hirsutism or acne, miscarriage, endometrial hyperplasia, metabolic presentation in terms of impaired glucose tolerance, type 2 diabetes, gestational diabetes, dyslipidemia, and this is the normal finding like in pelvic ultrasound, you have to find out the endometrial thickness, presence of polycystic ovary. A lot of endocrine parameters are there to how to diagnose the polycystic ovary. Hormonal assay, it is better to do in the second or fifth day of the menstrual cycle. Do the beta HCG if amenorrhea to rule out the pregnancy. FSH, LH, and estrogen, because raised LH in patients exclude the cause of anovulation such as hypogonadotropic hypogonadism or premature ovarian failure. Do thyroid function test, prolactin to rule out hyperprolactinemia, 17-hydroxyprogesterone to rule out congenital adrenal hyperplasia, and metabolic screening in terms of oral glucose tolerance test, lipid profile, and others. And this is the criteria by which we can diagnose polycystic ovary syndrome. Mostly the Rotterdam criteria has been used, which is the exclusion of other androgen excess or related disorder, like as I have told, hyperprolactinemia, hypothyroidism, Cushing syndrome, and presence of clinical or biochemical hyperandrogenism, oligo or ovulation or anovulation, excuse me, and polycystic ovary. Any two of the following is present, we can say it is polycystic ovary syndrome. So screening of the impaired glucose tolerance, current guidelines for the screening in PCOD, according to the American Diabetic Association, we have to screen the fasting plasma glucose in all patients of PCOS when requiring screening. Fasting plasma glucose and PCOD screen when the BMI is more than 30. According to the Rotterdam group, 75 gram oral glucose tolerance dose when the BMI is more than 28 kg per meter square. So these are the criteria, but we have to follow the ADA criteria, where screening test is the fasting plasma glucose in all patients who are come with a history of long menstrual cycle and you are suspecting polycystic ovary syndrome to be ruled out. Management of obesity, if a patients come, diet, physical activity, and behavioral therapy, pharmacotherapy, and metabolic surgery. Pharmacotherapy is better at BMI of more than 30. Surgical management is preferred if the BMI is more than 30 with complications, or BMI is more than 35 or 40 without any complication. Management of diabetes, we all know the basics of the management and we are also following that. But standard first-line treatment of type 2 diabetes is also a treatment of PCOD. Metformin is the preferred initial pharmacologic agent in diabetes with menstrual irregularity, especially polycystic ovary syndrome. And it should be continued unless and until it is contraindicated or intolerated. Other agents like thiazolidinedione should be added to metformin. And it has been shown that studies are available for the metformin and rosiglitazone combination along with the lifestyle change in the PCOD, which shows some form of improvement in the insulin resistance and regularization of ovarian menstrual cycle. It improves the ovulation period. It has also been seen in some of the Chinese study which shows the metformin plus rosiglitazone and metformin alone on the menstrual function and fertility, and demonstrated a reduction in triglyceride, testosterone, and insulin resistance. So, outline of the management of PCOD is the treatment based on the androgen-related symptom, based on the menstruation-related disorder, and based on the treatment for the fertility. So, for hirsutism, we can opt for the oral contraceptive pill, mostly the anti-androgen, that is the spironolactone, drospirenone, or finasteride can be used, or the epinephrine, which can be used as a topical cream. For acne, isotretinoin. For alopecia, again, oral contraceptive pill or androgen blocker. For menstrual disorder, we can opt for the lifestyle modification with weight loss and acupuncture, pharmacological management with cyclic progestin, low dose combined hormone contraceptive containing the estrogen and progesterone pill can also be given. For the infertility, we can stimulate by the negative feedback with the use of the clomiphene citrate or gonadotropin, insulin sensitizer, that is metformin and thiazolidinediones, or laparoscopic surgery. So thank you for your kind and patient hearing. and the topic is open for discussion. And over to the organizer.
Ritesh, excellent talk. It's a vast subject. You have covered it in the time stipulated. Yeah, and it's a complex subject which physician always find difficult to deal with. And we always take help of the gynecology friends when we deal with irregular menstrual bleed and all. But your presentation, I think, has cleared many doubts in the physician's mind, deciphering, deciphering various cause of menstrual bleed. And PCOS, no doubt, has been there. And as you said, metformin, and then continuing with metformin when type 2 diabetes happens to them. Yeah, I think it's open for discussion. If Dr. Sydney would like to comment on this lecture.
Oh, it is wonderful. I don't know how he managed to get everything done in that such a short period of time. He covered most of it. And as it went on, it became more complicated. So I never knew that it was so complicated enough, but I think it is. And he has read beautifully regarding all the pathophysiology of these conditions. In a very nutshell, I think beautifully done, Dr. Ritesh. I don't have any question to ask you.
Thank you, sir. Thank you very much.
If no question, then Ritesh, you have done excellently well. People are clear about your lecture, and we are happy to have you.
I think a lot of research thoughts came into my mind when I was listening to Dr. Ritesh. I think in a teaching college, medical school, I think we can put all these things as a research activity. I think it's a very nice, eye opener sometimes. You sometimes lose track on all these small things. We always, so much medical cause of diabetes and we forget of all these things. I think you've done extremely well. Thank you very much.
Thank you, sir. And most of the time while treating diabetes, actually, we are forget to take the menstrual history.
Exactly.
Because most of the time, the patient itself is not disclosing the menstrual history and they are coming with the report and we are more focusing on the blood report itself.
And our negligence says that we all blame on diabetes. That's it, over.
Yes, sir.
Beyond that, nothing.
I think adolescent obese patient with irregular menstrual history, that is the catchment we have to catch on. And as you said, as early as possible, we have to catch them so that we can prevent complication and aggressively treat them.
One question, sir, I have not any data available with because I didn't get the time to collect the data for the patient. One patient come with the menstrual irregularity, and the patient was not referred to me for the menstrual irregularity. The patient was referred to me for the uncontrolled blood sugar. When I evaluated, and this is two different entity, and I find out that 17-year female was found out to be having diabetes, young onset, along with congenital adrenal hyperplasia, which is responsible for the menstrual irregularity.
Excellent.
Yes.
Thank you, Ritesh ji. And
Thank you, sir.
Over to Dr. Sydney. Yeah.
Yes.
For the next speaker.
Shall we go to the next one? Approach to patient with anemia and diabetes. For that, we have Dr. Praveen Calvit. He is a senior consulting physician and diabetologist in Calvit Nursing Home and Infertility Center in Bilaspur. His areas of interest include diabetic foot, diabetes education, which is most important, which most of us, tend to forget. His major achievements are he was the organizing secretary of CG Epicon 2004, ex-chairman API, chairman-elect RSSTI 2020, founder chairman of Bilaspur Diabetes Society, editor of education books on diabetes, started first insulin bank. Oh yes, very nice, in the state of Chhattisgarh, and second only in India in 2012. He's a distinguished physician award from RCP, London. He has got various membership of various bodies. With this, he's also again treading into a very complex issue on anemia and diabetes. Again, it's a huge book itself. I don't know how he's going to do that. Anyway, over to Dr. Praveen.
I wish to share my screen.
Yeah.
Is this visible?
Yes.
Thank you very much, Mr. Chairperson. And I take this opportunity to extend my warm thanks to the organizing team, Dr. Banshi Sabu, Dr. Vasant Kumar, and Dr. Sanjay Agarwal, who have given me this opportunity to be with you today evening. And the topic they have allotted to me is management of anemia and diabetes, very complex, as rightly been said by our chairperson. And I think what I will start by saying that in medical science, we always do not.
10 minutes, sir. 10 minutes
am I audible?
RxJD Adam. Research such as
Somebody is talking. Please mute your things. Except the speakers.
Yeah,
Thank you.
Yeah. In medical science, we shouldn't belittle the importance of any other finding we get in any patient during this treatment. We speak volumes and we hear all year about the different modalities we are taking care of to keep our patients in the perfect glycemic targets. And in the pursuit of keeping our patients in perfect diabetic target, we should never ignore the importance of hemoglobin concentration, not glycated hemoglobin concentration, but hemoglobin concentration, which is observed in hemogram, because it is one of the most important parameters if we are intending to control our patients in a nice way. And I am sure, and I think personally, that we are not giving much more importance to hemoglobin concentration, which deserves its importance. Anemia is one such finding wherein majority of the patients of diabetes mellitus are usually found to have this associated anemia. And today we are giving, today we are here to give a, some position to the presence of anemia or otherwise in management of diabetes mellitus. My topic today is going to revolve around few points which I like to enlighten. That its introduction, then epidemiology, pathophysiology, clinical features, risk factors, treatment leading to anemia, diagnosis and management, referral and prevention, and take-home message. Well, to introduce, I would say coexistence of anemia and diabetes has a major impact on overall health status of the patient. Anemia associated is known to intensify the risk of developing diabetes-related micro and macrovascular complications.
Good evening, sir. Good evening. Good evening, sir. Yes. All well.
Yeah. Could one of the participants please mute their phone, their audio? It's causing some humming. The prevalence of concurrent anemia and diabetes ranges from 14 to 45% in different ethnic populations worldwide. And in India, the prevalence of anemia in patients with diabetes was estimated to be around 18% approximately. Now, why do we want to understand the importance of anemia? The risk of anemia in patients with diabetes should be 3 times higher than that of patients without diabetes. The early evidence indicates that incidence of anemia in patients with diabetes mellitus is typically associated with presence of kidney disease. But then we do have patients who do not have underlying kidney disease but still are anemic and still are diabetic. So the early occurrence of anemia in diabetic kidney patients suggests that the early occurrence of anemia in patients without kidney disease suggests that there could be some other factors for causation of anemia than kidney disease. And it has been observed, a study conducted by Pranay et al. Showed that almost 40% of the diabetic population is anemic, even with normal renal function. That means the kidney element is not primarily responsible for causation of anemia, because in many of the patients, it has been found the prevalence is higher among the male diabetic patients with normocytic normochromic anemia. This is the commonest type of anemia encountered in our patients with diabetes mellitus. There are definite implications of chronic anemia and diabetes. As you all know, it causes progression of the macro and microvascular complications as well, contributing to cardiac disease as well as nephro and retinopathy. And if this anemia is untreated, it has got significantly poor outcomes, because this patient can cause very deranged quality of life or poor quality of life with higher chances of hospitalization and inert mortality. So appropriate screening, prompt detection, correction of anemia are very crucial to improve the clinical outcomes in patients with diabetes mellitus. And we know that the The pathophysiology of anemia and diabetes is multifactorial. There are various factors in operation when you deal with patients of type 1 diabetes and type 2 diabetes as well. In primary type 1 diabetes, you can say it is basically immune-mediated diabetes. The causes for anemia are again related to autoimmunity, and the entities which contribute to anemia in type 1 diabetes patients revolve around autoimmune gastritis and pernicious anemia caused because of the deficiency and malabsorption of vitamin B12. Malabsorption of iron and other vitamins also contributes to development of anemia in type 1 diabetes who also have malabsorption syndrome such as celiac disease. And in hypothyroidism, what we find is the reduced synthesis of erythropoietin due to reduced need of oxygen, which may subsequently cause marrow suppression. So this is again the out of autoimmunity. So these four factors of autoimmunity contribute to development of anemia in type 1 diabetes patients. In type 2 diabetes patients, when you see, we know that the ominous uptake, as we always talk of, and dirty presence, we always talk of the factors, the pathophysiological defects, which contribute to development of hyperglycemia in type 2 diabetes. Similarly, when we think of anemia in type 2 diabetes patients, we have almost a dozen of factors which contribute to development of anemia, eventually causing significant iron depletion and iron deficiency. To quickly enumerate few of them, it would be electronic hyperglycemia, diabetic neuropathy causing renal denervation, significantly affecting renal erythropoietin production, increased stress, oxidative stress, and reactive oxygen species, abnormal lifespan of RBCs, use of metformin, ACE, and ARBs, which are conventional drugs used in management of hypertension and diabetes, which cause significant deficiency, malabsorption disorders, altered DPP4 activity, testosterone deficiency has also been postulated to be important cause of anemia in diabetic individuals, chronic inflammation, advanced glycation end products, and chronic kidney disease, and reduced production of erythropoietin and functional efficacy of erythropoietin produced also contributes a great deal for development of anemia. Is the iron and erythropoietin deficiency and hyporesponsiveness to erythropoietin, which are plausible causes of anemia in diabetes patients having kidney disease, or even with relatively normal glomerular filtration, because we see that diabetes leads to chronic hyperglycemia, hypoxic environment in the renal interstitium is resulted because of severe hyperglycemia, impaired production of erythropoietin by peritubular fibrosis, defective erythropoiesis, and symptoms of anemia and diabetes in the patient. So in diabetes individuals, we have iron deficiency, erythropoietin deficiency, or erythropoietin hyporesponsiveness, or also in patients with nephrotic syndrome, wherein significant loss of erythropoietin factors through urine has been contributed as one of the important causative mechanisms. In iron deficiency, which is almost in 50% of type 2 diabetes patients, it is a reduced oxygen saturation leading to upregulation of inflammatory markers, inflammatory cytokines, impaired erythropoietin production. All this is a cascade of events with a set of once iron deficiency sets in. Similarly, erythropoietin deficiency and hyporesponsiveness of the individuals with insulin resistance to erythropoietin is also one of the causative mechanisms. And in nephrotic syndrome, it is again decreased erythropoietin production, secretion, or hyporesponsiveness, which has been blamed for anemia in diabetes patients. Now we have to quickly go through clinical features of anemia in diabetes patients, which are attributable to primary folic acid or B12 deficiency and iron deficiency as well. Fatigue, dizziness, palpitations, poor wound healing, cardiovascular complications, then increased level of biomarkers like NT-proBNP and CRP, these are events. Then clinical features of anemia due to vitamin deficiency in diabetes, clinically they manifest as pale skin, irritability, mouth ulcers, disturbed vision, sore tongue, loss of balance, and problems in the memory. And adding to these complexities are the features of folate deficiency like tingling, numbness in the hands, muscle weakness, and depression. So these factors collectively. The clinical impact of anemia in diabetes causes decline in the kidney function, increases the risk of retinopathy, hastens the progression of diabetic neuropathy, and increases the incidence of stroke, reduces the cognitive capacity of the individual. So there are certain risk factors which contribute to development of anemia and diabetes, like advanced age, malnutrition, certain drugs which are being used to treat diabetes mellitus, blood loss for reasons obvious, poorly controlled diabetes, inhibition of erythropoietin secretion secondary to renal disease, systemic inflammation, and decreased androgen levels. Of course, these factors we already took a stock of situation while we refer to the 12 factors responsible for causation of anemia. How iron and insulin sensitivity are related, this is very interesting. Serum ferritin concentration has been proposed to be a component of insulin resistance syndrome, and insulin resistance is associated. Insulin resistance is associated with the good iron stored in the body in presence of normal glucose tolerance. Now, what happens because of that is we will quickly see that an increase in the beta cell mass, raised basal and stimulated C-peptide secretions were observed in type 2 diabetic patients with increased serum ferritin concentration. Furthermore, significantly lower C-peptide secretion was found after phlebotomy in this iron depletion. So, iron and insulin metabolism is very, very closely linked. Insulin can impair iron absorption, and vice versa. Iron inadvertently adversely affects the insulin metabolism. It reduces insulin sensitivity and it causes hyperinsulinemia and insulin resistance, which eventually culminates into hyperglycemia in the patient. So, having an insight into the basic, the pathophysiological defects, or how actually iron metabolism or deficiencies related to other factors contribute to development of anemia and diabetes, we are now concerning our agenda, concentrating our agenda on treatment leading to anemia. Antidepressant, anti-diabetic medication, bariatric surgery, which are the therapeutic options for management of diabetes. You would be amazed to know that one of the most common drugs used very rampantly in management of hyperglycemia is metformin. And it has been established that approximately 10 to 30% of the patients on long-term metformin therapy tend to experience vitamin B12 malabsorption, and the features of malabsorption of vitamin B12 start manifesting as early as 4 months after initiation, and the clinical features to be obvious in our patients with megaloblastic anemia usually takes pretty long time, from 5 to 10 years. Similarly, use of thiazolidinediones has been associated with expansion of the body fluid and causes reduction in the hematocrit of the individual. It causes significant reduction in the hemoglobin levels also. Treatment with ACE or ARBs have also been blamed to be associated with development of anemia. But the only silver lining in the dark clouds would be the recent introduction of the drug belonging to DPP4 and SGLT2 category, which have been shown to have some favorable outcomes in patients with anemia. So the incidence of iron anemia in patients with undergoing bariatric surgery has also ranging from 12 to 47%. And this anemia is primarily because of the reduced absorption of the micronutrients, intestinal bleeding due to ulcers, reduced acid secretion, which is which may eventually lead to iron deficiency and iron deficiency anemia. These are simple the pathological markers. If you take into consideration the mean MCV volume of the RBC, then if it is less than 100 and if it is more than 100, depend with associated iron concentration, that will help you guide whether your patient has got iron deficiency or associated coexistence of other disorders. So what is important in this point is it is imperative to identify the underlying cause that may require immediate management of iron deficiency anemia. This could be due to poor nutritional intake and poor iron absorption or chronic blood loss. So it could be because of malabsorption like celiac disease or autoimmune gastritis. And when in the first column, we would rely too much upon the management of anemia in type 1 diabetic patients. But when it comes to type 2 diabetes patients, it is basically chronic inflammatory disease, chronic kidney disease without overt occult blood loss. So in such patients, we are required to evaluate urine or stool for examination for chronic blood loss, colonoscopy, upper endoscopy to see if he has got some microhemorrhages, assessment whether patient is on long-term PPI uses or antacids of metformin or other medications. And in patients with normal or low MCV and hemoglobin electrophoresis can be taken help to perfume that patient does not have got diseases like sickle cell disease. Now quickly coming to management, a prompt correction of anemia of anemian patients with diabetes with or without kidney disease has shown positive clinical outcomes, shown to improve in quality of life and reduce the complications and mortality in individuals. How to manage? Depending upon the severity, the underlying cause and comorbid conditions, these patients will usually commence with vitamin B12, oral vitamin B12 or folate supplements if they are on protracted and prolonged course of metformin therapy. If they are detected to have significant iron deficiency on evaluation of the iron stores, then they should be given oral or intravenous iron treatment. And in comorbid conditions, associated comorbid conditions like chronic kidney disease, these patients may need to start erythropoietin stimulating agents. If hemoglobin ranges less than 10 grams in dialyzed patients, it is recommended to put them on erythropoietin stimulating agents. Less than 11 gram percent in non-dialyzing patients, and we have to monitor these patients every week and to continue administer erythropoietin stimulating agents till we have a stable HB goal of 11 to 12%. The target for maintaining optimal hemoglobin is still undefined in patients who are on CKD and having underlying anemia, but it should be individualized based upon the age and clinical status and treatment response. In patients with diabetic kidney disease, evidence shows that target hemoglobin of 11 to 12 gram per dl is adequate in order to improve the overall outcome. But then a bottom line, one has to remember this, that overcorrecting anemia, overcorrecting iron deficiency anemia in patients of diabetes mellitus with hemoglobin, and if you're trying to achieve HB of more than 13 grams, then it has been found to be associated with some adverse cardiovascular complications and adverse outcomes. So treat anemia to the level, but then don't overcorrect the anemia. One very interesting finding about glycated hemoglobin and anemia is that iron deficiency is commonly found in patients in Indian scenario mostly because of inadequate nutrition. But in this iron deficiency anemia, it elevates glycated hemoglobin levels in diabetes patients with controlled plasma glucose levels. So you can have a normoglycemic patients with elevated glycosylated hemoglobin in the face of or in the wake of iron deficiency anemia. And unfortunately, it would not be proper to immediately initiate anti-diabetic therapy in these individuals unless we give a very sensible and a very careful eye for correction of underlying anemia. This is very, very important point. Presence of iron deficiency anemia should be considered before altering the regime meant for diabetes, because if you are not correcting the underlying anemia, then patients glucose, sugars may be showing inordinately high levels, glycated hemoglobin may be showing inordinately high levels. And many a times, if you correct the underlying anemia, you find that with the same medication the patient is on, his glycated hemoglobin as well as the prandial and fasting blood sugar levels return to normal. Diagnostic mistake therefore can occur in patients with anemia and diabetes mellitus. Use of newer modalities for diagnosis of diabetes like fructosamine test can be used in this group of individuals. When to refer such patients to specialists? Of course, a patient protracted iron deficiency anemia not responding to oral therapy for 6 to 8 weeks. Then if you are not sure if the patient is iron deficiency and if you want to switch patients to iron therapy, you should be careful. You should take help of hematologist before putting these patients on direct IV iron therapy. Anemic patients with diabetes and comorbid conditions like CKD and heart disease, persistent albuminuria in patients with anemia, and a lot of other certain special situations wherein diabetes as a primary physician can take care of anemia in these patients. But in such special situations, there could be an occasion where you are required to take help of specialist, hematologist, or a concerned subspecialist. So prevention of anemia and diabetes mellitus is extremely important. The prevention strategies for anemia and diabetes patients is highly important, as the causes of anemia and diabetes can be multifactorial. Addressing the root cause on time is required for alleviation of further sequelae of anemic symptoms in diabetic patients. You need to have good weight management. You have to have good and dietary modification. So having made an attempt to make this complex topic very, very simple and highlighting the importance of anemia deficiency, folate deficiency, and vitamin B12 deficiency in type 2 diabetes patients.
और इसको खाते रहना, बंद नहीं करना, तो मैं कहता हूँ अभी कम कर दिए उसकी डोज, लेकिन बंद नहीं करना उसको, ठीक है? वो दवाई बंद है ना, इसलिए
Organizers,
और थोड़ा सा
mute
ध्यान लगाओ,
all the microphones.
है ना? मेडिटेशन
Organizer, RX events, please mute others.
Anemia has a significant impact on quality of life of patients in diabetes mellitus due to morbidity. Multiple hospital administration need for frequent blood transfusions are required in severely anemic patients. Treatment with oral or intravenous iron preparations and erythropoiesis stimulating agents need to be individualized based on the patient's clinical status and comorbid conditions. and patients receiving treatment for anemia should be routinely monitored along with the other evaluations for diabetes-related complications. So the first and the foremost thing is that whenever a diabetes patient comes to your clinic, never ever forget to evaluate him for his basic hemogram. We lay more credence and more importance to renal parameters and glycated hemoglobin, and maybe not intentionally, but inadvertently tend to forget basic hemogram characteristics, basic looking into the factors of MCV, and we try to somehow ignore associated iron deficiency. So as an astute clinician, with good acumen, we must lay more importance on correction of anemia, which perhaps is of greater importance rather than addressing other complexities associated with diabetes, because as they say, stitching time saves line. If the basic deficiency of iron in diabetic patients is corrected, you are able to have a very good control of diabetes, and all three parameters, glycated hemoglobin, then fasting prandial blood sugar level, and also with the judicious treatment, even the glycemic variability could be minimized, and then you are able to have a good complication-free life for our patients. I think with that, I conclude. I thank you very much for once again for giving me this opportunity and your patient listening. Now I hand over to the chairperson, please.
Volume.
Dr. Sydney, you're muted. Yeah, it's an excellent presentation again. Yeah,
Dr. Praveen, you have done extremely well, good job. Host of factors which produce anemia, right from type 1 diabetes and autoimmunity that causes anemia in a type 1 diabetics, all the causes, including the celiac disease, which we tend to forget, and the type 2 diabetes, the drugs, the various causes. As a patient advances, the multiple drugs that is taken, including the antiplatelet drug, which can cause anemia again, and of course the hematological disorders that a person can develop little later. Not to forget, in our zeal to give good diet to the patient, and we try to prevent them eating all sorts of things, probably we are also producing some amount of iron deficiency of essential nutrients that are required for hemopiosis. I think that is where our problem comes. And excellently you said how A1C can be altered in a patient with iron deficiency anemia. You should not give much credence to that. And that brings a question: do we need to give them a hematinics as a routine? Is a question. And second question is, what do you have literature to say that overcorrection of anemia can produce cardiovascular morbidity? There are two questions I would like to pose.
Overcorrection of anemia, basically, unless you are very sure, because what happens in CKD patients, unless you are very judicious, you tend to overgive them erythropoietin stimulating agents, and they have been found to have their.
That is true. That is true. I'm talking about patients without CKD.
This overcorrection of anemia, even in some underlying cardiovascular illnesses, also in patients with ischemic heart or patients with cardiomyopathy. These patients have been found to do unwell with overcorrection of anemia. There are few studies, actually I could not quote for want of time, the reference I could give, but they have mentioned that overcorrection of anemia is detrimental to patients with underlying cardiovascular disease also. So in patients who have moribund diabetes with severe anemia, correct anemia, but correct them to the level of 11 to 12, maybe 13, but overcorrecting more than 30 has been found to be associated with some, deteriorating complications to the patient.
Now, secondly, the serum ferritin levels, because diabetes is an inflammatory state, how useful is serum ferritin in making a diagnosis for iron deficiency? Because it may be falsely raised. That's another thing which probably contributes. It may be falsely high.
Iron profile. Yeah, total iron we do. Total iron we rely too much upon the MCV parameters, sir. MCV, mean corpuscular hemoglobin concentration, is one simple index which gives an absolute idea about the underlying iron deficiency status. So when we do evaluation iron stores, we do what is called as a total iron profile, total iron binding capacity, iron saturation, percentage saturation, and at the same time we do serum ferritin levels, and we also do this, a good hemogram which tells us about the MCV parameters and RDW width. The pathologists usually refer to this. So those who have got significantly reduced MCV of less than 100 with ferritin levels of less than 20, they have been established beyond doubt they are having iron deficiency and they should be given parenteral iron. But the individuals with MCV of more than 100 and ferritin levels ranging from 20 to 100, it's a dicey situation. You may give them other vitamins like B12 or folic acid depending upon the RBC morphology. But unless and until you are sure you have made 100% credible that the iron deficiency exists, parenteral iron is usually not recommended. Therefore, they say whenever a diabetologist or physician contemplates IV iron therapy, it would be a good suggestion to consult a hematologist also to evaluate his blood and then decide upon the necessity of using this modality.
Dr. Divya Malya, do you have any questions?
Yeah. And Dr. Calvert, you excellent presentation once again. You had covered everything about diabetic and anemia, and your presentation was very lucid. And I think even if with CKD or without CKD, the amount of anemias that has been seen in diabetic, diabetic is a complex and dynamic disease. I think, as you said, 16 to 20% of non-CKD diabetic also leads to anemia. And you rightly said that role of erythropoietin, whether it's CKD or non-CKD, there is that diabetic neuropathy leads to, again, erythropoietin dysregulation and leading to anemia in non-CKD. And there were some evidence of, that if you compare this diabetic CKD to a non-diabetic CKD, the amount of anemia in diabetic CKD is significantly higher than a non-diabetic CKD. So overall, diabetics have, underlying chronic inflammation and all due to many issues. The anemia is a part and parcel of diabetic, and as we said, 16 to 20%. And I think improvement of anemia is very prudent, and it also helps the quality of life, So yeah, it's very important to, as you said rightly, that when a patient comes to you, the patient hemoglobin and other factors has to be seen at every like regular interval, right? So excellent presentation, Dr. Calvert. I think Dr. Sidney, we can go ahead.
Yeah, please. Over to you.
Thank you very much for your comments, sir. Thank you very much. Thank you,
Doctor. Yeah. So next we go to the approach to patient with glycemic variability. Dr. Uday Lal is here.
Good evening.
Yeah.
Good evening.
Pleasure to have you. He's the chairman-elect of Hyderabad chapter of API, executive member board of trustees and former honorary secretary of API Hyderabad. Is a treasurer, RSSDI Telangana chapter, state council member of IMA Hyderabad city branch, and then chief editor of monogram on interpreting and evaluating the common laboratories in clinical practice, organizing secretary of cardio diabetic CME, then joint secretary of API Telangana state chapter, contribute publication in various journals and API medicines update, invited as faculty to deliver lectures at various national and CMEs. And he is the EC members organizing committee local ESICON 2017 Hyderabad, joint secretary of EPICON RSSDI 2016, from a treasurer and executive council member API Hyderabad chapter. So welcome, Dr. Lal, and please go ahead with your presentation.
Can't share the screen. I think the other person has to stop sharing.
I think the
Dr. Praveen, he is already.
Yeah. Just 1 second, sir. 1 second.
Dr. Lal will speak of a very pertinent topic of discussion these days, glycemic variability.
Is it okay now, sir? Yeah.
Please go ahead.
Your screen is visible now.
Yeah, visible.
Can Can you see my screen now, sir?
Yeah, very much.
Visible, it's visible.
Okay. Okay. Can you hear me?
Yeah.
Right.
very-
Okay. Right. Good evening. At the outset, I'd like to thank Dr. Vasant Kumar, Dr. Bansi Sabu, and Dr. Sanjay and the rest of the RSSDI organizing committee for having invited me today to speak at this forum. So I've been asked to speak today on a rather important topic on glycemic variability. The topic has been there for some time, and we've seen that over a period of time, there have been newer advances that have taken place in this topic, and I will in the next 15 minutes try to cover some of them. So we have seen that glycated hemoglobin, of course, we all know is a gold standard for assessing glycemic control in diabetic patients. However, it has its own limitations with respect to measurement because of certain factors like anemia, as Dr. Praveen has just alluded to, pregnancy, globinopathy and ethnicity are some contributing factors. And there's always been a discordance in the accuracy between the measured HbA1c and the true mean glucose that's been observed in multiple substantial portion of patients in various studies that have taken place. So we all know that HbA1c does not take into account the fluctuations of blood glucose levels known as glycemic variability. And the fluctuations in this blood glucose can produce both intraday and which are day-to-day variations as well as interday. There are also individual variations which I'm not going to touch on, and I'm going to really just talk on interday and intraday variations. And we all know that these can increase both hypoglycemia and hyperglycemia and cause complications. So as we've already know that the AIC is associated with diabetic complication, and as I've alluded, that glycemic variability may worsen outcomes by increasing inflammation, oxidative stress. There may be endothelial damage and even cardiac complications. So what do we need to manage diabetes effectively? We all know that there has to be the glycemic prior to control would be, you need to see that both the hypoglycemic levels are well controlled. There's no evidence of hypoglycemia, and the glycemic variability should also be under control. So now what is this definition of glycemic variability? It basically are just swings of troughs and peaks in blood glucose levels. As I mentioned, it could be both intraday as well as interday. And but why is it so important? Because we have seen in some studies that have all shown us that intermittently high blood glucose levels are associated with more deleterious effects on cardiovascular health than even compared to a constant high blood glucose level. That's the reason why glycemic variability needs to be addressed and why a lot of studies are still being done on this issue. So here we see that we have two patients here. We have one patient who has a low variability. That means there are not too many peaks and troughs. The patient seems to be in good control. While if you see the patient B, you see again there are a lot of ups and downs in his blood sugars. There's hyperglycemic as well as hypoglycemic episodes, and that's where the glycemic variability is a problem. This is again a slide showing us glycemic variability, which can be from day to day. This is a CGM that has been done for a patient over 6 days. And you can see here, there are a lot of fluctuations on certain days in comparison to the others. So how do we measure glycemic variation as a metric? You can do it both on the, if you calculate it on the y-axis, you can calculate it by the metric amplitude, and then on the x-axis by the time. I will allude to the time a little later. So when you're measuring glycemic variability, you use the concept of amplitude for measuring glycemic variability. There are various ways of measuring it. There are many ways, like standard deviation, coefficient of variance are the two common ones. You have a lot of other ones like Conga, MOD, SOD, HGBI, LGBI, etc., which I'm not really going to allude to. The two commonest are these two, standard deviation and CV. Standard deviation is basically a variation around the mean blood glucose, as we know, but coefficient of variation is one step further, and it's basically the standard deviation divided by the mean. And this is a better way of trying to measure glycemic variability, because what happens in most cases when you are trying to see, if you try to only measure it with hypoglycemic excursions, then the glycemic variability specifically gets influenced by blood glucose. So you may not get a very accurate picture with that. Now, as I was mentioning, that you can measure glycemic variability even on the with respect to time. So you see some of the patients would be within the time range, some could be above the time range, and some could be below the range. So we'll discuss this a little later, a little more in detail as we go by. So what is time in range basically? Time in range basically refers to time spent in an individual target glucose range, which is usually between 70 to 180 milligrams per deciliter. But occasionally if you want the tight TIR, as it's called, then it could be between 70 to 140. So the percentage of time spent below, which is TBR, or the percentage of time spent above the range is TAR, indicates both hypo or hyperglycemia respectively. So TIR may be used as an appropriate endpoint in clinical research, but now more and more of us are using this from a clinical point of view. With things have eased up. The CGM devices are much easier and easier to access also, and it could be a good measure of glycemic control in patients with diabetes when you need to follow them up on a regular basis. And there is also emerging evidence that suggests that TIR is inversely correlated to the developing of microvascular and macrovascular complications in patients with diabetes. So now, as I mentioned, why do we need this TIR? Does the HbA1c tell us the full story? Unfortunately, it doesn't. If you look at this slide, it shows us 3 patients with the same HbA1c. The patient in example 3 has 100% TIR. His target in range is very good. The second patient's target in range is 63%. But look at the patient 1. He seems to have a lot of swings of hypoglycemia as well as hyperglycemia, and his target in range is only 18%. And mind you, they all have the HbA1c of 7%. So that's a bit scary when you see this kind of situation. So we have the international consensus of the CGM and data interpretation. This was Ballatoni had has given a very good article on this, and the ATTD have come to a consensus. And they said that with each incremental 5% increase in TIR is associated with a significant clinical benefit in both type 1 and type 2 diabetes. So if you look at this graph here, they have recommended a target range of 70%, which is should be 16 hours and 48 minutes. That's where the target of range should ideally be. But you have the graph, the yellow bar, where the sugars could be a little high, 180 milligrams per deciliter, and that is above, and they recommend this should be less than 6 hours. If the patient is above 250 milligrams, then the target should ideally be less than 5%. That's less than 1 hour, 12 minutes. Not saying that should be what you should be looking, but that's what the least they should be in. You should obviously try to keep the targeted range as high as possible. Going down to the bar below, you have the orange and red range, which denotes the hypoglycemia. So you have the type 1, which is less than 70 milligrams per deciliter, and the duration should be less than 1 hour. And people who have severe hypoglycemia is less than 54, the recommendation is actually less than 15 minutes. So, but the international consensus for older patients and patients with high risk of type 1 and type 2 diabetes, older people with decreased cognitive function, risk factors like coronary artery disease, CKD, etc., the bar has been reduced a little bit. You could have a target in range of greater than 50%, and you could have the sugars a little higher. So if the sugars are in the range of 180, you could, that's really about less than 12 hours, approximately works out to 50% is still accepted. And as far as the higher range of 250 milligrams, there it's again recommended there should be less than 2 hours 24 minutes. But if you look at the hypoglycemic area, they're very strict. They've not really changed that much, and they've said that it should be less than 1%, that's 15 minutes. So the idea here is to prevent hypoglycemic episodes in the high risk and elderly people. But moving on to patients with pregnancy, both in type 1 as well as in type 2, here the target range has actually has increased both in pregnancy and GDM patients, where they expect a much tighter control for the TIR. It should be for a longer duration, where the target range is between 63 to 140 milligrams per deciliter. So this was a study, regressive analysis done by Vygotsky. So how did this this golden value of 70% come? Because if you see in the slide here, the time in range, when you see from 0% to 100%, when you go through it, the HbA1c proportionately decreases as the time in range increases. So if you go by the ADA guidelines, where they say they want the HbA1c is less than 7, it was seen that if the time in range is around about 70%, then your HbA1c is about 6.7%. So that's what was recommended, that 70% and above is what one should really aim for. And this was done with multiple studies, which Vygotsky went through 18 studies. And for every absolute 10% change in the percentage of time in range, there was a 0.8% reduction in HbA1c, which we can see very clearly here. Now, what is the time relationship between the TIR and the mean glucose? There is an inverse relationship between the TIR and mean glucose as far as the sugar is between 120 and 200. So as the TIR will will increase, there will be a decrease in the mean glucose. But this doesn't hold good. Moment when the sugar goes down below 120, the relationship reversely falls. So when there is a decrease of less than 120, you'll see a decrease in the TIR also. So the inverse relationship does not hold good there. So what is the glycemic variability in hyperglycemia? What is the association? So we will see here that in this slide, we have the HbA1c on the x-axis, and we have the hyperglycemic events, which have been shown on the y-axis, and then the z-axis, you have the glycemic variability. Now, as you see, as the HbA1c decreases from a higher range to a lower range, the chance of hyperglycemic events also tend to increase, as you can see here. But if the glycemic variability is low, as seen here in the first two tertiles, then the hypoglycemic episodes are less. But that's not the case. As it goes on decreasing, the hypoglycemic episodes will go on increasing chances, because as the HbA1c decreases, the swing between hypoglycemia and hyperglycemia can increase and cause this hypoglycemic events that we need to keep in mind. So at the lower tertile of glycemic variability, things would be better. Now, if you look at this, again, glycemic variability with the risk of hypoglycemia, this is a study, the post hoc analysis of the switch trial, where the insulin degludec was used with glargine. And if you see both in the overall nocturnal and severe hypoglycemia, both in type 1 and type 2 diabetes, it is seen that in the low day-to-day variability, the incidence is lower for hypoglycemia in comparison to the high day-to-day variability, which is shown in the graph, the gray color one. So this is, again, a very important point that one needs to keep in mind. Now, with respect to time in range and HbA1c differs by the percentage of CV, we have seen here that when the coefficient, when there is a low glycemic variability, there will be a better TIR. So the percentage of CV would be definitely lower. Like in this, if you see at 25%, the purple line here, there is a low glycemic variability and a better TIR. When you compare it to the green line down, where it's at about 50%, here you see there's a higher glycemic variability and a lower time in range. So it is always, once there's a better time in range with a low glycemic variability, automatically the glucose would be better controlled. What are the implications of glycemic variability? So if you see this slide, which is actually from the DEVO trial, which again shows the same thing, that the all-cause mortality and MACE definitely when there is low variability as compared to high variability, which is shown in the slide. And if you look at this slide, again, it shows the same thing, that in addition to fasting blood sugar, postprandial blood sugar, and HbA1c, if there is a lot of fluctuations in the glucose, which is measured by MAGE, then this can give rise to activation of oxidative stress and lead to endothelial damage and cause increased risk of complications. So we are all as well as the glucose fluctuations. If you control this, then only the oxidative stress and risk of complications are going to come down. Now, time and range in microvascular complications, we have seen that for each 10% less time in range, again, with each 10% less TIR, microalbuminuria progression increases by as high as 40%.
Dr. Lal, we can't hear you.
I think he lost the connectivity.
Yeah, there was some issue before also.
The organizers, can you just RX events?
Yes, sir.
There is some problem with the connectivity with Dr. Lal. We lost him somewhere. Hello.
सर गिव मी सेकंड, वो स्पीकर निकल गए, सो उनको वापस कांटेक्ट करें.
Dr. Udaylal is, we lost contact with him.
It's almost time also, 5:51.
We still have 6 more minutes to go. Don't worry. We will wait for 2 minutes. Vinit, are you able to fix it.
वहाँ पे जाके आप अपना respective hall पसंद कर लीजिए. Sir, I'm sorry for the inconvenience. वो जो speaker थे वो उनको internet issues हो रहे. So he'll be back in just some minutes.
Okay.
I think Dr. Udayalal was giving a very comprehensive and very good account of glycemic variability. And the only problem comes with our patients. Practically, how are we going to do it is a question that one we need to ask. It all looks good in the literature, but when it comes to practical aspects,
70% time in range is really impossible in clinical practice. And yeah, that as you are absolutely right.
it's almost impossible to get our patient who gets their blood sugar down once a month.
Dr. Lal is back.
Back?
Yeah, he's back.
Thank you.
Could somebody
Sorry,
tell me?
Dr. Lal, we could not find you. Okay.
Welcome back.
Proceed.
Yeah.
Yeah. So do I start with the slide?
Started somewhere in retinopathy. Yes.
Okay, right. So I'll just go back to retinopathy. Yeah.
We have 5 more minutes to go.
Yeah, I shall just finish that. So as I was mentioning that for each 10% less TIR, retinopathy progression could increase by 64%, and that's the same even with microalbuminuria. So the lesser the time in range, chances of complications are greater. With respect to diabetic polyneuropathy, as we can see in this black bar, where the glycemic variability is more than 85%, when you compare it to the white bar, the painful neuropathy is greater when the association of the, when the glycemic variability is lower. So what about the time in range with the carotid intima media thickness? Is there an association? Definitely there is. It is an indirect marker to give us an idea about coronary artery disease. Again, if you see in this slide, it shows that with each 10% increase in the time in range was associated with about a 6.4% lower risk of abnormal CIMT. So that's again an important correlation that we need to keep in mind with respect to glycemic variability. This was a paper that was presented by Bernstein et al. At 2020 ADA. And this also showed that the risk of MACE decreased when the time and range was greater than 70%, when you compare it to patients who were in less than 70% by 27%, and people whose time and range was greater than 70% in comparison to patients whose time and range was less than 50%, there was a risk of MACE as high as 31%. This is actually a 10-year cumulative incidence of developing diabetes, which is related to complications after improving time in range. So if you see the complications of myocardial infarction, end-stage renal disease, severe vision loss, and amputation, in this IQR core diabetic model, it has shown that people whose time in range was between 58%, and when you compare it to the patients whose time in range was 80%, there was a significant improvement in these complications, whether it be type 1 or type 2 diabetes. Obviously, the percentages are more significant in type 1, but there was definitely improvement even in type 2 cases. So I'll like to summarize by saying that time in range is a new concept in glycemic monitoring, which is yet to be utilized effectively, but it's a very important and new upcoming a system which can be used in our daily practice also to treat our patients. And TIR has shown some good trends in reducing both micro and macrovascular complications, as I've shown you, and it may serve as a good clinical endpoint in outcome trials. So thank you. I'd stop now and take any questions if there are any.
Thank you, Dr. Lal. It's an excellent presentation once again. And we have a lot of discussion on time in range these days. And yeah, 70% time in range in clinical practice. Is it feasible? We will all try to, we will put our focus and issues and challenges on driving it through. But yeah, in clinical practice, if it's possible, I mean, yeah, we will be more than happy. And in fact, glycemic variability with quality of life goes hand in hand, as we can say, for a patient of diabetes to have a good quality of life, has to have a good glycemic variabilities. And I think what do you say on incretin-based therapy and time in range as far as this therapy is concerned, and with time in range, Dr. Lal?
Sorry, did you mention incretins?
Yeah, incretin-based therapy.
Yeah, definitely. Incretins have a role. I think they help in decreasing the glycemic variability, as well as the GLP-1 agonists, which have been shown to have some good results in bringing down the glycemic variability in these cases. Yes, I think probably only the OHAs, especially the older ones, is something that we would not use. But some of the newer drugs, I think whether it's DPP-4 inhibitors, GLP-1 agonists, they should, they should have a good result.
I think glucose also, as far as like long basal, long acting analog.
Definitely. As I mentioned, the switch trial has shown that very conclusively, that where they've used whether they use glargine or degludec, they've used even OHAs, and most of them have been either DPP-4 inhibitors or the GLP-1 agonist in those trials. Yeah.
Yeah. Dr. Sydney, or
yes, Dr. Uday, your slides were excellent and your talk was really, informative. Only thing is I want to ask a very simple question. How are you going to put this time in range into practice? Tell me a simple way of putting
I think, sir, we need to just see in the sense that if you have patients whose blood sugars are not very well controlled with whatever measures you've done, as I mentioned about HbA1c, fasting, etc., you have the Abbott Libre Pro that can be used now, which is a good continuous glucose monitoring system.
Yeah, that's for about 2 weeks you can get it. Beyond that, again is a question.
Yeah.
Our patients come with
yeah, that's true. So you need to really choose the patients and see which are the patients who really benefit with that, and where you can use it. I do understand that, but if you think that your patients are not very well controlled, maybe you need to call them a little earlier than 1 month and see, and try to explain to them that at least at this one particular time they got to make that effort to come in 2 weeks time, so that we can try to help them. Because even if we get an idea as to where the glycemic variability is, even subtle change in the medication would go a long way in trying to control them. And otherwise what happens is that we tend to be trying to use medications, not really having a scientific rationale sometimes, and keep increasing the insulin or keeping adding on OHAs. Maybe a slight change in depending on what the patterns are, would help us. So that's where I think CGM does have a part from a clinical point of view. Yes, it's got its limitations. I am the first one to agree to that. But I think if you look where we were 10 years ago, and now where we are, we have something more to offer to the patient in terms of trying to prevent further complications. I think that should be our goal now. We're not only trying to see that the HbA1c should only be under control. As I've shown you, there have been many patients who may have a very good HbA1c, but may land up with complications if there's too much variability.
That's what you put it forward. I wish we are going in the right direction. Hopefully, this will improve the quality of the patient care and life. Thank you very much. It was wonderful. I think with this, Dr. Devamalya, should we stop?
Yeah, we can.
I enjoyed meeting you. It's nice that we met so many people around. This is a very good podium to meet and get friends. Very nice. Thank you much.
Pleasure. Thank you very much. Nice meeting you. Thanks once again. Thanks, Doctor.
And I thank Dr. Bansi Sabu and Dr. Sanjay and Dr. Vasant for giving us an opportunity for both me and Dr. Devu Malya to chair this session. Thank you very much.
Thank you. Thank you.
Dr. Malya, thank you.
RS event.
We'll close at this.
Should I proceed?
I think we are past 6 o'clock. Please do.
Okay, okay. Yeah. Good evening to all of you. Now moving to the next agenda. What are the new therapies, especially in the diabetic field? So I welcome Dr. Anand Nigam. He's a well-known figure from Jaipur. And the topic of his talk is multifactorial approach to diabetic management and what are the evidences with one weekly GLP-1 analogs, especially dulaglutide. He has a career over more than 35 years, especially with the diabetes, and he has established a diabetes center at Jaipur. He is a fellow of Royal College of Physicians. He's also been a visiting fellow of Joslin Diabetes Center, as well as the Johns Hopkins University Diabetic Care USA. He has delivered so many orations, invited lectures, keynote addresses at various forums, including IDF, as well as the RSSDI. He has also chaired scientific sessions at most national and international meetings like IDF, Melbourne, Dubai, ADA, Middle East Congress, and also related abstract for the IDF 2011 and 19. He has so many publications to his credit, especially for the API textbook, RSSDI textbook, and so many peer-reviewed international and national journals. He is also served as an expert for the so many projects related with the ICMR, and is also chairman and the organizing committee of various national as well as international conferences. So with this brief introduction, Dr. Nigam, please proceed.
Thank you, chairpersons. Good evening, and let me just share my screen. Yeah, good evening, friends. I'm sure all of us will agree that there has been a paradigm shift in how we manage and look at diabetes as a whole in the last decade or so. The most number of advances have been in the last 5 or 7 years after the arrival of the cardiovascular outcome trials related to incretin therapies, related to the SGLT2 inhibitors, and so on. And these have really rewritten guidelines how you manage people with type 2 diabetes. We all know that type 2 diabetes is a multifactorial disease. It never occurs alone. It occurs in the company of friends. These are my disclosures, and the views are essentially mine and not of Eli Lilly, who are sponsors of this talk. And these are my other disclosures. Now, when I go to defining type 2 diabetes, it is a cardiometabolic renal disease. And all of us know that it starts with something like glycemia and weight, and you can just have a patient with blood pressure, lipids, and all this ultimately in the company of genes, environment, lifestyle, different diet patterns, other endocrine, neural, and metabolic disturbances leads to all these metabolic features that you see here: hyperglycemia, dyslipidemia, NAFLD. Then you've got renal complications like CKD, electrolyte imbalances. You've got cardiovascular complications like hypertension, atherosclerosis. Now, cardiovascular complications are the most important and deadly and devastating complications of type 2 diabetes, responsible for almost 65% of deaths, more than 75% of all hospital admissions, and leading to almost 2 to 4 times increased death because of coronary artery disease. Now, when the chronic kidney disease comes in, it becomes a triple threat, and it is a disease multiplier. Now, this shows you the QR risk score, which is the risk of getting a cardiovascular disease in male and female patients in India. And you can see here, as your age advances, the QR risk 3 score continues to mount, and people, this is in women and this is in men, but people in India and Asian Indians do not have only an epidemic of diabetes. They have abdominal adiposity, they have hypertension, increased risk of cardiovascular and renal complications, and renal complications could be as high as the tune of 40 to 70%. All of us are aware of the various cardiovascular risk factors in diabetes, and these are so well known to everybody: smoking, hypertension, male gender, high cholesterol, family history, chronic kidney disease. But very important also are duration of diabetes, glycemic control, and presence of microvascular complications. Remember that cardiovascular death will increase in patients with diabetes who have multiple risk factors. So if you have just one risk factor, the gray bar shows you people with diabetes, the blue shows you no diabetes. If you just have one risk factor, then the risk is low. But as these risk factors multiply and are more in a particular individual, for example, if your patient has both type 2 diabetes, has hypertension, is a smoker, has obesity, he has got 3 risk factors, and that is the risk of cardiovascular disease that this individual would have. Now, if you don't control blood glucose, the UKPDS told us very clearly that you're going to get devastating micro and macrovascular complications. This is the Kaplan-Meier graph, which shows you very clearly that if you have clinical inertia, you don't act on time, there is increase in the incidence of diabetic retinopathy, and this is clinical inertia. But if you were to act on time and you had no clinical inertia, then people would be free of diabetic retinopathy. So a clinical inertia is associated with a decreased median time to the progression of diabetic retinopathy, and it causes poor metabolic control and increased progression. But not only that, macrovascular complications responsible because of a poor metabolic control could be 67% increase in myocardial infarction, a 51% increase in cerebrovascular accidents, heart failure, and a composite of 62% increase in people who do not control diabetes well. Now, this is a very big challenge when you try and control glucose. You get hypoglycemia. As you start getting your HbA1c down, you start getting hypoglycemia, especially when you're using agents like sulfonylureas and insulin. And this hypoglycemia probably, as the advanced study suggested, could be a factor somewhere playing a part in cardiovascular risk. And then the patient starts eating defensively and you gain weight. And so this sets into a vicious cycle. And look at the weight gained in clinical trials like the UKPDS, the DCCD. You can see here, people gained almost 9 to 10 kilograms of weight over all these studies. Also, hypoglycemia is a major limiting factor in achieving glycemic goals. Every time you increase your HbA1c, people get hypoglycemia. Now, if you just control glucose and don't look at other factors, the risk of cardiovascular disease is still high. Look at the hazard ratio, it's over 2 in people, even when they had a HbA1c of around 6.9, which means we need to move away from just glucose control and pay attention to multiple factors that surround and accompany type 2 diabetes. As your HbA1c increases, the hazard ratio of cardiovascular disease and mortality increases. So you've got to be not glucocentric and keep moving away and attack all the risk factors. And the STENO2 type 2 diabetes study was a landmark study by Peter Gate, which very clearly showed that if you have multifactorial intervention in type 2 diabetes, these were people with microalbuminuria, and there they paid attention to glycated hemoglobin, correcting cholesterol, triglycerides, systolic blood pressure, diastolic blood pressure. And you can see the study started only for a 7.8 period, but followed up for 13 years, showed a decrease in cardiovascular death and cardiovascular events. And this very clearly shows you people in blue are people who were intensively treated as compared to people in brown who were conventionally treated. And you can see the decrease in death from cardiovascular causes, stroke, myocardial infarction, CABG, PCI, and amputation. So if you intervene properly and you look at all factors, giving people anti-diabetics, antihypertensive, statins, aspirin, asking them to stop smoking, you are probably doing more justice to your patients. So there has been a paradigm shift in how we treat type 2 diabetes in 2021. Previously, it was all about glucose and glucose control. But now it's about glucose control with no hypoglycemia and weight gain, or aiming for weight loss, and cardiovascular and renal risk assessment and management. And so we need to really see what do guidelines and consensus statements tell us. Now, if you look at the prominent guidelines and the association remarks, the ADA 2021, the American College of Cardiology, and the American College of Clinical Endocrinology all very clearly show that the GLP-1 molecules, GLP-1 receptor agonists, and the SGLT2 inhibitors have to be considered independently of baseline HbA1c, which means if your patient is doing well, has an HbA1c of 7, but has an underlying cardiovascular disease, you really need to change this pattern, the therapy to either of these two agents, individualized HbA1c target or metformin use. So you just need to change molecules to a GLP-1 or SGLT2 with proven CVD benefits to reduce the risk of MACE in people who have established atherosclerotic cardiovascular disease, heart failure, or chronic kidney disease. And they suggest that use the long-acting GLP-1s or the SGLT2s with proven benefits. Now, it's not only that, it's also indicators of high risk, which means if your patient, for example, this morning I saw a patient who had type 2 diabetes, was morbidly obese with a BMI of 34, had hypertension. I needed to shift this patient to, and this patient was only on DPP-4 inhibitors and SUs. So I put the patient on a combination of GLP-1 and a SGLT2 inhibitor with a BMI of 34, 35. Now look at, this is the anti-hyperglycemic therapy that you have today, addressing not only efficacy. This is what we were looking at for most of our last 7 or 8 years, but now you've got hypoglycemia, weight change, CV effects, cost, progression of DKD, and dosing and other things that you need to consider. And so if I look at the bottom, DPP-4 inhibitors, the glitazones, the sulfin, they have really not shown us any benefit here. So I just close this box here. The SGLT metformin is high in efficacy, doesn't cause hypoglycemia, is weight neutral, has some potential benefit in atherosclerotic cardiovascular disease, but really no benefit as far as kidney disease is concerned. And you've got to stop it when your EGFR is approaching 30. So the molecules then left are the SGLT2 inhibitors and GLP-1s. Both are effective. The highest efficacy here is with the GLP-1s. Both don't cause hypoglycemia, and you've got potential benefits as far as atherosclerotic cardiovascular disease is concerned, and also progression of heart disease is kidney disease is concerned. And the focus of our evening discussion is the GLP-1. So here is the story of the GLP-1. So is there evidence that GLP-1s reduce multiple risk factors in people with type 2 diabetes and thereby reduce the risk of cardiovascular renal disease? And the answer to that is yes. And the data that is convincing comes from several trials. And this is the Rewind trial from dulaglutide, which shows the effect of dulaglutide on HbA1c, on body weight, on blood pressure, systolic blood pressure, on estimated EGFR and urinary albumin creatinine. And you can see here a good HbA1c control, a good body weight control, no hypoglycemia, systolic blood pressure is improved, estimated EGFR is stabilized, and there is a drop in urinary albumin creatinine. This study very clearly shows you that it also plays a part in the indices of vascular damage. And these are indices of vascular health. These are the important risk factors we just mentioned, but 3 important ones that I'd like to highlight here are reactive hyperemia index, which is a measurement of endothelial dysfunction, pulse wave velocity, and augmentation index. All are surrogate markers of the vascular health. And you can see here, as therapy with dulaglutide increased over 3 to 9 months, you can see here this reactive hyperemia index is inversely related, which means the higher the RHI, the better the improvement in endothelial dysfunction. And similarly, you can see here a drop in pulse wave velocity and augmentation index. Of course, dulaglutide decreased systolic blood pressure, decreased weight, decreased BMI, and also has had very effective benefits as far as lipids were concerned. Now, when you look at the summary of the CVOT trials with the GLP-1s, the REWIND trial stands out prominently. It was the longest trial with 5.4 years, 9,900 patients, HbA1c 7.3, but remarkably, this study only had 31% patients who had existing cardiovascular disease. The rest were people only with risk factors. So there was a large primary prevention population. In contrast to other studies, where, for example, ELIXIR had 100% people with pre-existing cardiovascular disease, LEADER at 81, SUSTAIN at 58, EXCEL at 73, but here it is only 31. And the MACE hazard ratio, the 3-point MACE, the hazard ratio was 0.88, which means it clearly had a 12% decrease, in significant decrease in the risk of reducing the risk of 3-point MACE. Now, how did it compare with the other GLP-1 trials? And this very clearly showed you that you can look at the hazard ratio of REWIND is 0.88, quite similar to LEADER and others here. And the overall HR, if you do a meta-analysis, was also 0.88, which then very clearly showed that dulaglutide reduced cardiovascular outcomes in both men and women with or without previous cardiovascular disease. I just mentioned that this group only had 31% people who had pre-existing cardiovascular disease, and therefore had an effect size similar to that observed in the trials of other GLP-1s, which were mainly secondary prevention populations, which I just mentioned. These are people with prior CVD or no prior CVD, and dulaglutide reduced the risk of MACE events in adults with or without known CVD. And you can see here the hazard ratio is almost similar in both groups, whether you had a pre-existing cardiovascular disease or you did not have it. Now, the renal outcomes of dulaglutide trials were exploratory in nature, but you still see a 15% reduction in composite kidney outcomes and also a 30% reduction in worsening of kidney problems. How did this all happen? Now, these are the potential probable cardiovascular mechanisms, how GLP-1s reduce cardiovascular risk in people. You've got a decrease in glucose and decrease in insulin resistance, a body weight reduction, and therefore you have decrease in visceral fat, LDL cholesterol, decrease in albuminuria. And specifically for the cardiac system, it decreases atherosclerosis. I showed you the improvement in endothelial dysfunction, decreases systolic blood pressure, improves endothelial function, increases cardiac function, and also decreases inflammatory markers. And there are studies which have shown improvement in inflammatory markers like the interleukin-6 and the PAI. And these studies are still ongoing, and maybe in the next year or so, we will have data very clearly to show the effect on the inflammatory markers. Now, side effects of GLP-1s are so well known to us, but this shouldn't be a deterrent in using these. These are almost side effects which pass away with time and need your time and reassurance. Nausea, vomiting, diarrhea. Most patients have short-lived problems just for 3 or 4 weeks, and maybe by the end of 4 weeks, these things pass off, but it constantly needs your monitoring and also your attention. Now, before I let me just show you a very interesting trial which was published in 2021, and this is called the CAPTURE trial. Now, this trial very clearly showed that, and this was in 9,000 patients over 13 countries. 34% patients had cardiovascular disease, 31% people had atherosclerotic cardiovascular disease. 89% were taking cardiovascular medication, which means they were not missing out on statins and aspirin, but only 25% were on glucose-lowering therapies with proven cardiovascular benefits like the GLP-1s, the SGLT2s, or the combination. I use a lot of combination of the GLP-1s and the SGLT2, especially in this very high-risk population, and prevent them from ending up into problems like that we have just discussed. So friends, type 2 diabetes is a cardio-renal metabolic disease. We've been able to show you how it affects micro and macrovascular complications if you don't control them. The residual risk is still high. You may control their glucose, but the risk is high. The risk of cardiovascular disease and mortality continues to be high. Several CVOT trials, like the one from the dulaglutide, the award trials, have shown that these molecules have very important benefits as far as reduction of glucose is concerned, but not only glucose, its weight. And the REWIND trial has shown effects on the weight, blood pressure, urinary albumin, creatinine, and overall reduction of cardiovascular risk factors. And therefore, most associations now recommend that you should be using these molecules in the presence of high indicators of cardiovascular risk, or established cardiovascular risk, heart failure, or chronic kidney disease, independent of the baseline HbA1c. And dulaglutide specifically amongst the GLP-1 receptor agonists stands out because it is importantly shown benefits of reduction in MACE in both people with and without cardiovascular disease. And this was seen as similar to other trials where there was a large secondary prevention population. The effects on kidney function are also important and should be kept in mind. And the side effects are something that are manageable with reassurance to the patient. Thank you very much for your attention.
Well, it was a wonderful talk. The slides were excellent. And if we space your talk, the first part and the second part, the first part laid the wonderful foundation where you rightly highlighted that the hyperglycemia is the only tip of the iceberg, and much of the submerged part are those metabolic parameters. And what most of us have been doing over the years is targeting the glycemic targets only, and more important are the non-glycemic targets. And probably dulaglutide is addressing more of the non-glycemic parameters, especially the lipids and the renal parameters. That in turn had a benefit over the cardiovascular risk factor. So it was a wonderful talk. You spaced it so well. So I would invite, if there are any questions. I don't see any questions in the chat box right now, but would you like to highlight the superiority of dulaglutide within the group itself as compared to the other ones?
Yeah, so that's an excellent question. I have very clearly shown that if you look at the cardiovascular outcome trials, what do you see in clinics every day? You don't see every patient who walks in had a heart attack or has had a stroke. These are people that you see commonly in clinical practice are people with risk factors. As I mentioned, type 2 diabetes never walks alone. It walks in the company of bad friends, or what are called as cluster of abnormalities. And these cluster of abnormalities include hypertension, include obesity. Yeah. And so these molecules, when you look at a general population, and the REWIND trial very clearly showed that this was only a group of 31% people with pre-existing cardiovascular disease and 60% no cardiovascular disease. So if you're talking to a general population, if you're talking in a general population perspective, I think this very clearly has shown the benefit of being able to prevent cardiovascular disease and prevent the ensuing complications that you may get over time. There are post hoc analysis of the REWIND trial, which have also been published, which I have not been able to show here because of constraint of time. And this has shown even benefits in the renal parameters. The parameters that I showed you were from the REWIND trial. These were exploratory in nature. But if you were to combine both attacking cardiovascular problems and renal problems, I think you're doing much more benefit to your patient. Now, one would wonder that this only reduces your systolic blood pressure by 4 millimeters and 3 millimeters. So what's the big deal? Well, let me tell you, if you use GLP-1s, as I do, I know from clinical judgment and clinical practice and experience that even this 4 millimeters transcends to larger reductions in blood pressure over a period of time, because patients lose visceral adiposity, patients lose weight. And so over a period of 4 to 6 weeks, you're able to decrease their antihypertensive agents. So even that which you see in the trial is just 4 millimeters. I think those 4 millimeters are just nominal. What you see is larger improvements in overall vascular indices and vascular health of the patient. So this trial, this molecule stands out because of several factors. One, because of the nature of the trial. It was the longest trial, 5.4 years, 9,000, the longest CVOT trial in the GLP-1s. The population I've just showed, men and women equally distributed. And then the benefits that you see. And once a week, single injection, excellent pen. I think it makes the story very simple.
So wonderful. And you answered it very well. So I still don't see any questions in the chat box. If there are no more questions.
So can I ask one question?
Yes, sure, please.
Sir, what do you find the difference between the side effect when you use daily like liraglutide and versus weekly this dulaglutide? Is there any same side effects, especially nausea, vomiting, or there is a low, especially with this weekly?
Well, there are several studies which have shown that when you have a weekly injection, the side effects are much less than a daily injection. And these are patient studies where patients have been asked to fill up forms and give their opinion about and from clinical experience also, people, when we used exenatide about 10 years ago, which was Byta, at that time there were 2 injections a day. So the nausea vomiting was much more. And then came once a day with liraglutide, it fell. And now with once a day, once a week injections, these are very, very little. But what they will still be there. I mean, this is how the molecule works. It decreases gastric motility. And once it decreases gastric motility, it causes that fullness, and that fullness is responsible. So what you need to do really is to explain to patients why will you get this? And once you explain that patient, he's got to be patient for the next 3-4 weeks. I sometimes advise, if you have a history of nausea, vomiting, patients sometimes are intolerant to metformin. So what you could do sometimes is decrease the dose of metformin when you are starting a GLP-1 and see his response over 3 or 4 weeks, and then build up the dose of metformin and also build up the dose of GLP-1. Of course, they say start with 1.5, but I find sometimes that I start with 0.75, wait for 2-3 weeks, prime the patient, and then increase to 1.5. Now, off-label, GLP-1 dulaglutide has been approved in the dose of 3 milligrams and 4.5 milligrams for people with morbid obesity in the United States, and those pens are available separately. And I have some patients where I'm using 3 milligrams of dulaglutide once a week, and just by convincing, they are able to tolerate. They have this initial. So what we do is we start with 0.75, build it up to 1.5. And when he's taken that 1.5 for 3-4 weeks or 3-4 months, we increase it to 3 milligrams. And these are people with body mass indices of 38, 39, refusing to go for bariatric surgery and getting all the worst complications of obesity that you can have, like obstructive sleep apnea, osteoarthritis, and lung problems, and so on. So these patients really benefit. Of course, this is still not on the label in India, but it's approved. It's FDA approved, and you've got pens. So here again, 3 milligrams works without nausea. It just gets you that nausea 24 hours after you give the first shot. But this nausea then passes off as you increase the duration of therapy.
Thank you, sir, for a wonderful answer. So I think there is no questions in the chat box. Can we move to the another session?
Thank you very much. Thank you.
Thank you, sir. Thank you. Next.
Yeah.
Dr. Amit Verma, sir, can you please proceed, or should I?
I'll do that. It's my honor.
Okay.
Huh? A pleasure.
Thank you.
It's really a pleasure introducing Dr. Kamal Sharma. And Dr. Sharma is a senior interventional cardiologist with vast experience of coronary angioplasties, stenting, valvuloplasties, pacemakers, and pediatric interventions. And he has a rare combination of DNB degrees in both medicine as well as cardiology. And apart from practicing at SAL Hospital, UN Mehta Institute of Cardiology, Ahmedabad. Dr. Sharma has also been teaching the subject of cardiology at BJ Medical College. He has been awarded 22 gold medals for academic excellence during medical studies. That's great. That's wonderful. And did world's first vagal stimulation device implant as a part of Anthem study in the refractory heart failure, discovered winking coronary sign of VSR on angiography, also called as Kamal Sharma sign of VSR, principal investigator in trials like Paradigm, Heart Failure Atlas, TIMI, TIPS, and Surf Canvas, 210 publications and more than 10,000 Google Scholar citations, wonderful, awarded Excellence Teacher Award by Gujarat University, and only cardiologist to have cleared civil services in first attempt. Oh, well, I'm really impressed by such a wonderful, impressive CV. So with this, I welcome Dr. Sharma. He will be talking on decoding new heart failure silence. Where and how do I put dapagliflozin in the treatment regime? You're welcome, Dr. Sharma.
Good evening, everyone. Thank you, Dr. Amit, for a wonderful introduction and kind words. Thank you, RSSDI, Dr. Bansi Sabu, and all the faculties for giving this opportunity to me. So I'll be talking about decoding new heart failure science, and I'll be focusing where and how I put dapagliflozin in the treatment regime in these patients. This is my disclosure. So I'll be talking about the therapy of SGLT2, and as my previous speaker was touching upon, how science of diabetes has changed. But what has also changed simultaneously is the change in science of heart failure. Heart failure is a global major health problem. And if you look at just the Indian figures, which are meager, but roughly in the Trivandrum Heart Failure Registry, we know it's almost 1% of adult population. And it's roughly the same in China, Japan, and which are almost the similar demographics in terms of not the ethnicity, but the age of population, which is now more aging in China. But if you look at more discrete population bases like Singapore and Malaysia, the prevalence is much higher. So the global prevalence is 63.6 million, and heart failure with the SGLT2 in the background, that's why you have a cardiologist now speaking at an RSSDI diabetes conference. So it's a big problem because trends in the worldwide prevalence of heart failure with the DALI or the years lost in terms of the quality life, the heart failure prevalence has increased by 36%. I think we were probably underdiagnosing them, or maybe they were underreported and not diagnosed till for quite some time for the diastolic heart failure. The expected increase is another 10% with the rising prevalence and awareness of the same disorder among specialties beyond cardiology. And heart failure prevalence is expected to increase by further 15% by 2030. So the prevalence of heart failure, there are at least 8 to 10 million patients right now with 1% adult population with mortality, which is higher compared to the West of 20 to 30%, with the prevalence and the adherence of medication being as low as, if I was to take a figure more supportive of that, it would not be more than 50%. And the prevalence of heart failure, which is 22% below 30 years, it goes up as the patients go on aging, but still this goes on to reflect that only 15% are above 50, which means a lot of our young patients are actually suffering, and this is going to get worse. And the incidence of diabetes in heart failure was almost 54.9%, which means in heart failure, the majority patients still were diabetics. So heart failure patients are at very high risk of sudden death. 9 out of 10 patients are actually asymptomatic. And nearly 1/3 of the patients of heart failure with reduced ejection fraction are at high risk of hospitalization for CV death, including those who appear so-called stable heart failure. So when we look at these subgroup of patients, each heart failure hospitalization will further increase the risk of mortality, which means after one heart failure hospitalization, the median survival was 2.6 years, but which goes down if the second hospitalization takes place to 1.8, then 1.5, 1.3, and then of course the death ensues. So repeated hospitalization is a predictor of bad outcome, and it cut down on the median survival expected or anticipated for these patients. The residual risk of death and heart failure remains following the usage of therapy as a big a gap that further needs to be filled upon. Even if you look at the paradigm HF, which talked about RNI therapies in these patients, and it showed that adding this therapy amounted to adding 2 years of life to these patients from a median survival of 2 years to 5 years. Despite adding RNI, there was a huge residual gap with cumulative probability exceeding almost nearly 3% at the end of 4 to 5 years. So despite these are on the optimal therapies that you've thought of, and that's why the important role emerged for SGLT2. And then there used to be times when, I would be walking into diabetology forum and arguing that SGLT2s belong probably as much to cardiologists as to diabetologists. Now, I think probably this debate would be turned around, and sometimes in future, I hope we don't have to debate that it's actually a diabetes molecule which has been hijacked by cardiologists. So there are a number of potential mechanisms why we talk about this cardiovascular therapy whose glycosuric effect and anti-diabetic properties probably were discovered first as the elephant in the room, and somebody caught hold of the trunk and thought that was purely an anti-diabetic drug. But not only it does reduce preload and afterload and cause volume reduction, but it also improves myocardial energetics, and the cardiac remodeling with improved contractility and benefit in the symptoms are an icing on top of the cake. So SGLT2 inhibitors have emerged in the heart failure with reduced ejection fraction. The first SGLT2 which was approved, including in our own country, and it's now available in more than 40 countries as an approved therapy for reduced ejection fraction. And the trial was, of course, DAPA-HF, which looked at the first heart failure outcome study for the SGLT2 in chronic heart failure, whether the patients had diabetes or not. So some people say you had this trial tilted because it had a lot of diabetes patients, but as I showed you in the Indian registry also, 56% patients are actually diabetic. So to have a different separately 50% plus patients with diabetes was pretty much an important aspect of this trial. So this included patients who were symptomatic with reduced ejection fraction class 2 to 4 for more than 2 months with EF less than 40%, EGFR more than 30, and stable on heart failure reduced ejection fraction with elevated NT-proBNP with or without diabetes, randomized to either dapagliflozin 10 milligrams or the standard care with just 1.5 years of follow-up, looking at the first primary composite endpoint of CV death and heart failure reduced hospitalization. Secondary endpoints were not only the two were separately looked out, but also they looked at the quality life questionnaire by KCCQ, Kansas City questionnaire from the baseline to 8 months, not 18 months. And they also looked at the end of this visit. And also they looked at the renal outcomes, which I believe the subsequent speaker will also touch upon. So the landmark DAPA-HF actually had a median age, which is very much falling like what our patients are. 66-year-old with 3/4 being male. And you can see this had almost 1/4 patients from Asian ethnicity. BMI was 28. The rate of EGFR below 60 was present in 41%. Majority patients were class 2. And you had substantial 33% patients in class 3, with even 1% amounting to class 4, with mean EF of 31%, with median NT-proBNP in the range of 1428 to 1446. 45% were diabetic, 47% had past history of hospitalization, and more than 1/3 were already having atrial fibrillation. Now, the key baseline parameters were pretty much matched when you look at the placebo versus control arm, and patient population was hence reflective of what we see in our daily practices, with including those patients with the majority being non-diabetic, 55% with EGFR more than 30 in most of the patients. So the outcomes were, again, as you can see, the curve started diverging pretty early, and you can see them very significantly emerging, which I will touch upon as to how early you can anticipate the results. But at the end of the study, you had 26% relative risk reduction with an absolute reduction nearly 5%. Very rarely you find therapies where you find 5% absolute risk reduction, amounting to net number to treat being just 21. So you give 21 patients of heart failure this therapy, and you are done with praying to God that you saved one life or one hospitalization by prescribing to 20 patients this therapy. So risk reduction were again greatest in patients with history of heart failure, especially within last 1 year. If you look at the patients who were not having those hospitalization, there the reduction was 2%, but as the number of hospitalizations went up, the benefits were even more dramatic and more significant. The benefit when you look at, once you initiate, when you plot all the events in placebo arm versus the therapeutic arm, the statistically significant value arrives within first 28 days, which means this therapy, if you give for a month, you are done with preventing an event rate, and the hazards ratio goes to half, which is 0.51. So this is another analysis which was published by Sebastian et al. And they found out that the benefits are pretty much significant as early as 1 month of therapy. You cannot think about any other therapy in cardiology which can bring about such small number of patients, bringing down event rates so early, so significant. Individual components, when you compare, whether you look at CV death, that also is statistically significant and reduced by 18 relative risk reduction, 18%, and heart failure hospitalization by 30%. If you look at the all-cause death, even that is reduced by 17%. Again, that is also statistically significant. And I think there is nothing more that matters than life. If you can prevent a therapy, can prevent death from irrespective what mode the patient is dying, I think that therapy has to come as the first line of therapy ahead of many other therapies which you can contemplate in these subgroup of patients. So heart failure, reduced ejection fraction, people previously wondered, was it because of the diabetes management? It wasn't the case. Even if the patients did not have diabetes, actually the results were equally dramatic and significant with absolute reduction of 4.5%, which is like 27% relative risk reduction in non-diabetic versus 25% relative risk reduction in diabetic subgroup. The new onset diabetes is another benefit that you get. So in non-diabetic patients, when you give this therapy, new onset of diabetes is also prevented by 32%. So why not have a therapy that will prevent another anti-diabetic to be introduced later on in these subgroup of patients? So post-hoc analysis also looked at arrhythmic mode of death, and it found out that the ventricular arrhythmias were 33%, resuscitated cardiac arrest was 3%, and sudden death was 64%, with primary outcome of 6.6%. So the composite of this was also reduced by 21%. So as I said, I mean, if you look at the CV mode of death, or you look at sudden death, or you look at the resuscitated deaths, or you look at ventricular arrhythmia, all are significantly reduced. Even if we look at the quality life questionnaire, which looked upon the symptom frequency, severity, functional assessment, social limitation, or quality life, these were also significantly improved. Whether you look at the total symptom score by 2.8 points, clinical summary score by 2.5 points, and overall summary by 2.3 points, all having clinically significant, statistically significant values. So the quality life from the baseline to the end of therapy at 8 months also, not 18 months. Remember, in the ESC talks about increase in KCCQ TSS also improving the subgroup with significant improvement in quality life, which is of high clinical value. So few worsening of renal events. Again, I think my next speaker is going to touch that in detail, but overall the number of events was low. Renal composite endpoint is reduced by 29% with dapagliflozin, and that's why it's renoprotective as well. Now, when you have observed this broad range of effects in heart failure with reduced ejection fraction, apart from the glycemic status, heart failure history, baseline EF, baseline mortality risk, heart failure etiology, all of the subgroup quality life, NT-proBNP improvement, irrespective of the age, blood pressure, renal function, concomitant therapy, it works across the class. You don't have any reason whom to give, not to give. Give it as a blanket to one and all heart failure patients. So it provides clinical benefit in reduced ejection fraction. This is on top of ACE, ARB, and beta blockers. And remember, they were almost more than 10% patients who were already on ARNI. So there's another reason to consider that as well. There is 34% relative risk reduction when this therapy was combined with ACE, ARB, beta blocker as compared to those where it was not prescribed, compared where it was 18%. What about safety tolerability? This is the very important aspect. No cases of Fourier's gangrene, no amputation increased risk, none of the significant serious AEs, which of course was driven primarily by the mortality reduction, but euglycemic ketosis also was not very different. This goes on to talk about how safe it is, especially in the non-diabetic subgroup as well. The doubling of creatinine in DAPA-HF, the CKD worsening was also by 44% in this study. There is no significant risk increase in terms of adverse events as compared to placebo, and overall serious adverse events were significantly lower because of the heart failure hospitalization and mortality being reduced. Genital infections, UTI, did not have any significant differences, because unless you throw glucose out, that's not going to happen, and that's not the mechanism. That's how it's going to probably work in non-diabetic subgroups. So there is low risk of hypertension, UTI, renal events, or even hyperkalemia. And actually, there are papers to tell us that once the patient is on SGLT2, likelihood of getting hyperkalemia is reduced significantly, and there are papers to talk about it. So when you compare various trials, when you look at the paradigm HF or SHIFT, the all-cause death significantly was reduced only in paradigm HF and DAPA HF, which is 0.84 and 0.83. And when you look at the heart failure hospitalization, this is very promisingly looking good in DAPA HF. Emperor reduced when you compare death per se is not significantly reduced, which was actually the case with DAPA HF. Now, one can always debate and talk about the trial designs, but that's not the point of discussion today. I think maybe if Dr. Verma would have a question on that, we can probably discuss that. What about current care now? Now, when you look at the event-free survival when comprehensive management versus conventional therapy, with 8.3 or more event-free survival versus conventional therapy in symptomatic heart failure can be achieved. So this is another important subgroup publication in the Lancet recently in 2020, where they talked about how projected median survival in a 55-year-old male actually improved by 8 years. When you add these therapies, you add 8 years to somebody's life. The traditional heart failure reduced ejection fraction therapies, which talked about ACE, beta blocker, MRA, RNA, and SGLT2, there is a delay because stepwise approach may take up almost 6 months. So how do you can sequence these therapies early? In India, I say we don't even do these 3 steps. Probably most of the patient would end up with all 3 of them in maybe 2 visits rather than 3 visits, because if you were to call them every weekly, probably because of the overburden and the patient's hesitancy, you may not actually be able to achieve that. But it's been proposed by John McMurray's group that in circulation that you can actually go ahead and start with beta blocker and SGLT2 as the first therapy, and then maybe subsequently add an RNA and MRA. The patient profiling with tailoring is an important aspect. If your heart rate is something that you need to target, maybe to keep choosing an ivabradine, maybe a therapy. But otherwise, all across the spectrum, SGLT2 is going to be an important parameter, irrespective of heart rate, CKD, atrial fibrillation, or even EGFR baselines. So initiating in symptomatic patient across a broad group of heart failure, reduced ejection fraction, early initiation as a part of guideline-directed therapy as early as 1 month to 28 days, you'll get it. And it's very easy to use, 10 milligrams, no titration on top of the standard care. So it can be started once tablet immediately without any titration, use with existing therapies, including diuretics. You need to be cautious. You can actually cut down dose of diuretics in elderly. Use the common CV medications like antiplatelet and statins can be given. And if EGFR is more than 30, that's the reason when you can have, because that's where it's proven, though there have been trials to look at patients with EGFR below it. So the new guidelines also talking in ESC 2021, they talk about adding ACE, RNA, beta blocker, MRA, and or on top of that, dapagliflozin and empagliflozin ahead of diuretics. So EF is less than 35, QRS is narrow, ICD is more than 35. You don't have to choose any device, but EF is less than 35 and QRS is wide. You can choose CRT along with ICD. Canadian guidelines also talk about SGLT2, such as dapagliflozin in patients with reduced ejection fraction below 40% and type 2 diabetes. And now they talk about without diabetes also based on this trial. The consensus report from the American College of Cardiology also talks about addition of this therapy in patients with reduced ejection fraction, in improving clinical outcomes, and achieving target or maximally tolerated doses is not necessary before you add an SGLT2. And one should aim at the guideline-directed therapy within 3 to 6 months of diagnosis of heart failure. So the 4 pillars of heart failure is now formed by SGLT2, apart from RNA, beta blockers, and MRA. Thank you very much. Over to you, Chair. Thank you. Thank you very much.
Thank you,
Sir, you're muted.
Thank you, Dr. Kamal, for a nice and lucid presentation. Now we're using SGLT2 for last 3 or 4 years. And all, I think we all well experienced, well happy, well satisfied with this molecule, especially dapagliflozin. Now we have enough science, enough evidences, robust evidences, which is also boost our confidences, especially in the heart failure. So is there any questions from the audiences? Yeah, Dr. Amit, if you want to ask anything. After this, I will ask one personal question to you.
Dr. Amit, you're muted, sir.
Hello. Yeah.
Yes, sir, we can hear you.
Yeah. So, well, it was a wonderful talk and you have spaced it so well. And truly, half of the molecule belongs to you, definitely. And just a word of caution that before initiating, sometimes while initiating the therapy, one should always be cautious about look. It has been, few studies have come up that even the first degree relatives of bladder malignancies, the chances of developing a fresh one is increased. So this is only a word of caution. Of course, nothing to do with heart failure and SGLT2 receptors. So if there
Dr.
are no...
Sharma, can I ask first?
Yeah.
You cleared IPS first civil services. Then why you opted this medical science?
So that I can speak in RSSDI on SGLT2. Oh, so that was where I was doing my MBBS, and then I thought that I should be sticking to cardiology, and I have no regrets. I'm happy. I thought when I'll turn 60, I'll look back in life as to what will make me happy. And those days, cardiology always fascinated me. I choose MBBS because I thought I'll become cardiologist, and I'm glad that I stuck to it. I mean, at least I can count on the one who did not go to that field despite getting it. I mean, I can always vouch as one person who chose to stick to this branch rather than be to services.
Great, great. So it was a nice meeting.
Thank you.
It was nice, yes.
Whether it's a virtual, but it is a nice meeting with you. Sir Ramesh,
thank you.
Please introduce third speaker.
Yeah. So, well, it's a pleasure to introduce Dr. Peter Lynn. And Dr. Peter Lynn began his studies in the Faculty of Science and Engineering at the University of Toronto, Ontario, and midway through, he moved to the Faculty of Medicine, where he completed his studies and became involved in research. And over the years, it became apparent to him that there was a wide chasm between research and clinical practice, and he moved into clinical practice in primary care and eventually into teaching in order to help bridge this gap. And he served as medical director at the Health and Wellness Center, University of Toronto, Scarborough, for 7 years. And currently, he is the director of primary care initiative at the Canadian Heart Research Center. And he lectures and speaks throughout the world and maintains two busy family practices in Toronto. And Dr. Lynn is a consultant for preservatives in cardiology and is on editorial board of the Canadian Review of Alzheimer's Disease and Other Dementias. And he has been the chairman of the Dementia Congress in the US for the last 4 years. And he has also served on editorial board of Primary Medicine, a US company that provides education for physicians. And Dr. Lynn received a teaching award from the College of Family Physicians. One more genius with us. He also switched from the clinical practice to research, just like Dr. Sharma, who's switched from the civil services to medicine. So it's a real pleasure listening to Dr. Lynn. You're welcome. He would be talking about dapagliflozin in CKD, an established option to slow the progression early in the disease setting. So you're welcome, Dr. Lynn.
Thanks very much, Amit. It's good to see you, but unfortunately, it's in a little box that we are doing. Now, let me just try and share my slides here. Okay, I'll get my slides up. So I was asked to talk about prevention in the early stages of disease. So I will touch on the sicker kidneys in DAPA-CKD, but mainly I'll focus in on the mechanism, because I think once we understand the mechanism, then that might be very helpful for us. So I'm going to talk about dapagliflozin, but it's basically SGLT2 class in terms of the medication that we're looking at. These are my conflict of interest. So I've worked with these companies before in education. I don't do any clinical trials and I don't own any patents. So this is your patient with diabetes right here. And really the problem with diabetes are the complications. If we can avoid the complications, then we can, live with diabetes. And that's really what all these new medications are. And that's why you're hearing speakers saying GLP-1 can prevent prevent some of these complications. SGLT2 can prevent these complications like heart failure, renal failure, those kinds of things. So that's really why we're so interested in these categories of medication. This is my simplest slide for nephrology. You know, blood comes in and the urine comes out. And if you look at this, this is basically a vascular organ. So if you look at just the vessels itself, they estimate it's about a 7-mile long blood vessel that's curled up into these little balls called glomeruli. Those are the filters. And here's the blood going into the filter, and here's the blood coming back out. And so this is the filter that is there processing off all of the nutrients and the garbage that we have to get rid of as well. I like this picture. This is a good prostate commercial picture. When we look at the kidneys, we measure EGFR and urine albumin creatinine. Now, not everywhere in the world are people doing this. And the reason why is because I think we don't understand fundamentally what it is. Our patients don't understand what these numbers are. And so we try to explain these numbers to patients. The EGFR is basically the speed of processing. How fast are your kidneys processing in terms of filtering? And so therefore, if that number is above 60 miles an hour, then we tell them that's not bad. But if it's below 60 miles an hour, then their kidneys are not doing well. So then that way they have a reference point as to what we're talking about. Albumin creatinine ratio is really talking about the quality of your filtration. How good is your filter? So let's say this is albumin, this is protein. We want to keep that in our body. And creatinine is a waste product that's generated from muscle breakdown. And so what we're doing is we're saying, how much of the creatinine do you get rid of for the amount of albumin that you get rid of? So if you get rid of no albumin, then that's a good thing. Yet your filter is picking out just the bad things to send out. If on the other hand, you're losing a lot of protein, a lot of albumin, then that's a bad sign. It means that your filter is not good quality. And so therefore, if you have an albumin creatinine ratio that's high, it means you're losing good stuff. And that means the quality of the filter is no good. So that's why the two things give us different information. One is speed and one is quality. And so who cares, about your kidneys? I mean, the nephrologists obviously care, but most of your patients don't. And that's because, just for example, here, this is the dosage adjustments for kidney patients. So all of these medications need dosing adjustment. So if you don't even care about kidneys, if you're a physician, you care about this, because this is the first page. There's about 12 pages of medications that you have to adjust if the kidneys are not working well. The other issue is that the chance of them going on to dialysis is higher if you have bad kidneys. So if you look at here, this is the EGFR going down to 15. So it's going bad in this direction. This is the chance of going on dialysis. And you'll notice that this is not a linear scale. You can see that this is 8,000 times higher than this person at 1. So it's a doubling system that goes up and a quadrupling system. And so what you see here is that if you have normal urine albumin creatinine ratio, so in other words, your filter is good quality, then really, as you expected, as the EGFR comes down, eventually it's going to increase your risk of kidney disease if your filter is slowing down. So if it's a good quality filter, if it's not filtering fast enough, you're going to have trouble as well. What happens if it's a bad quality filter? So you're leaking more protein, the line actually gets shifted upward. And then if it's really bad and you're losing lots of protein, the line gets shifted upward again. So what does this upward shift mean? It means that for the same EGFR, let's say 75, if you have lots of protein leak, then you're 64 times more likely to develop end-stage renal disease compared to the person with good protein. So if you have a bad filter for the exact same EGFR, you're still at much higher risk. And if you look at cardiovascular mortality, we see that upward shift as well. So if you have the same EGFR, but you have bad filtration, you're going to be at higher risk of dying. And the same thing for all-cause mortality, it's shifted upwards. So that's why we look at both EGFR, the speed, as well as the quality of your filtration to decide whether your patients are in trouble or not. Now, can we actually protect kidneys in diabetes? And so this is the filter. You've seen this picture a lot. This is the blood coming in. This is the filter. This is the blood going out. And this is the urine that is coming out here. There's two types of kidney disease in diabetes. One is where the sugar sticks inside here. So the sugar sticking inside will cause clogging up, and that will cause kidneys to begin to fail. Anything that lowers sugar will help with that kind of kidney disease. So GLP-1, DPP-4, metformin, SU, any of those things that lower sugar will help that. The second one is where you have high pressure sitting inside here. So this is a low pressure system. It's meant to be at half systolic. So therefore, if your systolic is 120, you should be running the filter at 60. So anything that opens the pipe to let in pressure will cause increased pressure here and therefore cause damage to the filter. So that second one, which is the pressure phenomenon, the SGLT2 is very good at. So SGLT2 can lower sugar, which fixes the first type of kidney disease, but it also lowers the pressure. And so therefore it can fix the second type of kidney disease. So two types, glucose sticking and then high pressure in the system. I'm going to talk about the high pressure in the system. So this is how it happens. So blood comes in here, filters around, goes out. Glucose is a very small molecule, so all of it gets filtered out. The filter cannot stop glucose because it's so small. So now you have glucose in your urine. You need it back because it's your fuel source. So if I can't stop it with the filter, then I have to give you a pump. So the SGLT1, SGLT2 is a pump to pump back in the glucose. But this is a sodium glucose co-transporter. So for every glucose you bring in, you must bring in a sodium at the same time. This is fine. This is happening in you right now. But in a patient with diabetes, there's lots of sugar going in here. So therefore, there's lots of glucose in the urine. So this pump is going crazy. It's pulling out lots and lots of glucose, which now means it has to pull out lots of sodium at the same time. Now, what happens to the urine sodium? The urine sodium now goes down. So now the amount of sodium is low. And you're thinking, who cares about that? Well, it turns out we have a little police officer that is checking the sodium. And he's checking the sodium to decide, are you making enough urine? So when he sees sodium going down, he's assuming you're not making enough urine. And the most common reason of not making enough urine is you don't have enough flow going into the filter. And he doesn't know anything about this stuff happening. He just thinks there's not enough flow. So therefore, he's going to send a message and open up the pipe. So therefore, you can push in more blood flow and then you'll make more urine. At the same time, it'll squeeze off the out pipe. So therefore, you get more filtration. Now, this is very good if you're in the desert and you're dehydrated. This will keep your kidneys functioning. So it's an adaptation to help you survive if there's low pressure or low hydration. The problem is that with the diabetes patients, they have high sugar all the time. So this is always high. So this is always happening. So this signal is always coming here. And so therefore their kidneys stay in this position every single day, where the pipe coming in is too big and the pipe going out is too small. So let me show it to you this way. This is normal. In a diabetic kidney, the pipe coming in is too big. I just showed you why. And the pipe coming out is too small, which now means you have very high pressure sitting right here. So you get big traffic jam. This is Mumbai traffic jam. So high pressure sitting in here. And what will it do is when you put a lot of pressure on a filter, basically it hyperfiltrates. So that's why when you check kidney disease in diabetes early on, you see a high eGFR. You'll see 130 or something like that. And that's because there's a huge pressure pushing on there. And with that huge pressure, you're going to push out more protein. So that's why in diabetic kidney disease, proteinuria is an early marker where you see the protein leaking out. Whereas in other kidney diseases, that's a late marker of disease. And so therefore, it's the high pressure sitting in there. Eventually, with that pressure, the cells die. And as the cells die, your eGFR begins to fall. And that's diabetic kidney disease. Now, you and I know what to do. We got to reduce the pressure. So what we do is we give an ACE or ARB that opens up the out pipe. And by opening up this pipe, you will lower the pressure here. But as you can see, this pipe is still too big. So no matter how you open this one, you cannot, get rid of all the pressure because the pipe coming in is too large. And so that's why ACE inhibitors and ARB can slow down kidney disease in diabetes, but it can't stop it. And so therefore, how do we close this one? The police officer needs to see sodium. And so if I give you an SGLT2 inhibitor, then basically I stop the glucose from coming out of the urine, which now means the sodium is no longer coming out either. So now the amount of urine sodium is correct, or at least enough. And the police officer now says we can go back to normal. So he sends back a signal, close the pipe down to normal. Now notice this isn't constriction to nothing, it's closing it back to normal. And therefore you have good blood flow going in here, hence no AKI risk in terms of prerenal failure. And so now you have normal pressure sitting in the filter, which means normal filtration. There's going to be less proteinuria. And of course, we're hoping that there's less renal cell damage and your eGFR may not fall so quickly. And so can we show this in a study? So this is eGFR. This is over a 4-year period. I want you to follow the black line. The black line are the people on an ACE or ARB. They've opened the out pipe. So therefore, the pressure is going to be lower, and therefore, you're going to have some benefit. But you'll notice the in pipe is still too big, and so therefore, the kidneys continue to deteriorate. Now, don't get me wrong. If we didn't give the ACE or ARB, it would be worse, right? The deterioration would be even worse. So it is helpful, but it can't stop it. Now, if I give you an SGLT2 inhibitor and close the in pipe, Now what we can see is that it's more stable. It is still going down, but not as fast. And you can imagine if this slope is even a little bit turned, basically your risk of going to dialysis has now been stretched out for years. And so therefore, this is a very good strategy. And that's why the nephrologists are very excited. You heard our cardiologists excited about heart failure. You now have nephrologists excited because this is in addition to an ACE or ARB strategy. So ACE or ARB opens the outpipe, the SGLT2 brings back to normal the inpipe, and that's how you reduce the pressure inside the filter. Now, DAPA-CKD was looking at people with eGFRs down to 25. Now, the reason why I say that is because we were told don't use these things below 45 eGFR, and that was never a safety issue. It was always because the kidneys were no longer filtering out sugar. So therefore, below 45, your A1C can't drop that 0.5% that's necessary for the government to say that you are a diabetes drug. And so that's why the government's all said below 45, you're not really filtering sugar anymore. So therefore, you're not a diabetes drug. We shouldn't be using it for diabetes. As you can see now, we're not using it for diabetes. We're using it to control the flow inside the filter. And so DAPA-CKD was a beautiful study where they looked at people down to eGFR of 25, and they said, what happens to these people? And what you see here is that these are the outcomes. So the first primary outcome is renal as well as cardiovascular death. And then the rest of them are breaking them apart, CV death and renal, total death, that kind of thing, mix and match. And you can see all of them are extremely positive. And look at all-cause mortality. This is reduced by 31%. Now, these are quite sick people, and yet you can reduce their death by 31%. Statins, you know how we love statins? In a renal population, like really sick kidneys, like dialysis levels, you cannot change the outcome. And yet here we have fairly sick kidneys, and yet we're able to change the outcome for these people. The interesting thing is that whether you had diabetes or not, you had that benefit. So this study enrolled people with diabetes and without diabetes, just like DAPA-HF had diabetes and no diabetes people. And so how do we explain the benefit here? Clearly, it's not the glucose. But you remember my slides before, it was all about sodium management. So these are SGLT2, sodium glucose co-transporters. So it's managing both glucose and sodium. And it may very well be it's the management of the sodium that is giving you the benefits in these people without diabetes. In fact, it may be the management of sodium that's giving you the benefit in people with diabetes, because whether the A1C comes down or not, they seem to have these benefits as if you go and subdivide the patients, whether they had good results from their A1C or not in these trials. Now, why is it in non-diabetes they're helpful? Well, let's say you have damaged kidneys from IgA nephropathy. The nephrologists are very excited because we don't have good treatment there. So let's say you have nephrons that are now dropped off. So let's say you've lost 50% of them. What will your body do? Your body will then direct the work to the remaining nephrons that are okay. And the way it directs the work, it dilates the pipe. The pipe going in gets big, and now you send blood into those filters. We now just increase the pressure, and now you're going to damage and kill those ones off. It's kind of like if, let's say, one of your colleagues is sick with COVID, you have to look after all those patients, and now that's going to burn you out. So by giving an SGLT2 in that situation, we allow more sodium to go to that police officer. And that police officer will do the same thing. If it sees more sodium, it says you're making enough urine, it will send back a signal to close that pipe back down. And by closing that pipe back down, you now reduce the pressure in the filter. And therefore now the filter can last much longer. Just like if you had to work only 8 hours a day, you would last much longer as well. And so therefore it can protect those kidneys as well. And that's why in people without diabetes, we are still seeing very good benefits. And that's why the nephrologists for IgA nephropathy, they've never had a study this big with IgA nephropathy. That's the main one that is the non-diabetes kidney people that they're looking at. Polycystic kidneys, it's a different system. So therefore those people were excluded. It's a different mechanism of how the damage comes. It's physical pressure and so on and so forth. So that's why now we have exciting stories for our patients with diabetes. They can have benefit. Without diabetes, you're going to see people using these medications as well. SGLT2 or a DPP4, because we're very comfortable with DPP4. And if they both control sugar well, is there one better than the other? And we can't do a study, head-to-head studies is very difficult, right? You have to have 40,000 people. And so what they did is they said, let's go into the real world database. So in the CVD Real Nordic, the Nordic country says we have about 1 million people that were started on medication. So let's go look at those people and let's compare dapagliflozin versus DPP-4. So what they did was they looked at the people taking dapagliflozin or DPP-4, and then they matched them together to make sure their age and disease process and all those things are the same. The only difference is dapagliflozin versus DPP-4. And they were able to collect 10,000 people and match them to 30,000 people on DPP-4. Why is this number so high? We have 3 good DPP-4 inhibitors. So this gives each one an opportunity to win. So each one can have 10,000 patients, and therefore it's equal footing in terms of ability to win. So it's really 1 versus 3. You have 3 competitors here. And what did they find? This thing, HKD, you know, when I first saw this HK, I thought it was Hong Kong dollar. It's not Hong Kong dollar. It's hospitalization for kidney disease. And so therefore, if you look at dapagliflozin versus DPP-4 right here, you can see a 62% reduction in kidney disease hospitalization. We didn't know this. These were just patients taking it just for diabetes. So they weren't special, you know, kidney failure patients. These are just normal people taking these drugs. And what we found is that there's a huge reduction in hospitalization for kidney disease, which means that mechanism that I just explained to you was happening in the real world. It's just we went and looked and we saw that the benefit was already there that we were thinking about. In fact, there were other benefits. So if you look at heart failure, MACE, death benefits, is there a difference between these 2 agents? And what you see here for MACE, it's reduction of 21% in favor of dapagliflozin over the DPP-4. And if you look at heart failure hospitalization, 38% reduction in favor of dapagliflozin, and all-cause mortality is reduced by 41%. So that's why I tell my students, you know, if it's your mother, like which one would you use? You know, this one takes an extra minute to explain if you get sick, you should stop the medications, stay hydrated, you know, simple stuff. If it's your mother-in-law, it's a different story, right? Then we can just give whatever you want to give, but certainly you can think about this. Can we protect good kidneys? And here it's very important because we don't have a study with good kidneys, because you can't start a drug on a patient with good kidneys and see if there's any benefit. But in the DECLARE study, you'll remember, first of all, it had 10,000 people that were primary prevention. You know how we were talking about REWIND being a big study on primary prevention? The whole study of REWIND, all of them, was 9,900 patients. In DECLARE, just the primary prevention group was 10,000. So you can see that that's a huge population. And the FDA had a rule that they had to enroll people with EGFR above 60. So therefore, normal kidneys. And the baseline EGFR was 85 in the whole study. So very good looking kidneys. And so by accident, we now have a study in healthy kidneys and what happens. And these are the outcomes that they looked at. EGFR has to fall 40% and go below 60 for it to count, or you have to have dialysis or renal death. And in the patients on dapagliflozin, you can see here, there was a 47% reduction in this outcome, mainly driven by the EGFR. So think of it this way, people taking dapagliflozin, the flow was correct in the filter, so their kidneys don't deteriorate much. The people not on it deteriorate, and that's why you have this big difference. So therefore, if we give these drugs early, we can protect good kidneys. And that's really what we learned from the DECLARE study, renal sub-study, which is dapagliflozin in good kidneys. You can actually have that protection and keep that EGFR nice and healthy. What about proteinuria? In the study, there were people with either normal or small amounts of protein going into large amounts of protein. But the people that progressed this way, 46% less if they were on the dapagliflozin side. And then there were people that got better. And in terms of the dapagliflozin side, 82% more people got better in terms of their proteinuria. So both the EGFR and the proteinuria went in the right direction. And so therefore, we look at this thing, now we have the heart, you see, with the heart failure, and then you have the kidney sitting here. Who's interested? Everybody's interested now in this category of medication, including the patients, because the patients don't want to have renal failure or heart failure. And now we have a single agent that controls sugar and gives you these extra benefits as well. Now, somebody's going to ask me about the types of drugs that we have and how do you think about it? This table I made up, so there's no reference for this. So how many of them have a MACE outcome, heart attack, stroke, or death? And so here are the studies that we have that are positive. So metformin had reduction of MI, and of course, SGLT2 and GLP-1. If you look at heart failure, it's just SGLT2 that had to have the significance, and kidney disease, it's only this one in terms of the good solid outcomes. We know that there's some data coming from GLP-1. We may be able to put a plus there as well in the future. And so therefore, SGLT2 now becomes the darling of the guidelines people. And you could see that SGLT2 metformin combination would be a good one as well. And that's why you're hearing about combination therapies in that way. Which one should you choose? And this one is up to you, right? You're all comfortable with the different gliflozins. The way I look at it is, do they have any death benefit in any study that they've ever done? Do they have death benefit? And they all do. So therefore, you can be confident that there's a death reduction just depending on the patient type population. In heart failure hospitalization, I'm going to divide it into two types of people. Secondary prevention people, you already have disease, heart attack, stroke, you have heart failure, you have renal failure, any of those kinds of people. In that group of people, we have positive results for all of them. In the primary prevention, meaning you don't have anything, no heart failure, no heart attack, no stroke, no renal failure to begin with, the only one that we have good data is dapagliflozin with that 10,000 people in primary prevention mode. In the CKD, I'll do the same thing. People that have some sort of disease, either kidney disease, heart failure, heart attack. In other words, they already have disease, there is good data. In people that do not have existing disease, no kidney disease, no heart attack, no heart failure, the only one that we have data with is the dapagliflozin. So therefore, you can see that perhaps if we're treating the primary prevention patient, maybe this would be useful. So even if they don't have heart failure or kidney failure, we can prevent those things from happening. And that would be a good thing that we can do for our patients. And so I showed my patients this picture. So would you like to be this lady, or would you like to be this lady? Both of them are 74 years old. Okay, it's up to you to decide. So if we take good care of you and we use these agents early, then we will be able to prevent all these complications of renal failure, heart failure, and those kinds of things that we're seeing. Anyway, thank you very much for your time, and thank you for staying awake for my little ramble, and I'll turn things back to Amit.
Thank you, Dr. for wonderful presentation. You choose wonderful photos, wonderful your experience, and it is very surprising to me. You switched from engineering background to the medical. That's so very surprising, and it is not looking by your speech that you did lots of justification with your talk and subject. So
Oh, I think we've lost his video. Amit, are you still there? You might be muted.
Yeah.
Okay, there we go. I think we just lost his video. The internet, maybe it's too many people.
Yes.
Too much
It was a
excitement.
wonderful.
Thank you.
Wonderful talk. Of course, I was focusing on the technical aspects. I was focusing on the technical aspects that you gave, but more so on your skills of teaching. You know, you're an excellent teacher, wonderful
Thank
teacher.
you. I appreciate that. I appreciate that.
So easy for your students. That's really great. Yeah.
Thank you. Well, I'm hoping that if people understand how these drugs work, then they'll feel good to use them, because there's a lot of people that need
Believe me,
it.
it was a wonderful show. Yes. So it was a wonderful presentation. Let me see if there is anything in the chat box, and I don't find. So I think all the questions are already answered. So there are no more questions in the chat box, right?
That's very good. Well, thank you very much for the opportunity.
So
It's
if there
always
are
a
any
pleasure.
questions, yeah. And well, it would be a pleasure to invite you for a CDIFCon. We have got a Southeast Asian Diabetes Foundation. So it would be a pleasure inviting you there also. You're a wonderful orator.
It would be my pleasure. It would be my pleasure. Thank you very much for the opportunity.
Hi,
Sanjay. You're muted.
Hello, hi, how are you?
Good. How are you?
Great. How are you doing, Peter?
I like to see your background. This is nice. With this social distancing, I get to see your homes, which is fantastic.
Yeah.
I think this is great. Beautiful paintings and everything else. This is your office? This is office. This office
This
or
is my
home?
study, yes. My
Oh,
study.
your study.
Yes.
Looks
How
good.
are
It
you,
looks
Peter?
good.
Good to see you.
Yeah, good to see you. See, normally we see you at a meeting. We don't see your home, right? This is very good.
Absolutely. Absolutely. Wonderful.
Well, thank you very much. It's a pleasure. Thank you for the invitation. I appreciate it.
Thank you so much for being part of this meeting. I mean, your thoughts are always well received and people love to hear you.
Thank you very much. I appreciate that. So it was well worth it. I was thinking about pictures for you guys. Which one would be the best pictures?
So thank Dr. Peter. I really enjoyed your talk. The way you put your thoughts through is fabulous. Just wanted to share this
Thank
along with my name. And I think Dr. Sanjay, the other Sanjay agrees with me.
Thank you. Thank you very much. I appreciate that. I really do appreciate that.
Yeah.
Well, you guys have a very good meeting. You know, I took a look at the schedule. It's you want to attend so many different halls and you know, because the topics are really good. So it's a beautiful meeting that you guys have put together. I think that's very impressive. I hope that people understand the amount of work that goes into putting something like this together. And I hope that we show our appreciation to you all in terms of organizing.
Thank you very much, Peter. I know you spend a lot of sleepless nights getting topics together, speakers together, and getting the flow right, you know, because you may have a lot of topics, but then if you don't have the flow right, it can be, you know, a very disjointed program that we're looking at. So it was very important to have the flow right of all the subtopics. And of course, we have incredible speakers like you.
Thank you very much. I appreciate that.
Thank you so
Very
much.
good.
Thank you.
All right. You take care then. Everybody stay
Thank
safe.
you.
And
Thank you.
we'll see you next time again. Thank you very much. You take care.
Thank you
Okay,
so
bye-bye.
much. Thank you.
Thank you.
I think we have some time before we start. We have another 5 minutes before we
5
start.
minutes. Yeah,
Yes.
but I haven't seen Kamlesh and Dr. Kamlesh Kunti and Dr. Chandalia join in.
Yeah. Both of them have not logged in as yet.
So
Need to find out
somebody from RX Events is here. Can you please check?
There is somebody from.
I know I can see blanked out too, but
Yes, I can contact you.
I don't think Dr. Kunti still yet joined in, right? No, I don't see him.
Sir, Dr. Kamlesh Khunti can't be here, so he has sent a video. I'll play it over.
Yeah, so can you play the video of Dr. Kunti and I can introduce him right away?
Just give me some minutes.
I think Dr. Kamlesh cannot be with us, and we take the first topic, that's simplifying type 2 diabetes management to improve outcomes. There's a video recording of his talk, which shall be played by now RX Events. I asked Sanjay to make his comments, and then request RX to move ahead with the.
Can I have the introductory slide of Dr. Kunti?
Vinit, can we have Dr. Kamlesh Kunti's introductory slide, please?
Yes, sir.
Is the video ready to play? Stuti, can you get me the introductory slide of Dr. Kamlesh Kunti? And is the video...
Introduction slide. I'm just sharing his recording.
Yes, sure. Can I have the introductory slide? Yes. Is the recording ready for me to... Okay. It gives me a great pleasure to introduce a wonderful speaker who's done exemplary work. His topic today for the meeting is going to be simplifying type 2 diabetes management to improve outcomes. Dr. Kamlesh Kunti has been part of the RSSDI meetings for many years, and every year it's a pleasure to hear him, and we always learn something new from him. Dr. Kunti is a professor of primary care diabetes and vascular medicine at the University of Leicester in UK. He's the co-director of the Leicester Diabetes Center and leads a research group that is currently working on the early identification of and interventions with people who have diabetes or at increased risk of developing diabetes. His work has influenced national and international guidelines on the screening and management of people with diabetes. He's also the director of the UK National Institute for Health Research, Collaboration for Leadership in Applied Health Research and Care Midlands, and director of the Real World Evidence Unit. He is a NIHR senior investigator and principal investigator on several major national and international studies. He has published over 500 articles. He is a fellow of the Academy of Medical Sciences and is currently an advisor to the Department of Health, a clinical advisor for the National Institute for Health and Care Excellence, and secretary of the Primary Care Group of the European Association. He's the past chair of the Department of Health, the RCGP Committee on Classification of Diabetes, and is the past chair on NICE Guidelines on Prevention of Diabetes. He's a co-director of the Diabetes MSc at the Leicester University, and he has won numerous awards nationally and internationally. So with such a luminary speaker, I think we would love to hear his talk without much time loss. So over to Stuti to give us the video presentation of Dr. Kamlesh Kunti.
Hello, thank you very much for those kind introductions. Again, really sorry I can't be at the RSSDI meeting in India, one of my favorite destinations, as I keep saying. But I hope the conference is going well. And again, thank you very much to Bansi and the team for this kind introduction and inviting me to present again. So today I'm going to be talking about simplifying type 2 diabetes management to improve outcomes, really doing simple things well. These are my disclosures. So the next few minutes I'm going to go through the background, the evidence and guideline recommendations, the efficacy to effectiveness gap as in why we're not getting to the targets that we are supposed to be doing, and some pragmatic solutions how we can get to those targets. So in terms of background, there are a number of strategies for interventions which are public health approaches, particularly in prevention and management of diabetes. So we have the upstream public health policies that the government do, tax incentives, etc., national health insurance for prevention of diabetes. Then the midstream, where there are a number of preventative strategies at individual level, which I'll briefly talk about. But finally, once people have developed the disease, in this case diabetes, the secondary prevention strategies including lifestyle interventions and tight glycemic control. In terms of prevention of diabetes, there is overwhelming evidence that those who have or are at risk of diabetes, people with prediabetes, we can prevent diabetes with lifestyle interventions, a 50% relative risk reduction from the meta-analysis that we conducted a few years back. And as you can see, no matter which country the patient population comes from, including the fantastic studies done in India with Ramachandran, that we can prevent diabetes. There's a number of other therapies, diabetes agents and anti-obesity therapies that have shown to improve outcomes. The one particular one that is promoted in the UK and many other countries is metformin for prevention of diabetes. And prevention is important because we can improve outcomes. So this is the Da-Ching study. The long-term follow-up at 20 years showed that there was a 47% relative risk reduction in incidence of severe retinopathy in those who went through the lifestyle intervention and who had prediabetes. Similarly, from the same study, 23-year follow-up showed that those who had prediabetes, there was delayed onset of diabetes associated with significantly lower cardiovascular mortality in favor of those who had the lifestyle intervention. And as you know, the study was completed early on, but the separation occurred at 12 years. And you can see at 23 years, a significant, about 41% relative risk reduction for cardiovascular mortality. The so-called legacy benefits of prevention. So we really want to try and do our best to prevent the diabetes coming on. Once diabetes has come on, we want to use strategies to reduce and improve their outcomes. And there's now good data from, this is US, and this is study from the Sweden, showing that overall we have improved outcomes for people with diabetes. So death from any cause, death from cardiovascular disease, death from coronary heart disease, and hospitalization from cardiovascular disease have improved significantly over the years. However, the gap between people with type 2 diabetes and those matched controls at population level still remains. So still a far way to go. In terms of the guidelines and the recommendations, they're based on randomized controlled trials. So these are all the glucose lowering trials, UKPDS, Accord, Advance, and VDT that you all know about in people with type 2 diabetes, showed that early tight control leads to improved microvascular outcomes. And if we start early enough, such as UKPDS from diagnosis, we can have cardiovascular disease and mortality benefits as well. The DCCT in people with type 1 diabetes also showed similarly that we can reduce microvascular outcomes in the short term with tight glycemic control, and cardiovascular disease and microvascular outcomes and the long-term follow-up as well. So overwhelming evidence for improving outcomes with glycemic control. And this is the UKPDS study. As you know, these were patients newly diagnosed with diabetes in a conventional arm compared to metformin arm. The metformin arm was associated with improved outcomes when the trial was completed in 1997. But the long-term follow-up for 10 years in 2007 showed that the differences in HbA1c, although they were lost after the trial completed because clinicians started acting on the trial results and HbA1c was similar over the long-term follow-up, there was still benefits of that early tight control with reductions in microvascular complications, 15% significant reduction in myocardial infarction, and a 13% reduction in all-cause mortality. And the UKPDS termed this the so-called legacy benefits. The legacy benefits don't only hold for glycemic control. Legacy benefits hold for a number of risk factor control in people with type 2 diabetes in terms of beneficial effects on cardiovascular outcomes and mortality. So there are data from glucose lowering, such as the UKPDS, blood pressure lowering up to 10 years of legacy benefits, lipid lowering up to 18 years of benefits, and multiple risk factor control up to 21 years of data from the STENO-2 study. So guidelines now are more evidence-based. We know glycemic control is important in people with diabetes, but we've got now a lot more data, and for the first time we can have evidence-based recommendations, which are on the left-hand panel. People with established atherosclerotic cardiovascular disease or CKD or heart failure, we can improve outcomes by using GLP-1 receptor agonists and SGLT2 inhibitors. And in the yellow, if we want to reduce the risk of hypoglycemia, then we need to use therapies that have a low risk, and avoiding therapies such as sulfonylurea, where we want to minimize weight gain or promote weight loss. Then again, a strategy of using GLP-1 receptor agonists or SGLT2 inhibitors. And where cost is an issue, sulfonylureas and TZDs are the preferred option. But if we look at in the red box, eventually, if we target early enough, majority of the patients will require basal insulin, which doesn't seem to be happening currently. The most important for me on this is, as I've said before, is the blue circle on the right-hand top, which tells us that to avoid clinical inertia, we need to reassess and modify therapy regularly. And this means within 3 to 6 months. So now we have good evidence. We have excellent randomized controlled trials showing improved outcomes, but this doesn't seem to be translating into clinical practice. And this is what's called the efficacy to effectiveness gap. And there are a number of reasons for this. The key areas that I want to concentrate on are therapeutic inertia, hypoglycemia, and medication adherence. So if you look at trends in diabetes treatment and control, this is data from the US, very recent publication this year in the New England Journal of Medicine, is we really haven't improved glycemic control. As you can see in the top left-hand corner, HbA1c is around 50% in those achieving a target of less than 7%. And this really hasn't changed over the years from 1999. If we look at blood pressure control, tight blood pressure control less than 130 over 80, there's been some improvements. Lipid control, there's been some improvements. And all the 3 risk factor controls, we're only achieving 22% of patients with that target, which has improved a little, mainly driven by improved lipid control. So despite having excellent therapies, despite having excellent guidelines, we are not really improving outcomes. And one of the reasons is therapeutic inertia, which is a major issue in clinical practice. We've defined therapeutic inertia as failure to advance therapy or to de-intensify therapy when appropriate to do so. And therapeutic inertia is present throughout the treatment paradigm, although previously we used to think it was mainly when we initiated insulin or when we started intensifying people on insulin. But overwhelming data that is present throughout. Just to give you a recent example, this is a large prospective study we have been conducting. 37 countries, more than 15,000 participants, the largest prospective study, observational prospective study of people initiating second-line therapies. And we now have 3-year follow-up data, the so-called DISCOVER study. And as you can see, overall, the mean HbA1c was 8.3% when we initiate second-line therapies. Far longer that we're leaving people in hyperglycemia. And the commonest therapies initiated are second-line therapy are metformin with sulfonylurea and metformin with a DPP-4 inhibitor, as you can see. SGLT2 inhibitors are not used, and there may be a number of reasons for this. And when they are used, they're not used in the right populations as defined by the guidelines that I mentioned earlier. So people with atherosclerotic cardiovascular disease or heart failure or CKD are the ones who are not getting these therapies. And when we bring all the data together, this is a meta-analysis of over 50 studies, we see that therapeutic inertia is a global phenomenon. Whether we initiate first-line, second-line therapies, or going on to basal insulin, we're waiting far too long, anything from 2 to 7 years. in intensifying with these therapies. And the consequences of therapeutic inertia, which I've discussed at previous meetings in India, is it's associated with worse microvascular outcomes, worse cardiovascular outcomes, and increased mortality. And there's overwhelming evidence from very large observational studies for this. The other reason for not reaching the targets is hypoglycemia. We know hypoglycemia is a major problem. This is a study we conducted with Francesco Zaccardi in our group, looking at all admissions in English hospitals, the whole of England. And what we see is a few observations. First of all, at the left-hand side, these are people with type 1 diabetes. The number of admissions hasn't changed despite us having better therapies and also having monitoring systems and devices for improving insulin delivery. And then we see that there's an exponential rise from the age of around 50. And we see a few observations here that the rise continues. It's quite severe in people who are aged over 70. And the question is, why are we managing these patients so aggressively that they're getting hypoglycemia? And secondly, despite having excellent therapies, we really haven't improved outcomes over the last 5 years at all. So a number of questions that are raised from this study. When we look at globally, this is the HAT study that we conducted, including India as one of the countries that was included in this study. So HAT was one of the largest studies of a prospective study looking at people who had been on basal insulin. Globally, over 18,000 people were recruited to this study from 24 countries. And the uniqueness about HAT study was we had a prospective arm in this where we asked patients to keep a diary, and inclusion criteria were very broad, people aged more than 18 years on insulin for more than 12 months. And what we saw was that overall 46% of people reported hypoglycemia. When we look at the estimated annual rate, this is per person per year overall, they varied from about 14 to 28 per person per year. Nocturnal hypoglycemia varied from 3 to 6.4, so twice as many in some countries. And when we look at severe hypoglycemia, they were around 2.5 per person per year, but much higher in Southeast Asia, 3.4 per person per year. So there are overall large numbers of people having hypoglycemia when we look at them globally, and the rates vary enormously. And again, this may be because of the individual level, patient level, or system level barriers for not overcoming hypoglycemia. When we look at data overall, that hypoglycemia rates are low in people on metformin, sulfonylurea, and incretin-based therapies. This is a prospective study we conducted over a 12-month period where patients collected diaries. So most of the hypoglycemia are in people with insulin. We see about a rate of 1 person per year incidence. This is a definition of symptomatic blood glucose of less than 54 milligrams per deciliter. But as you can see, sulfonylureas, overall the rates are low when we use the correct sulfonylureas, and we use glycoside mainly, which is a better profile. But we need to ask patients about hypoglycemia. If we don't ask them, we will never find out whether they're getting hypoglycemia. And then the consequences of hypoglycemia, as you know, reduced dosing of their therapies, especially insulin. They see healthcare professionals more often. They skip meals, skip their injections. And this was seen in the HAT study. So what we see here is the rates in type 1 and type 2 in the left-hand side prospective study of estimated episodes per person per year. So 73 per person per year on insulin overall, nocturnal about 11 per person a year with type 1 diabetes, and severe 5. For type 2 diabetes, much lower rates as one would expect. But on the right-hand side, we look at the prospective and the retrospective data for both type 1 and type 2 diabetes. And here we're just sharing with you the data for severe hypoglycemia. When we ask patients, we see over double the rates compared to when we get diaries and ask about them, we get double the rates. But when we just ask about them if they had it, we see that we have a lot less hypoglycemia rates. So getting people to keep a diary is more likely to get a better estimate of hypoglycemia rates. Finally, medication adherence, important issue. This is data from Pankaj Gupta, who is the first one to develop a urine assay for an objective measure of adherence. And what we see here is overall adherence rates are low for GLP-1 receptor agonists and statins, but for sulfonylurea is about 80% adherence. And non-adherence overall was present in about 30% for oral hypoglycemic, antihypertensive, and lipid-lowering agents. And what we see is those who were adherent, who were non-adherent, had worse HbA1c, albumin-creatinine ratio, and lipid profile, the multiple risk factors that I mentioned earlier that we need to control. And non-adherence is associated with worse outcomes. So this is a meta-analysis of 8 observational studies. People who are adherent have about a 28% reduction in hospitalization and about a 10% significant reduction in mortality. So adherence is very, very important to inquire about and manage. Finally, overcoming these barriers, some of the pragmatic solutions and looking at the evidence base. There are a number of factors that lead to the efficacy to effectiveness gap, including hypoglycemia, impaired quality of life, lack of adherence, as I mentioned, financial restrictions, risk of comorbidities, regimes being complex, the weight gain that may be associated with the therapies. And all of these are barriers for patients and healthcare professionals as well. Intervention to overcome therapeutic inertia. This is the most recent and the only systematic review of interventions to overcome inertia, 36 studies with over 22,000 participants. And what we see here is the interventions that work well are pharmacist-based interventions. We get a 0.6% reduction in mean HbA1c, and nurse or certified educators, where we see a 0.4% reduction in HbA1c. We don't see improvements with care management and patient education alone, or particularly the physician-based intervention. So we really need to invest in nurses and pharmacists to manage these complex patients, because they will have time to manage these patients. We do that in the UK now more and more often. Multifaceted approaches to interventions to improve adherence lead to better outcomes. As you can see, this is a systematic review we conducted, and at the top we see multifaceted intervention, twofold increase of ratios for improving adherence, where single-faceted interventions about a 50% increase in adherence. So multifaceted interventions for improving adherence. And finally, education programs looking at improving hypoglycemia. This is a randomized controlled trial of patients with a STENO2-like population, microalbuminuria, and type 2 diabetes. At the end of 18 months, we had a 0.5% reduction in HbA1c in the intervention group, who had a multifactorial intervention. But what we saw was this was reduced hypoglycemia in those who had the intervention, despite having HbA1c reductions of 0.5%. And many of these patients had to go on to insulin. And we saw no severe hypoglycemia intervention group and reduced moderate hypoglycemia. And this was mainly because all these patients had education how to recognize hypoglycemia and how to overcome hypoglycememia. Finally, not treating patients too aggressively. As I mentioned, therapeutic inertia is also failure to de-intensify therapy when appropriate to do so. And this is what's called quaternary prevention, intervention that protect a group of risk of over-medicalization. And we see this time and time again. This is a study we conducted recently on patients aged more than 70 years and more than 75 and 80 years, as you can see, and 85 years. And these patients had an HbA1c values less than 7%, while on insulin or sulfonylurea. And what we see is at 5 years and 10 years, there was increased association for hospitalization for severe hypoglycemia, but no differences in mortality. So hypoglycemia, a big risk when HbA1c is low with certain therapies. And we've looked at de-intensification, systematic review here with some Sadie in our group, showing that you can de-intensify people with no deterioration in HbA1c, hypoglycemic episodes, falls, or hospitalization on de-intensification, and no significant differences in adverse outcomes. So in summary, we know type 2 diabetes is a progressive disease, and early prevention, both in people with pre-diabetes and those with early diabetes, leads to long-term benefits. However, there is a major efficacy to effectiveness gap in the real-world settings, and there are many barriers that stop us translating evidence into improving outcomes. And different solutions are needed in different settings to individualize therapies and interventions. And I really like this quote from Vincent Gamport, which I'll leave you with: doing little things well in a step toward doing big things better. Thank you very much for listening.
Yeah, we thank Dr. Kamalesh Kunti for the presentation, and I don't think he's there with us for any questions, but it was a wonderful session on trying to look at, with all the therapeutic options available to us, we're still not reaching our goals, and therapeutic inertia is one of the major, one of the factors which need to be considered. And also, other thing which was pointed out was reducing therapy when it was necessary. So with this, we go on to the next talk. I see Dr. Chandaliya. Can I have Dr. Chandaliya's introduction? It's an honor and pleasure to introduce Dr. H.P. Chandaliya. For me, is the topic which he's going to speak today is minimizing hypoglycemia in insulin therapy. So he's director, he's patron of RSSDI and the past president of RSSDI. He's been one of the, he's been at the RSSDI from its inception. He's director endocrinology, diabetes and metabolism at Jaslok Hospitals, Mumbai, and also the Diabetes Endocrine Nutrition Management and Research Center, Mumbai. Past president and patron RSSDI. Faculty, University of Alabama Medical Center, Birmingham in the 70s. Faculty at Grant Medical College, 70s to 2000. He has 75 original articles, reviews in scientific journals, 20 authorships, editorships, or contribution to books. Editor, International Journal of Diabetes in Developing Countries. Editor, Diabetes Today since 1991. Editor-in-Chief, RSSDI Textbook of Medicine, 3rd edition. So welcome. It's an honor to be listening to you. For all of those who are listening to you today, it's not. I think you have lived across all the genre of insulins, and I don't think anybody better than you in the country to talk about how to use it appropriately. Over to you, sir.
Thank you, Dr. Sanjay Reddy, for this introduction. And I will be discussing a topic which is intensely clinical. In fact, it touches upon day-to-day practice, which often the talks do have some application, but here it is direct application because I'm still in practice, so I think of a topic like this. So this is the outline of my talk. You see, insulin therapy is always associated with hypoglycemia. A little bit I will talk about dangers of hypoglycemia and how does hypoglycemia arise? What is the genesis of this? How can you minimize it? And then we discuss some special situations. So hypoglycemia with insulin therapy is always a lurking fear. For example, when you intensify any therapy, like here you see data of UKPDS, insulin therapy, you see, and you find the hypoglycemia there, and of course, in the intensive group, you will be surprised, the hypoglycemia was 3 times. So here you see, for example, in the standard treatment versus intensive in DCCT, and it is 3 times more hypoglycemia in the intensive group. So whenever we intensify treatment, in order to achieve better glycemic goals, you will be facing this problem of hypoglycemia. So how to that is the key to success of our medical therapy, especially insulin therapy. So standard versus intensive you saw here, and of course sulfonylurea and insulin are the prime culprits, but also the glycides also be careful. So these are the 3 group of drugs which are more likely to produce. So when you combine them also, you'll have to be cautious. is the main barrier in getting effective glycemic control, and it really is overcoming hypoglycemia is the key. Most doctors hesitate to start. Most patients hesitate. They heard about bad hypoglycemic episode from some peer group in some peer group, then they would not like to go on insulin. So this is the major barrier to successful insulin therapy. And therefore, we have to learn to overcome it. And this is what I'm going to discuss. Dangers of hypoglycemia, I don't need to expand, but give a few new aspects. Remember that hypoglycemia is invariably associated. You see, of course, intensive treatment, it is more, but invariably associated also with weight gain. They go hand in hand. It is assumed that a patient undertakes defensive eating when there is an episode of hypoglycemia. But I have a feeling that it is not all the story. As a matter of fact, it does make far more lipid synthesis or whatever it does, and there is really weight gain, which without even much defensive eating. And of course, the we hesitate to discuss that very bad recurrent hypoglycemia can result in cognitive impairment. You know, we don't ever tell our patients who get hypoglycemia. A repeated one, you can see the hazard ratio for dementia, I see increases. So this is something we don't discuss often. It can result into increased QTc and lowering of potassium and throw an arrhythmia at night. A nocturnal arrhythmia and that in bad syndrome in diabetes, you see, is not been described by many investigators, but it is felt that it is arrhythmia, then it is undisturbed bad. And if it is hypoglycemia, it is still disturbed bad. So that in bad with disturbed bad and undisturbed bad, you see hypoglycemia or hypoglycemia resulting into a cardiac event. And that is mostly arrhythmia because of potassium shift and causing, you see, death. And then this can occur mostly. So cardiovascular complication, hypoglycemia can paralyze your barrow reflex sensitivity. You see, so that when you give anesthesia to a diabetic, and we control diabetes during the perioperative period, we are called upon to do that as physicians. And if there is hypoglycemia, the anesthetist is that scared because even the autonomic failure comes. It causes acute autonomic failure. I'm not talking of autonomic neuropathy or autonomic failure. It's an acute autonomic failure is possible with hypoglycemia, which we don't recognize as much in clinical. Hypoglycemia can throw all the interleukins and damage the endothelium. And now we know that more and more data are emerging that whenever there is more hypoglycemia, that particular cohort, if you follow, versus one without much hypoglycemia, you will find more cardiac events. And there are cardiac events associated with a bad hypoglycemic episode soon after that in near future. So all this is being reported now. We have to be acutely aware of this. And I think we have to learn how to avoid. Again, standard versus, you see, so whenever you do intensive treatment, like it was tried in ACCORD, Advanced, and VADT, the trial studies we keep discussing, and there was attended by a lot of hypoglycemia. Whether the increased mortality in ACCORD study, on the basis of which the study was terminated prematurely, was associated only in the hypoglycemia group is not shown. But if you look at differently, those who had hypoglycemia itself, they did have increased mortality. So I think in a sense, it can aggravate cardiovascular disease. This is very important to know. So what do we learn from this? We learn from this that without, at the end of this slide, there are two important lines. You see, without pre-existing cardiovascular disease, intensive control is beneficial. But with pre-existing cardiovascular disease, intensive control can be detrimental. By that I mean highly intensive and highly ambitious, where you are trying to target a A1C below 6, in a group of patients who already have 10 or 15 years of diabetes with cardiovascular complications. But by this we'll learn that early, as you heard Dr. Kunti just a while ago, that early treatment, it is possible to intensify. And as a matter of fact, that is the situation where treating diabetes is extremely easy. You can reach your target so easily in first 5 years of diabetes, type 2 diabetes. I primarily discuss type 2 diabetes today. But you see, when you try to do that initially, results are excellent. Results are excellent. Newly discovered diabetic, they have beautiful response to whatever drugs you exhibit, couple of oral drugs, and they are absolutely all right. So that is the area for us to concentrate on if we want to avoid complications. See, so this is the essence of some of these studies that I think you should, of course, change your targets or change your goalposts wisely. That of course, sometimes misused by patients saying that A1C of 8.5 is okay for me. Doctor, haven't you read in Times of India? But you should know that the best thing don't appear in the newspapers. They appear only in scientific journals. So next slide. Sorry. Okay. The genesis of hypoglycemia is very simple. All of you know, this is a glucose profile showing normal in green, and then in red and yellow, you see the diabetic. And then the basal is high, the prandials are high. Both are high. And this is genesis of hypoglycemia. We do differentiate when we're treating people with insulin, basal and prandial hyperglycemia. And we have tools to primarily address one of the two. So we do that. So basal primarily, of course, controls the hepatic glucose production, and prandial, of course, controls the postprandial blood glucose or surge of glucose there. And technically, by many of the what was earlier called biostatter studies, it was shown that half of the insulin is used really for the hepatic function. In fact, in the first pass through the liver, almost 50% of insulin is absorbed by the hepatic cells, and it obviously exerts its function, its influence there with whatever actions you know on the insulin's action on the liver. So be sure that basal dose is close to 40 or 50%. And I found this as a big error in our prescriptions in our country. And once we examined our prescription about 4 to 5 years ago, we realized that our basal, even in the basal bolus therapy, had made only about 20, 25% or 30%. So it needs to be at least 40%. This is what most of the investigators say now. And the hepatic insulin extraction, of course, and I hope one day there is hepatoselective insulin, which I'm very much hopeful will occur. And then I think you will have lot better control of diabetes. So fixing fasting first, sometimes the slogan is there, but remember that when you give good basal therapy also, and we are underusing basal therapy very much. See, Dr. Kunti also referred to that, but in our country, it's grossly underused. You see, after metformin, even, somebody is losing weight, actually you should think of basal insulin right away, instead of exhibiting multiple oral drugs and waiting. So unintentional weight loss is an indication for insulin therapy. Please remember, it is absolutely incontrovertible indication for insulin therapy. But we don't do that. But remember that basal itself, when you lower the basal, the prandial also comes down. So there is an overlap between the two. When you control prandial better, there is some interprandial effect, which really is basal period. So these both overlap with each other, and therefore doing efficiently one also can have good impact, and doing efficiently both is required in difficult patients. So insulin distribution, sometimes we don't understand how to distribute our insulin. For example, if they close to 100 units, which doesn't happen, but hypothetically, remember that half of the dose will be for basal between the meals, and at night 32% is 40-50% of insulin, and meal time you see is prandial insulin. And you see, before breakfast requirement is more than any other meal. This is not recognized in India. With great difficulty, we have been teaching this concept that your dose in the morning has to be higher. Even the meal can be small, but this is the basic body's glucose rhythm, which has to do with hormones and with cyclicity, which we have in our body built up, the rhythms that you have built up in our body. And next requirement is probably before dinner dose. Usually the lunch dose should be less, although here it is appearing similar. But individually, it can work out very differently. That's why we always, the watchword is individualization. But you have to go by something when you are titrating treatment. And these are the clues for you to go by. And of course, this is what, now you see, basal bolus therapy, again, you see there will be large dose of regular insulin and less of, if you use only NPHN, human regular, which can still be done very economically in our country in patients who cannot afford. And then very large amount of basal insulin at night. So this is another very important but say simple point that please feel. I've seen diabetologists, having seen a patient keep changing clinics, so they land in my clinic. I see that there are bad lipodystrophy which was not even detected. I said, doctor, examine your injection sites, and they're bad lipodystrophy, and patient is injecting there. And that gives a very variable response. There is as such a built-in variability in insulin response, and this intensifies that variability, and you do not get good control, you get hyper. Another principle I want to bring out for you, that one shot of the or two shots of premix and versus basal bolus. Now I think we all have graduated into basal bolus. I think any difficult patient type 2, you see, you should think of basal bolus. The frequency of injection now, once the patient accepts insulin therapy, really doesn't bother them. It's a little more nuisance than pain. It is only a small nuisance, but in India we put up with a lot of nuisances. This is not a big nuisance at all. I tell the patient, not big nuisance. You put up with every day. So I think this shows that last one we see glargine with glucosine 3 times a day with, of course, oral agents. I'll discuss that a little later. Using oral agents in a type 2 diabetic whom we are giving insulin therapy, however refined insulin therapy you want to give, sensitizing oral agent is required. So this is what they did here in the green. You see here horizontal, and this obviously worked better, as you can see. So remember that multiple doses you should not have any reservations in using multiple doses and convincing your patient. You see, they gain so much better control, and they are so much more comfortable without hyper. They'll bless you for it, but you must have a capacity to convince, and for that you have to be first convince yourself. Then you see, you see, you stepwise increase basal bolus, and ultimately, of course, when you go to the full basal bolus, where there is 3 doses of regular or short-acting insulin. And remember that works the best, as you see here. So when you give insulin therapy, another thing is don't try to minimize doses. That compromise is a bad compromise. You will not be able to achieve good control. See? Then what kind of insulin you use also is important. So the insulin we use, you see, can be, you see, human regular versus, an analog has been tried here, as you can see. And human and analogs, of course, work very fast. And now there are faster analog, and human regular insulin comes in. The peak action is at about 1.5 to 2 hours, and it carries on for 4, 5, 6 hours. So remember that there is the interprandial hypoglycemia. Human insulin is more likely to do that. Human regular insulin. That is the problem. The very bad prandial hyperglycemia, you'll have to cover with the analog, a quick acting analog. You see, there is a lot of interprandial hyperglycemia. I think sometimes human regular will cover better than analog. In some of my type 1, I tried to change to analog because earlier they were on human regular, and some of them I'm treating for 30, 40 years before analogs came, and after analogs came. I have follow-up of people, type 1 of 40 years standing, which many of us not have had the privilege to treat, And you see, I tried to change, and I find that control deteriorated very badly because the interprandial effect of the regular insulin was working, And although I gave glargine or whatever analog, basal analogs were possible at that time because all these stories stretch over 30, 40 years. So anyway, NPH of course has a problem. It is not a real good basal. Unfortunately, you see the cost of all others is expensive, but remember, glargine is almost about to come under price control in our country. And I think, although it is not absolutely ace if you see very minutely basal insulin, but it is good for all practical purposes. And I think that is what you should use if you have cost consideration. Should be uppermost in our mind, at least in this country, when we realize that the American and European guidelines are worried about the cost. And then obviously we have to worry about the cost all the time. So anyway, so you use better insulin, obviously better basal analog, and glargine was the first basal analog. And I think it is cost-wise, it is slowly coming down. Glargine cost was down. And of course, it is peak less insulin, steady, but it has a very minor peak after 6 to 8 hours. That's why all of us started giving at night, so that morning that peak can cover the breakfast a little bit. So there is a minor peak there. It is not truly a total peak less steady concentration, the insulin that gives you steady concentration for 24 hours. So I think we pass on. And remember that variability of absorption of insulin is tremendous in the body. If you inject at the same site lipodystrophy, the variability is terrible. See, you can never control that patient properly. But without that obstacle or problem also, you can see the one injection, they produce 3 different profiles or different day. Same individual. And you see intra-individual variation in the same day and sometimes day to day. So these all variations have been a bugbear of insulin therapy. Not much talked about initially, although it was all known until the better insulins came, they started talking about these old ones, you see, and they brought out the data that ours is better. So this happens with all the time. You see, coefficient of variation of insulin response, you see regular insulin, NPH, biphasic, and remember, the basal insulins, the long-acting ones, has even more coefficient of variation, 30–40%, except the newer ones there are probably getting better and better. But remember, the regular insulin overall variation is less. That's why sometimes 3 doses of, you see, regular insulin is what my professor will tell me about 40 years ago or 50 years ago when I was working together with him, you see, and as another as assistant professor. So you see, so remember that, you see, there is less variability with regular and short-acting insulins than the basal. Now, basal, this is not a lecture, pharma lecture to tell you more about this beautiful insulin. They are certainly good. Cost is the only constant. Otherwise, you should use the best. Largely in 300, you see. And of course, you see the IDAG aspart, I'm sorry, IDAG insulin, and the degludec insulin of Novo. Those are obviously the best basal analogs we have. If you can afford, they are very good, very steady concentration, going slightly over 24 hours. So some difference in timing is possible. The 1 or 2 hours window is there. You see, you don't have to inject exactly at the same time. To my mind, if you see these two, the comparison does not really show very massive differences. Slight difference in nocturnal hypoglycemia, slight difference sometimes during the induction phase. As a clinician, I don't give it importance. I would equate them as equally good as a clinician. See, and looking at the data carefully, mind you see. So I think, similar, A1C reduction and all, you can see here comparison of these head-on. And I think there is a slight differences being pointed out, but I think they can be ignored by VS patients. Insulin pumps will give a much better stable response, you see, to insulin. The coefficient of variation with insulin pumps is only 1%. It narrows down this minute-to-minute injection, you see, makes all the difference, very steady, delivery of insulin. So the one diabetic, which I'm not discussing today, if you have problem, ultimate solution is insulin pump, which is the expensive solution. But next to that is a good basal bolus therapy. You cannot cut corners there. You'll never achieve good control in a type 1 diabetic by doing that. So how does pump work? You see, it is how it cuts down the coefficient of variation of less than 3%, some say even 1%. This is all algorithm purposely are given. After metformin failure, when we have this fire and even the SGLT2 inhibitor is not there, you see, we consider, but basal insulin quite often is not used in our country, which is there as an option. And of course, later on, we start using insulin with multiple drug failure. And then, of course, remember that some guidelines given by ADA and etc., they'd forgotten. In the end, they said insulin therapy. So some of us, some lectures pointed out, and many others probably they also saw. In the end, also, after insulin therapy, there has to be sensitization in a type 2 diabetic. And that is a very important thing in successful insulin therapy. So they added that in later guidelines, sensitizers. You see, which sensitizer will you use? So this is another key to successful insulin therapy. So you would like to use what is shown here as anti-hyperglycemic agents, because they are less likely to cause hypoglycemia instead of hypoglycemic agents like sulfonylurea, glinides, and insulin. And all the others, they sensitize. Some of them are super sensitizers. Others reduce the insulin dose, which in a way ultimately means less insulin requirement. And less insulin requirement divided into 3 or 4 doses, like I told you, basal bolus therapy, you see, will obviously avoid hypoglycemia. When you're using big bulk of insulin, and then obviously one day a little difference in food intake or a little extra exertion by the patient, you're going to get hypoglycemia. So therefore, you have to minimize doses. And minimizing doses, the key is sensitizing agents. So I don't remember out of thousands of my type 2 patients whether I treated anyone with insulin therapy without an oral agent there. So I think it is an essential requirement, sensitizing, because insulin resistance is quite marked in type 2 diabetes. You see, remember that when you get a lot of hypo, we'll have to also revise your A1C targets. And this is from one of our paper we published on in the RxEvents journal. You see, and it shows the targets have to be different in different people. And of course, I don't see 8.5 there, but 7.5, 8 I'll accept. But 8.5 is Times of India or Indian Express, you see. And it might come sometimes from abroad, from some investigator, but it is out of context. You taken out of context by our patients. And remember, this is very interesting here. The last one, pregnancy. This is something new in this paper. You see, I must tell you. I don't know whether any other author has pointed out this. At least I have not seen. If you can find anybody antedating this paper, let me know. Because these glycemic targets in gestational diabetes versus pre-gestational type 2 diabetes and type 1 diabetes has to be different. Quite different. If you're treated enough, which some of us have, this comes to you automatically. You see, gestational diabetes is easily controlled with insulin. You see, and you can achieve the target very easily. Pre-gestational type 2 will require something more. And type 1, even less than 7 is also with insulin pump. I delivered at least a dozen type 1, and I know how difficult it is. Some of you have done that. You will recall those cases, you see, and getting them 7, 6.5 are done with insulin pump. But with basal bolus, 7, 7.5 is quite okay. I don't think you'll get beyond that. This is very important to see this because this is something you will not, it is not being talked about anywhere else at the present time. So if you have problem in adjusting your insulin to get an insight, yes, ambulatory glucose profile is a good idea. You see, use it at least sparingly because it's all expensive. Type 1, of course, we have to use very often. Those on pumps may have to use very often. But type 2, in order to gain insight. But remember, when you do this, ask patient to maintain a food. Otherwise, it makes no sense. All the funny statistical parameter you get so enamored, fantastic parameter. Time in range, of course, is a good parameter now. And we think that less than 70% should be time, more than 70% should be time in range, and less than 4% should be low range. You see, those are the criteria that AD has recommended now with the help of this continuous glucose monitoring. So that's a new criterion and an important one. But remember that your changes will be made based upon activity and food diet. If that is not maintained, it is absurd to go on putting pump and try to read it, and do anything worthwhile. Drug interactions is important. We don't talk much about drug interaction. In fact, in our country, except some very advanced hospital, there is still no warning for drug interaction. There are 10 drugs being described. The pharmacist is supposed to warn doctor, there are 3 drugs interacting very badly with each other. It is not being done. I'm very sorry that we don't learn the real proper clinical aspect because the hospitals are being run by the business management people. So it's very unfortunate. But this is what has happened, and it is happening world over. So I think it is a problem. You see, and of course, you see drug interaction. And mainly, please remember, you see, the alcohol, please remember very well. Remember quinine there, you see, very, very notorious while treating malaria. And most important cause of hypoglycemia in our concurrent illness, intercurrent illness is gastroenteritis. Gastroenteritis, extremely common because bad hygiene, which we are trying to improve with great difficulty. You see, extremely common. It's the commonest cause of hypoglycemia. You must tell the patient what to do when you have diarrhea or vomiting. Their sick day routine, you have to teach to everyone. You see, minimizing hypoglycemia, therefore, you individualize targets, I told you. You see, use either SMBG or little more intensively, at least in the adjustment phase, and CGMS once in a while. You see, good patient education to learn the meal, medication, exercise, interaction, this interaction of these 3. You see, wider use of anti-hyperglycemic drug to sensitize patients to insulin, and wider use of acting anti-insulin analogs if it is affordable, mind you. Otherwise, you have to still use human regular and insulin pumps if possible, They're getting better and better, getting semi-automated for the initial supply, and hope one day will be automated for the boluses, but expensive deal. And development of insulin, I still looking for insulins which will give me less variation of response. But my hope may be belied for the reason that it may be inherent in the basic our biology, and therefore the insulin levels will not be very constant day to day, even intra-individual, you see, in a particular patient. So this is the thing I've seen in automated pump data, that there also was coefficient of variation. So I was quite disappointed that one day we'll get over it. We worry about weight change, weight gain. So this is one study we published showing that weight gain obviously is with insulin more, and insulin is sulfonylurea, which we use in our country to sensitize patients. Sulfonylurea is not mentioned as good sensitizers now, but I must tell you that 40 or 50 years back, there are hundreds of articles using sulfonylurea as sensitizer for insulin. They are superb sensitizers, far more potent than any other sensitizer. But usually, so they can cause bad hypoglycemia. So when I use that, I use something like plain glycoside, 20 to 40 milligram 3 times a day. Beautiful sensitization, no aggravation of hypoglycemia. This is the art of sensitizing agent, which one to use and how to use. But otherwise, safely use, this is metformin and many others for that. Another interesting thing we found, we say that insulin therapy causes weight gain, but we found that weight gain has occurred mainly, this is close to 500 people, mainly in people who lost weight before therapy. So weight gain is a function of prior weight loss. It is not really an attribute of a good, well-planned insulin therapy. Unless it's a bogus insulin therapy with 80 units morning, 80 units evening, then you'll gain weight because there is hypo. But otherwise, frankly, there should not be much weight gain in a good insulin therapy. Insulin pump therapy has not caused much weight gain. In fact, the youngsters know how to control their weight when they are on the pump much better than they could ever do with the B1 basal bolus therapy. A few special situations, and I'll finish in time of, you see, nocturnal hypoglycemia is bad. Watch for it. Watch for it. You see, night, for example, human regular, and then you give your glargine or whatever basal, and then you get a combination hypo. So then you shift the glargine even to morning. We have started shifting. And remember, sometimes you'll have to use an analog so that you don't get a nocturnal hypo. You see, and of course, you see, the nocturnal symptomatic and all that. I think we leave that out. Hypoglycemia during sleep, there is a problem. The counter-regulatory responses are impaired in the horizontal position and in sleep. They don't kick in very fast. So recovery from hypoglycemia can be very difficult. Patient can really go into sink into very bad hypoglycemia. So you have to be very careful about what therapy you are giving in the evening. You have to be very, very careful about that. And I wouldn't say 3 a.m. blood sugar, but very smart is between 2 and 4, because very large number of people wake up once at night, and that time is between 2 to 4. So I say between 2 to 4, anytime you wake up, once in a while, once a week or so, please do a blood glucose, especially in intensified therapies. And in type 1, you have to do that, as was done in DCCT study, as you know very well. You see, so glucose shows that there is nocturnal hypoglycemia. Fasting blood glucose very good on one day and very bad. One day it is 90 and the other day it is 250, and it goes on swinging like that. It is indicator that at night patient is undergoing nocturnal hypoglycemia. And these are the surge you have in the morning is probably post-hypoglycemic hyperglycemia. So this is interesting. So I think this is another important concept I want to tell you, that with age, the hypoglycemia symptoms get blunted. The range between the symptomatic hypoglycemia, the sympathoadrenal discharge, which is at 68 milligram to be precise, you see, and the neuroglycopenia, which is at 40 or 35, 40, that gap becomes very narrow in old people. It is only 10 milligram gap. So they go straight into neuroglycopenia, which is dangerous because there is no warning. And sometimes they're living alone, it is very dangerous. And as you saw, hypoglycemia increases with age, as shown by, I think, Dr. Kunti's one slide, hypoglycemia increases with age. So this is very important for you to be careful in elderly people. And of course, hypoglycemia unawareness is a problem. Very intensively treated people can become unaware. Long-standing diabetics, type 1 especially, become hypoglycemia unaware. So you have to be very careful. Somebody keep talking about beta blocker and autonomic nervous system. That is not that important, let me tell you. So if that happens, you have to be very careful in planning your therapy, insulin therapy. And of course, sometimes we have to really relax the control for about 2 to 3 weeks to restore some recognition of hypoglycemia. But remember, when you do that, what do you do next? To my mind, you will have to revise, if it keeps happening, revise the glycemic target upwards. This is an indication that you revise it upwards. Instead of 7, less than 7, let it be 7.5, even 8, because patient is going into bad hypoglycemia unawareness. So I think with that, I think how to restore it, I'm not going to details of any of the topic, you see, and I think we very quickly, so we'll go to the key points in the interest of time. So hypoglycemia is a frequent event with insulin therapy as compared to OAD or GLP-1 analog, or now I will say SGLT2 inhibitors, is risky immediately to the life really, and subsequently to brain or to cardiac events. And then to minimize it, you improve your insulin, stay close to physiology. You see, I'll take 1 minute. Yeah, sorry, I'm just finishing. I use adequate.
No, go ahead.
Sorry, I'm sorry, 1 or 2 minutes. Use adequate dose of basal insulin. This I told you, very important. We don't use basal insulin properly. So then you can, because there is less intense hypo with basal. So while very, very intensive hypo with regular and fast-acting insulin. So use basal a little more, proper proportion. Use better insulins with less coefficient of variation. I'm hoping to some more improvement even today in that. And sensitize patient to insulin with hypoglycemic agents, oral hypoglycemic agents. This is very, very important, very important. The key to success is that. And how to use sulfonylurea, I gave you the key. You see, they don't use glimepiride, for God's sake. Don't use modified glycoside. It's a wrong thing to use. Use short-acting drugs. You see, less charge of hypo, the control of prandial glucose. You see, this goes against the industry, because the industry is trying to sell the modified forms, because they probably want money in it. So I'm sorry, but then we should know what we need. So we stick to that, you see, and please set realistic A1C goals. So I think, and then of course, special situation, hypoglycemia, be very careful. Elderly subject, be very careful. Hypoglycemia, unawareness, be very careful. Thank you very much for your patient hearing. I'm happy to take some questions if you permit for a minute or two. I'll take some questions.
No. So there's a lot of. Thank you very much, sir. That was very interesting. Trying to individualize goals, minimize hypoglycemia, and an experience of having used insulin through its evolution, rather than I would say for half a decade or so, makes a lot of interesting.
Half a century.
Half a century, yes. No, I don't think anybody has used that much. That's what I made a comment earlier. So
55 years of practice. 55 years of practice.
My age is what you're using insulin to.
Yep.
So very interesting to know that not to be carried away that the newer insulins would do two miracles. When they don't have money, they do good. But using the right amount of basal insulin in adequate format, adequate doses, titrating, patient education, insulin technique, hypoglycemic unawareness, probably, and the age at which and keeping the age of the patient into consideration. And also using a sensitizer. That's a very nice thing. Many people forget that they need to use a sensitizer with insulin, otherwise very nice. And hope your dream comes true, where we get smarter insulins. Heard the dream of what you want, or hepatic sensitive insulins, which would do. I think I also think like we have a future to look forward, the way insulin therapy has changed over the years. I would open the forum to questions. Thank you very much, sir. It was a pleasure listening to every aspect of what you told and the experience which you shared with us. Any questions from the audience, please? Anything from the chat box? So I have a question. One of the most important thing, many people miss this patient education and examining injection sites. You told me your story. Many of them would have gone, nobody would have lifted his shirt to see his abdomen or looked at the area at the thigh where they've injected or at the hand. I think that's a big question to say. How often do you think you see lipodystrophy and hypertrophy in practice, sir?
Now I think we primarily get lipohypertrophy.
Yeah.
Because the older insulin, the dirty insulins which I have used,
Yeah, yeah.
not used,
They're not dirty as a good insulins, but they were dirty. Yeah.
10% impurities. A
Okay.
lot of lipoatrophy was there. Now it is mainly lipohypertrophy. But that site, doesn't absorb insulin. And that site, it becomes a little bit insensitive. So patient loves to inject there because doesn't feel the prick. But frankly, you see, I don't know if you have I've taken sham injections to see whether they pain. Frankly, there
No,
is
I've taken
pain.
I've taken for 14 days, four
Yeah.
times a day.
Yeah,
Anytime
very
I
good.
take an insulin class, I say, you take the insulin shot, you take a sham injection, come to the class. Only
Yeah.
then I will teach you how to take insulin.
That's true, I think. So I've done it also for a very long time. But frankly, there is not much pain. It is just a nuisance. If you can afford to change the needle after about 3 uses, so then even your lancet also after about 4 or 5 uses. But
Yeah.
people don't change and that causes pain. But
Yes.
unfortunately that costs. But I think it's a different issue how to bring costs down
Yeah.
about this. I think the Make in India will bring down costs.
Yeah,
Definitely.
yeah, yes, sir.
Make India
People use it for once a day, two or three times, and then change the insulin and
Yeah.
then change the syringe.
Hardly any pain. Hardly. I've seen very small kids, 2, 3 year old I've treated long ago. They could no pediatric endocrinologist. So 30, 40 years back, I had to treat 2 year old also, 1 year old also.
Oh, no,
You see, and mother was injecting the child in sleep. Child will not get up. Child will not turn around. I've seen that. So this is a myth. This pain part is a myth.
Yeah, a pain part is a myth, and if the right technique and if they use the bevel right and use the right angle taking it out, I
works
don't think there is a pain. And those who have taken the shot, the sham shot, I'm not a diabetic, but I'm taking a sham shot for 14 days, treat a lot of type 1 diabetes kids. So if you've taken it for 5 or 6 days, taken 4 shots, you know that it's not going to be painful if you take the right technique. I understand you. I totally agree with you. Patient education, the key for insulin therapy. And as Dr. Kamlesh was talking about therapeutic inertia, though we have so many drugs, so much of outcome, so many things on the outcome, I think we still lag far behind. And I think a lot of time should be invested in how the patient takes, how you talk to him, how we individualize goals, and so on. Though there may be new therapies which are coming in.
But
One
really,
final comment.
about the inertia, I wanted to comment. You see, it is well written in the very good articles. But do you know that very simple nitty-gritty aspects of the inertia nobody has mentioned? For example, when you start insulin, in 3 days it reaches equilibrium.
Yes.
How many of us, at least I'm doing that. See, in 3 days I expect an email on the blood glucoses. And I
Sir,
order that on
sir,
email.
I will
do
come
that.
on that. I will come on that.
If you are doing that, is wonderful.
Sir, I'll
Because
come on
that
that.
inertia, I would like to ask those authors, the patient under your care, are you reviewing every 3 or 5 days?
Sir,
When you start some treatment,
sir,
you see.
we use technology to combat it.
Yeah.
I start insulin to a patient, they have a number where they're going to, it's not starting insulin therapy, it's titrating insulin therapy, which makes the whole story. Starting insulin therapy is first, yes, I agree. That's the bottom line. But if you don't titrate, initiate to goals, there's no point. It's like driving a Mercedes Benz car in a dark road without the lights and you don't know the destination. So you have the Benz and you don't know where to go. So for me, if you start insulin therapy, please monitor once in 3 days. Can you send me a value till you reach your goals? And after that, we try to teach you how to do it. This is the most important thing. I don't know how many would agree on that, but that's the bottom line. Thank you for initiating the talk.
Thank you.
I
Thank you,
love that,
Dr. Bailey.
statement. Initiate insulin, but please make sure you monitor, reach the goal, then you've done your job. Thank you, sir. It was a pleasure listening
Thank you
to
very
you.
much.
Thank you. Thank you, everybody. And if there's nothing else, thank you, sir. It was like listening to 50 years of insulin therapy, which is not even my age as of now, but I know you've used them for so many years, helped millions of patients in your practice, directly, indirectly, through treatment, through education, through publications, through your experience. And I learned a lot today from what you spoke. Thank you very much. I think, Shruti, if you're there, we can close. I think we don't have anything else. We can close the event.
Yes, sir.
Thank you, RX Events, for everything. Thank you, everybody. Bye.
Thank you so much, sir.
Thank you. Bye, everybody. Bye.
Bye. Good night.